We are good to go.
My dear esteemed colleagues and friends who have joined in thousand number yesterday for this great event, National Update on Clinical Diabetes, and me and the chief organizer in chief, Dr. Professor Alok Anungo and Jayant, welcome you to this very extraordinary meeting. And I must tell you, this is the 10th update, and 10th is the occult number which heralds not walking towards the future, not running towards the future. We must take all of us together, Salini, Mithun, Wagesh, all the people take together that will not walk, run, we take a leap towards the future on this great Dasak. Dear friends, we have a program for you for the whole day, which is centered around 5 sessions. We'll start up with the insulins and the GLP-1, a fabulous session, both insulin and the anti-obesity drug and other glycemic efficacy drug will be introduced and discussed. We have a session on the exercise, the lifestyle. We have somebody who is a champion in exercise who will be conducting the session. We have a session on the basal insulin, strong foundation, and that will be discussed. The third therapy today. And the fourth one is something very different, leveraging the technology for diabetes care. And the last one we have taken on the diabetes bone and muscle. And to discuss all this, we have the faculty of the faculty. For the bone and muscle, we have Sanjay Badada, Rakesh Shah, we have Kalpana Das, we have Nikhil Tandon. For the technology, we have Jyoti, we have Devashish Das, we have Manoj Chawla, Bansi Sabu. For the session on insulin, today we have Dr. Shalini Jaggi, we have Mithun Bhartiya, we have Dr. Wagi Shayar, we have Sambit Das, and we have Dhammalya Sanyal. And we have for the exercise, Dr. Bharat Panigai, Abhay Shahu, Archana Sardar from Aurangabad. We have Utkal Kishore Khadanga, Alok. And for the session on basal insulin, we have Dr. Schwein, Dr. Alok Anungo, Abhay Shaw, Jayashree Schwein, me and Jayant, and the discussion. And as you said in the very beginning, this format is something different, something unique. We have in the beginning a context setting for about 2 to 3 minutes. Then we have two talks. In between the talk, we have a discussion with the hero in the field who has achieved maximum. Like today's discussion is with Dr. Sanjay Badada in the last session. The session today on the addressing the weight reduction in diabetes will be and the discussion will be between Wagesh Iyer, will moderate the discussion between Salini and Mithun. So this is the format. Followed by that, there's a 40 minutes, I repeat again, 40 minutes of panel discussion. With these initial remarks, it's my great honor and pleasure to hand over the session to Alok.
Thank you, Professor Das. Welcome all the faculties, honorable faculties, and all delegates to the 10th NUCD, and which has been continuing since yesterday. And now the present session is a very interesting session. We have divided the session into two parts. The first is on insulin, and second part is on GLP-1. And we have also divided the panel discussion time of 40 minutes to 20 each. So this will be, once the insulin is discussed, there will be a panel discussion led by Bhagish Sayer, and then GLP-1 by Sambit and Devmalya. Then it will be moderated by me. So we'll go ahead. I invite Dr. Salini Jaggi to present her talk on insulin co-formulation, clinical attributes beyond efficacy. And at the beginning, I want to thank our dear partners like USB, the major sponsor of the event, and they have done everything for academic support, and we express our gratitude for whole of USB team. Then Sanofi is there, Novo Nordisk is there. They are doing excellent things. They are the pioneers in their field. Then we have Eris Pharmaceutical, Glenmark, Abbott, and Medley. And along with my hospital, Kids Hospital, and Dr. Kanungo's Diabetes Center, the City Center, are also sponsoring the event. So thank you very much. And Salini, please start. Salini is a consultant diabetologist and director, Life Care Diabetes Center, New Delhi. And she is a fellow of Royal College of Physicians and a fellow of the governing council member of DIPSI Endocrinology USA, Secretary RSSDI Delhi chapter, Secretary RSSDI, and serving as advisory board member, diabetes committee and lipid and CV health, and many such things. She is already known to the audience very much. So Salini, please start your talk.
Thank you so much, sir, for that warm introduction and happy Makar Sankranti to everyone. And I bring greetings from a very cold, foggy, chilly Delhi. And it's a pleasure to be part of NUCD with stalwarts like Dr. A.K. Das sir and Dr. Kanungo sir being here. So it's actually a pleasure to be presenting today. I'll just share my slides. Are my slides visible?
No.
No, just a moment. Are they visible now?
Yes, yes.
Okay. So, good morning, everyone. We are starting this great conference today, the second day, with a discussion on insulins. And this is what I am going to talk in the next few minutes is introduce the insulin co-formulation that we all have been using and its clinical attributes beyond efficacy. And this is my disclosure. Of course, this is a Novo Nordisk sponsored session, but what we are going to discuss is the science. So, when it comes to managing our patients with diabetes, I think there are a number of challenges that all of us identify. Poor glycemic control, of course, is the one challenge which actually propels us towards thinking for insulin because data clearly shows that almost 76.6% of adults with type 2 diabetes in India achieve that golden target of HbA1c less than 7%, out of which 83% have suboptimal postprandial control. So, a very important challenge why our patients are not achieving a good HbA1c is also the poor PPG control that is seen in Asian Indian populations. And I'll come to that in a little while. Now, in spite of all the studies showing that patients are not under control, the HbA1c is not on target, there's a very important challenge that all of us need to identify and take steps to prevent it is therapeutic inertia, which means that in spite of knowing that patient needs insulin, we do not start insulin on time. And studies show that 10% of adults with type 2 diabetes in India actually achieve an injectable treatment after spending 10 years of diabetes, and most chunk of it is uncontrolled diabetes. Now, non-adherence to therapy is again a very important challenge because multiple complex regimes, cost factors, so many other factors clearly show that almost more than 50% of Indians are non-adherent to their anti-diabetic therapy. And hypoglycemia is again a huge barrier to glycemic control because one episode of severe hypoglycemia actually leads to cessation or downregulation of treatment, and therefore patient is not able to achieve a good glycemic control. So whenever we talk of treating a patient with type 2 diabetes, these are five important key challenges we need to keep in our mind. Now, what do we expect from an insulin therapy? We need a holistic insulin therapy that is going to be efficacious, safe, and has to give good glycemic control, but at a cost of no hypoglycemia. So, you need an insulin therapy which gives lower hypoglycemia compared to the others. It offers mealtime flexibility, so it can be dosed according to the highest meal of the day. The regime of insulin that we prescribe to our patients has to be simple because complex regimes sometimes are too difficult for patients to understand and follow. And then there are a lot of prescription errors that happen when you put them on complex regimes. convenience of the device is also something very important, because the moment we say insulin, patients have the needle phobia, patients feel it is going to be very painful. So a good device which is painless is something which is more acceptable to the patients. Eventually, a good efficacious insulin regime, which is simple to follow, offering flexibility, reduced hypoglycemia, translates into better glycemic control and a better quality of life for our patients, and eventually turns out to be cost effective in terms of reduced complications in the future. So with these kind of characteristics, what we need to see is whether the co-formulation of IDEC-Aspart fits this entire bill of choosing the best insulin for our patients. Now, just to give a very brief introduction of the world's only co-formulation insulin, the IDEC-Aspart insulin that all of us have been using, we all know this is basically 30% the aspart hexamers and about 70% the ultra long acting degludec hexamers that are fitted together in solution, coexisting peacefully with each other, both in solution and in the subcutaneous tissue. So it's more like a marriage of convenience wherein both the insulins coexist peacefully and then they retain their individual properties. So the rapid acting continues working as a rapid acting without interference from the degludec or the ultra long acting. And the degludec provides a constant basal control without interference from the S part. So you have a marriage of convenience of a rapid acting insulin with an ultra long insulin in the same injection. So both of them peacefully coexisting and going on their own paths parallel to each other while still staying together. Now, how does it work? You can clearly see here the basal ultra long acting degludec provides a flat and stable control all day for the 24 hours, while the mealtime control, the postprandial control with the biggest meal of the day, is provided by insulin S part. So, when you dose it with the biggest meal of the day, you will take care of the post meal spike that happens with that meal, as well as the long term ultra long acting degludec is going to provide the basal component with a flat and stable glycemic control. So this is backed by a number of clinical trials, and you can see on your screens the phase 3A and the phase 3B trials, where it has been used with all the different patterns and different patients and has been compared and proved to be as good as and even superior to detimir insulin, to bias 30, to glargine U100, as well as the basal plus and the basal bolus regimes. Now, this is a huge amount of real world evidence that backs the efficacy and safety of IDEC-Aspart. And you can see coming from all over the world, including data from our own Indian stalwarts. Now, when it comes to the efficacy of this co-formulation, let me show you this beautiful study wherein about 296 insulin-naive patients, one arm was initiated on IDEC-Aspart one shot along with OADs, and the other arm was given the basal insulin glargine U100, which we use as a standard along with OADs, and these were followed up for 26 weeks. What you see on your screens is a similar fasting control with 70% basal component in the IDEC-Aspart versus the 100% basal in glargine U100. But you see a much superior HbA1c reduction of 1.4% versus the basal alone. And probably this is attributed to the better postprandial control that you see after the major meal, almost a 57 milligram reduction in the postprandial glucose levels. So IDEC-Aspart provides a superior long-term glycemic control compared to the glargine U100 with a similar degree of fasting reduction, even when the basal component is only 70% in the IDEC-Aspart. Now, this is the ARISE India results. Again, 185 adults with type 2 diabetes prescribed IDEC-Aspart as per the local practice. And you can see 43.8% patients were given once daily injection of Aspart with the biggest meal of the day. And 56.2% patients were given twice daily Aspart. So you can clearly see that the end of study, you see a mean reduction in HbA1c of 1.6%. And similarly, like I said, even a reduction in fasting plasma glucose by almost 52.2 milligrams. So clearly you see that the ARISE India data shows that in Indian patients, you see a significant fasting reduction along with an HbA1c reduction when you use a co-formulation of IDEC-Aspart. Now, if you look at the safety data, Again, like I said, hypoglycemia is a huge challenge. So the moment you talk of insulin, besides the fear of injections, hypoglycemia appears as a huge challenge. After a severe episode of hypoglycemia, studies have shown that almost 84.2% of patients experience a fear of future episodes. Even after a mild or moderate episode of hypoglycemia, 30% patients experience a fear of future episodes of hypoglycemia, and therefore 16.2% of patients actually start skipping their anti-diabetic medications. And again, due to the fear of future hypoglycemia, because one hypoglycemia scares them so much, 36.7% will report reducing their insulin doses, and even 11.7% actually start missing their insulin injections. So therefore, hypoglycemia is a huge challenge. Now, how does IDEGESPART fare when it comes to the hypoglycemia concern? Well, this is the ARISE global cohort clearly showing you that the number of hypoglycemic episodes, both non-severe as well as severe, come down drastically when you initiate a patient on IDEGESPART compared to patients who are not given IDEGESPART. So you can clearly see 4 weeks prior to initiation versus 4 weeks after initiation, you see a significant reduction in the number of severe as well as non-severe hypoglycemic episodes with IDEGESPART. So clearly the number of hypoglycemia comes down. This is the SMART study, again documenting what I said before initiation of IDEGESPART versus 2 week, the 3 months, 6 months, and the 12 months post IDEGESPART, you will see much less episodes of confirmed hypoglycemia and zero episodes of severe hypoglycemia with IDEGESPART. So we're seeing how it is meeting all the challenges. Now moving on to how simple is it to initiate and dose IDEGESPART. Well, if you have a patient failing on OADs and you initiate him on a basal insulin, what happens is, suppose his glucose levels are not under control, the postprandials are not on target, then you have to add an additional SPART injection with the biggest meal, and then maybe still you need to upstep by adding a second SPART and eventually a third SPART. So eventually a patient goes on to 4 shots, which means three boluses and one basal. So that is the intensification that we follow when you start a basal and then you go to basal plus and eventually result in a basal bolus with 4 shots. Compared to that, when you initiate a patient on 1 shot of IDEGESPART, and then you can very easily intensify by adding the second shot with the second biggest meal, and you eventually get in similar HbA1c reduction, and patient is able to achieve goal HbA1c target along with goal fasting and postprandial targets by simply starting on 1 shot and intensifying with the second shot. Now, this is data that I'm going to show you on a comparison between IDEGESPART versus the basal bolus therapy. So you are, as you can see here, this was about 500 plus patients with type 2 diabetes who were already uncontrolled on a basal insulin. So what was done? One arm was switched from basal to IDEGESPART along with OADs, 1 shot, and the other arm was continued on basal with OADs and 1 shot of SPART was introduced. So this is 2 shots of IDEGESPART plus 1 shot of IDEGESPART plus OADs in one arm, and glargine plus SPART, that means 2 shots, a basal plus regime along with OADs in the second arm. So beyond 26 weeks, if they were still not on target, what was done was intensification. That means a second shot of IDEGESPART was added to OADs in patients who were not on control, not on target, with 1 shot of IDEGESPART in the first arm. And in the second arm, where patient was already on a basal plus, he was further intensified by adding a second shot or even a third shot of SPART. So in the second treatment period, that is 26 weeks to up to end of treatment 38 weeks, we have intensified by putting 2 shots of IDEGESPART with OAD in one arm and basal bolus regime in the second arm. But surprisingly, what we see is IDEGESPART achieved similar improvements in fasting plasma glucose as well as HbA1c compared to the basal bolus. So there you are giving 4 injections. Here you are giving 2 pricks, but you are achieving similar fasting control and similar HbA1c control. And what you also see is a 9% significantly reduced dose of insulin being required in the IDEGESPART arm, and the fewer mean number of daily injections, obviously, because here the intensification was 2 injections of IDEGESPART. In the other arm, you are seeing 4 injections with basal bolus. So the number of injections is less. total dose of insulin required is less, but the degree of glycemic control achieved is same. So it is easy to switch to idegespart from other insulin regimes. So if your patient is already on a basal one shot or a premix one shot, you can transform and switch him to idegespart one shot, or maybe intensify to twice. Similarly, a patient who is not doing well on a basal or basal plus or a premix twice, two shots, he can be switched to idegespart two shots. And somebody on a basal bolus, based on the individualized parameters, you can switch him to two shots of idegespart. And of course, friends, it is very important that glucose monitoring is done when we are doing the switch, because you need to individualize therapy based on the careful consideration of the basal bolus therapies, because this is a very insulin regime, intensive insulin regime, and close glucose monitoring, like I said, is important. Now, how does all this translate to an improvement in the quality of life? You can clearly see here that the total dose of insulin required and the basal insulin dose requirement comes down, as you can see here. Besides that, in this study, you can clearly see that the diabetes therapy related quality of life improves, because the patient is able to achieve good glycemic control with lesser insulin doses, lesser number of pricks, and he's happier. So the quality of life and the complications are also much prevented. So the treatment preference, of course, 7 out of 10 patients, that means almost 75% patients, prefer idegespart to their previous treatment. So therefore, lesser insulin requirement, lesser dose requirement, and significant improvement in quality of life. This is a single standard study from Dr. Coville's center. Again, adults were questioned. They were switched to idegespart, and they were given a questionnaire of 26 questions to actually look at their quality of life improvement and treatment preference. And what this showed was 95% patients were happy, managed their day-to-day activities better after idegespart initiation. Almost 90% had improved quality of life because the number of pricks came down, and almost 86.7% patients found it comfortable to inject idegespart in different social situations. So all of this tells you that the quality of life is good and the pill burden comes down, because once you are able to achieve a good glycemic control, so patients who were on 3 OADs can be shifted to 1 or 2 OADs, and 50% of 2 OADs a day were shifted to 1 OAD. So maybe an idegespart injection with one meal and the OAD on the second meal. So the pill burden also comes down with improved quality of life and adherence to treatment. So dosing convenience and flexibility is a hallmark of this insulin. And the best part is you can give this insulin with the largest meal of the day. So if your patient is somebody who has has a heavy breakfast and is a light eater for lunch or dinner, you can give this shot in the morning. Somebody who eats a heavy dinner, so you can space it at night. So you can initiate with 10 units of idegespart with the major meal of the day, with the, where the carb content of the meal is heavy. And then suppose the glycemic control is still not achieved, so you are still seeing a post meal spike with some other meal, you can add, that means you can intensify by adding a second shot of idegespart with the second carb heavy meal of the day. So meal size and the postprandial response should dictate the ratio of the two doses. It's not necessary that you're giving exactly the same units in the morning and the same units with the second meal. So whichever meal is the heaviest, you give a bigger dose at that time. Whichever meal is lighter than the heaviest meal, so the second dose can be a little less units for that meal. So it is not necessary that you have to equally divide the dose between the two shots. So a practical recommendation of how you should actually titrate the doses is based on a very simple algorithm. You look at the fasting plasma glucose. If your patient is taking idegespart once with whichever major meal of the day, just look at the fasting plasma glucose. If it is on target, you maintain the same dose. If the fasting plasma glucose is still above that individualized target for the patient, you increase in steps of 2 every week till you achieve a fasting plasma glucose on target. If the patient is experiencing hypoglycemia or the fasting plasma glucose is less than the target, you reduce 2 units. However, if the patient is on 2 injections of idegespart with 2 major meals of the day, then if the patient is going to, you look at the pre-breakfast or the pre-lunch, that dose, if you're suppose giving the injection in the morning or you are giving it with lunch, then you have to look at the pre-dinner. blood glucose level. So the pre-dinner blood glucose level will dictate either the morning or the lunch dose if the patient is taking it at that time. The second dose, so if the patient is actually going to take the shot for dinner time, so the pre-dinner dose will depend on the pre-breakfast dose. So you look at the fasting glucose level to decide on the pre-dinner dose, and you look at the pre-dinner glucose level to decide on the breakfast or the lunch dose. I hope I've made that clear. If the patient is taking one shot of idegespart with whichever meal of the day, just look at the fasting and keep up titrating or down titrating. If the patient is taking a dose at dinner, pre-dinner, so you look at the fasting glucose and accordingly up titrate. If the patient is taking a pre-breakfast shot or a pre-lunch shot as the second shot, then you look at the pre-dinner glucose level and then you up titrate or down titrate. Now, a lot of people feel that this is an expensive insulin because if you look at the cost of the cartridge or the cost of the pen, you find it expensive. But this is a study that actually, an Indian study that looked at the cost effectiveness in terms of exactly the yearly total cost of medication and healthcare resources based on the Indian cohort. What this showed is if you look at the medication price, yes, seems to be a little more expensive than the other medications put together. But if you look at the overall aggregate of the healthcare resources utilized, the outpatient visits, the emergency room visits, the inpatient hospitalizations, and the work days missed. If the patient is not on glucose control or if he lands up with an acute or chronic complication and needs all that treatment, what you discover is the yearly total cost is lower with idegespart because you achieve a better degree of glycemic control and therefore the risk of complications, hypoglycemias, hospital administrations, emergency visits all comes down. So it actually proves to be a cost effective in the long term. So friends, to wind up, idegespart is a choice when you have to initiate an insulin because all the challenges that I talked of are met with this insulin. It is an efficacious insulin. It is a cost effective insulin which provides you a good quality of glycemic control and offers the benefits of mealtime flexibility, lower hypoglycemia, a simple regime which can be initiated and then intensified, convenience of the device is very beautiful, and a better quality of life in the end. With that, I'll rest my case and I'll hand over to the organizers.
Thank you, Salini, for an excellent talk. Very clear for the audience. Everything was very much clarified and points there is no doubt at all. I request Dr. Vagis to invite Dr. Mithun and take over.
Thank you, sir.
Thank you.
Good morning. I think we had an excellent discussion on the insulin from Dr. Shalini Jaggi. I think now we are going to have one more interesting talk on the insulin by Dr. Mithun Bhartia.
Only thing to be informed that speakers should stick to time.
Yes, I think we'll try to finish as per time as possible. I think Dr. Mithun Bhartia has done his MRCGP and MRCP from a UK. He has done a CCT in diabetes and endocrinology from a UK. He has done a scholar at Mayo Clinic, USA. And he is also a task force member of RSSDI Technology and National Technology, represents the India at the Worldwide AGP Clinical Academy. I think that's fine. And a founder secretary of Association of Clinical Endocrinologists. And he is part of a group in Amsterdam and also won a Newman's Prize in 2013 for his work on diabetes, testosterone, and erectile dysfunction. Dr. Mithun Bhartia, for your talk, please.
Thank you, Dr. Iyer, for the kind introduction. Thank you, Dr. Kanugo sir and Ekedas sir, for inviting me for this meeting. Just going to share the screen and I will try to make up the time as well so that we are in time. I'll just get my slide deck up. So is my slide visible and moving?
Yeah, it is visible.
Thank you.
Full screen. Good.
So I've been asked to talk about the dichotomy of insulin innovation and adoption. I think, it's a sponsored meeting, so there's financial disclosure for the honorarium that I would receive. Now, things have evolved. I'm sure everybody who's sitting here is no longer using an old Nokia phone that we all knew, and things have evolved for the benefit of human. And similarly, the insulin has evolved from venting and best the isolation of insulin to the modern first generation, then the second generation insulin like deglutec, like a basal insulin that has been there, which causes lower variability and has got a longer half-life, giving flexibility of meal regimens to our patients that is needed. Sorry, why is this like? Similarly, for premix insulin, it has evolved from ultra pure to biphasic human insulin to lispro to biphasic insulin aspart towards to the crown presently, which is co-formulation, which has beautifully been explained by dear friend Shalini already. And similarly has devices. Long gone are those glass pens with the insulin, and now we've got beautiful pens which are user friendly and pumps which has made life for our patients far more easier. And we continue to strive to get better and better to provide the better avenues for our patients, because friends, we cannot cure diabetes. Our job as a clinician is to provide them a quality of life that they truly deserve. Now, if you look at the flexibility and inconvenience, the deglutec gives you flexibility of 8 to 40 hours. Not that we'll ask the patient to take it like that, but then if it has that area of flexibility just in case sometimes due to various reasons the patient may not be able to take it. And ITEC has been very nicely explained how it has changed. Now, diabetes prevalence is increasing worldwide. I think it's an epidemic that is coming, and what we are looking at is only the tip of the epidemic, because a huge proportionate of patients could be pre-diabetic at to 15.3% with the ICMR India DEP study was this. And all the trials, all the studies are showing that a large proportion of our patients are not well controlled in diabetes. And this is very important, because if you're not going to control diabetes, the risk of complications goes high. It's very simple. What I tell my patients is that whenever there is a spike of sugar, it goes and slaps the various end organs. It will slap your eyes, it will slap your kidneys, it will slap your heart, it will slap your nerves. And there's a given point of time that you can take the slapping before that organ does not function. And so it's very important that we do not let that damage happen to our end organs. And hence, we need to bring the glycemia under control. But there's a fear when we talk about insulin. And in our current trend, if you see, a huge proportion of patients are not controlled because insulin therapy is delayed for these patients. Now, the landmark trial has very clearly said that if you have 3 oral medication, even if you try to put a 4th one, it's not going to help. But there is a huge barrier that are there, both from the physicians and the patient's perspective, which actually is a burden for starting insulin therapy. They all wish for the golden duck, that is, everything gets honky-ponky clear without insulin therapy. But my friend, a lot of that is not possible. And even that, a lot of patients, even though they are insulin, omit a few doses that they are to their convenience. As I've explained, there's a risk of micro and macrovascular complications, which tend to increase, be it retinopathy, be neuropathy, be cardiovascular disease, be nephropathy, with poor diabetes control. Now, what are these barriers? These barriers, I would say, either they are physician-related barriers and are patient-related barriers. You see, depend upon your workload. If you're aiming to see 40 patients in a daytime, unless you have the ground staff and supporting staff for it, I don't think you're doing a good job for the patient. I was in England for 12 years. We saw 3 patients in an hour or 4 patients in an hour. And a lot of subtleties could come out which could give care of the patient. So you need to have time yourself or your team to give to the patient. And you need to have trained paramedical staff to support the patients. Because hypoglycemia is, anyways, patient has a barrier to start themselves on insulin. And if you have a hypoglycemic attack, you can imagine that patient is not going near an insulin pen ever in their life. Weight gain is a huge issue for a lot of our patients. And they worry that, yes, because their diabetes will get controlled, they will put on more weight. Everybody wants to be size 0 with all the ads and the movies that are going on. But what they fail to realize is that they're not leading a quality of life. And that's what we need to have a discussion with, honest discussion with the patient about the quality of life that are there. Now, even though we may have a lot of guidelines, I'm not a person who loves guidelines, because guidelines, I personally think, are not for doctors. We look at a holistic approach for a patient. They may be for nurses who are doing specialist nurses, but we know what we are doing and we need to provide that care to our patients. And because targets get changed, newer therapies keep coming, and we need to keep the patients in the loop as what needs to be done. And we need to be honest to our patients. In fact, suppose your patient is coming to a clinic and you're going to talk about, you say, I'm going to give insulin. The patient's mind is completely blank. He's not thinking of anything else after that. His world has stopped when you utter the word insulin. And I'm sure all of us, including seniors, have more stories to say how the patients react when we, take out the word insulin. It's just, and there are a lot of anecdotes everybody has to see, their stories, and everybody has strategies how to fight these barriers, because the barrier of the patient could be knowledge barrier, socioeconomic barrier, which not really nowadays, because the cost of insulin has come down. Sometimes the cost of insulin is cheaper than the tablets, but psychological barrier is, I think, is the most important barrier that is there. Because diabetes, my friends, is not just a medical condition. It's a social, medical, familial conditions. What you believe about diabetes, what your barber was telling you when you were having a haircut, telling that, once somebody had insulin, he died. That's, it fit in your mind, and you need to take that out. You need to understand his fears of insulin, and perhaps, strategies you need to find out to reduce their anxiety and help them focus on the broader picture of getting diabetes control and improving their quality of life. Sorry. One of the important factors, strategies that we can do is that perhaps, if you inject the insulin, first dose of insulin in the clinic, and then talk to the patient. Then, all the fear about the pain, the needle, everything is gone. And you need to give more consulting time and find an environment in which the patient can ask more questions and get their sides seen. Because lipohypertrophy is a real important problem that is there. And patients, because of faulty techniques of insulin, I do not let any pharma company teach insulin to my patients. I've made that a rule in my clinic, and I suggest everybody does that. Either you do yourself or you train your staff to do it. Because that is the best way I found ahead, because the goals of everybody are different. Our goal is predominantly towards the patient and not towards the sale of the molecule. So lipohypertrophy should be examined every time, because this can be cosmetically distracting. This can reduce the insulin absorption and can also let patients to stop their insulin. So things have evolved. The newer insulins that have come down has got lesser weight gain, lesser hypoglycemia, and better quality of life. And we need to have workshops with our patients, and the insulin techniques should be checked at every visit that they come in the clinic. The most important thing out here that I should say is that बात कीजिए, बात करेंगे तो ही बात बनेगी. So start insulin conversation shortly after diagnosis, but you must have this open conversation with your patients. And together, we know that the future is bright. We know newer things are coming in the pipeline. You've got once weekly insulin coming. We've got oral insulin, glucose sensitive insulin, and beta cell replacement. Hopefully, I shall see that, in the term of my life, that my patient will have beta cell replacement very easily. And that would be the love of every endocrinologist and diabetologist of our country and of our world. With that, I thank you very much for your pleasant, giving me the time to say. And in summary, I would say poor diabetes control increases the risk of micro and macrovascular complications. Newer insulins are there, which are convenient, but we need to have conversations with our patients, understand their anxieties, and develop strategies to help them cope and actually take insulin to get the sugar under control. With that, I thank you again once very much.
Superb talk, as usual. And Vagesh will now, of course, Vagesh will give the final comment. And after that, Vagesh to kindly initiate the dialogue between both. But the time is limit is very short, but
yes, sir. We'll make best use of the time with the experts we have got. I think we had an excellent talk by Dr. Shalini Jackie and Dr. Mithun Bhartia about co-formulation, and also on the insulin, what is the practical difference we have from the innovation to implement it to the thing. I think very one great message which came out of it. I think we have to teach ourselves, or our trained staff has to teach. That's, I think, the best way to take forward the insulin teaching. I think I have next two cases how to practically implement this insulin in the clinical scenario, because we are all clinicians. After all, it comes how best we can use this in our clinical practice. So can I have the first case?
Stuti? Shruti, can you put the case, please?
Sorry, sir?
Yes, the
Yes,
case.
yeah, 1 minute.
Yeah, it has come. It has come.
It has come. Okay. Yeah. So I'm not seeing. Is it moving slides?
So we are not able to see your slides. Just
1 minute.
unshare it and then share it. Unshare it and then share it.
Okay, right. Just I will do that.
Yeah. Yes. Yeah, now it has come. Make it full screen and continue.
Yeah. So this is just an art and science, both not only art, it's a art and science of customizing insulin therapy. How to apply it in our clinical practice. I think this is a supported by the NUCD, but doesn't make any difference when it comes to the serving the patient with the facts and science. So the first case, this is about Mrs. Rekha, 56-year-old homemaker, moderately active, admitted fever, breathlessness, malaise, and reduced appetite. So diagnosis of a LRTI is there. Her blood glucose levels is uncontrolled. BP is normal. She's an obese lady. So oxygen concentration is 88% because she has got a LRTI. Her LFTs are normal. EGFR 53 by and large practically makes use of most drugs possible for in a diabetes kitty. Her TSH is normal. Creatinine is 1.2. I think more than creatinine, it's the EGFR which makes convenience for the treatment. She is on metformin 2 grams per day, that's 1 gram twice daily. Sitagliptin 100 milligrams OD. For hypertension, she is on telmisartan 40 milligrams and rosuvastatin 10 milligrams and levothyroxine 100 micrograms. She is a hypertensive, dyslipidemic, and hypothyroidism. The question comes, she's been admitted. How to manage her hyperglycemia in the hospital? What are the challenges we have got, Dr. Okay. What are the challenges we have in facing her? Dr. Mithun Bharti, yeah.
Yes. I think, sir, the interesting scenario out here is they've got a sick patient who's already admitted. Now, in a sick patient, metformin is an absolute no-no because if there is already hypoglycemia, there's a theoretical fear of lactic acidosis. I've not seen many cases, maybe 1 or 2 in my lifetime, but you cannot give metformin to a patient who's sick. And his EGFR is slightly on the lower end as well. And in SGLT2 is an absolute no-no in a sick patient who's admitted, who's dehydrated, who's sick in the hospital. Now, other medications, we know no medications is going to work fast enough. So we need insulin in this patient. I've been trained in England and I always do basal bolus. That's my default prescription setting. In fact, I have less than 1% patient on a mixture. So my default setting is always basal bolus for these patients. Easier for me to titrate, easier for me to understand. And what good thing about basal bolus, especially in an inpatient like this, is that you see nurses, when they give meals in our hospital, I've never come across any hospital in England or in India which will give meal and insulin the right way for the patient. So we need mealtime flexibility for our patient as well. Very often it is administered ad hoc with the meals, and sometimes we don't know how much the patient is eating. So a newer generation bolus insulin is very useful, which can be given up to 20 minutes after the meal. So in patients who are not eating and drinking, I prescribed and I said, once the patient khana kha liya, uske baad de de. So that gives me more predictability, and the next assessment after 3-4 days, at least I can find out and titrate and bring it pre-meal that is required. A basal insulin would be required on top of the bolus. So basal bolus, I would think, would be the way forward. Now, basal bolus, we can talk about first generation and second generation insulin that are there. If we talk about second generation, there's a theoretical or a slight risk of improvement of hypoglycemia over first generation insulin. It's like we are going today to buy a mobile phone. I'm not going to buy an iPhone 7. I'll buy an iPhone 13. I don't know if 15 is also comes. My phone is still old now. So you would like to give the best thing that is available in the market for the patient. And that would be the ideal scenario. A lot of doctors, a lot of hospitals still use sliding scales. I think sliding scales is a very obsolete, but a lot of general medicine people do use it. The real way to do it is a basal bolus regimen. sliding scales are done by people who don't know what they are doing, and then you are reacting to the sliding scale and trying to fay out just to crisis manage the patient, because a lot of these hospital patients do not eat and drink well. So I think good bolus insulin that you can be given just after meal is a way forward, especially if the renal function, now EGFR was 58, suppose this EGFR was less than 30, then I will not do a basal insulin at all. I will just do bolus insulin to find out what the insulin requirement and sensitivity of the patient is, that, and then absolutely titrate based on that.
Absolutely fine. Thrilled, Dr. Mithun Bharti. I think it's really a way forward. I think two important points to take forward is stop OADs. I think metformin, the SpO2, that's oxygen saturation, is 88. Any hypoxic condition can be a risk factor for a MALI. We know that metformin associated lactic acid is little over exaggerated, but always to be careful when we are handling a patient. It can be that same patient or a 1% of the patient we are seeing with the MALA. And regarding the modern insulins, especially prandial insulins, which can be given up to 20 minutes after the food intake. I think that's the greatest advantage for the hospitalized patient. We don't know how much they are going to eat when we have offered a food. I think this is one of the important thing in a hospitalized patient, and also practicable in elderly and young patients outside. That makes our hospitalized patient management much more easier and comfortable. I think all the questions which I wanted to ask Dr. Mithun Bharti has been upfront has asked. It's a basal bolus is a choice of the therapy, ultra long acting basal insulin once the renal functions are very well established, and also the bolus insulins are the one which will be based on patient's intake and also can be given once the patient takes the food. That is, I think, that. Thank you very much, Dr. Minut Bhate. I think you have covered each and every point to the precisely what we wanted. We'll move to the next case. This is again a 52-year-old, I think, entrepreneur with a sedentary lifestyle. She has got some features of peripheral neuropathy, uncontrolled sugar in the form of fatigue and lethargy. And she has a challenge of adhering to the advised diet. That's true with all patients, probably more with the people who are very, very sedentary and otherwise engaged in the work. She is quite busy with lifestyle, and it's affecting her day-to-day management. She is motivated to adhere to the doctor's advice. That's what happens whenever they come. And she is also has delaying insulin therapy, has got lots of complexity. Once we start on the insulin, yes, it will happen. My lifestyle will go for a toss. I won't be able to take meal on time, all those things. But all these things compounded by uncontrolled glucose of HbA1c 9.8% in a young female, 52 years. Fasting is 142. Post breakfast is 168. Post lunch is 148. Post dinner is a 284. I know that the dinners are quite huge in India compared to the West. The breakfast is a huge, but in India dinners are the huge and it's quite late. Otherwise, I think her creatinine and the EGFR are quite good. LDL is on the higher side, needs to be on the medication. BP is normal. She is obese. Hemoglobin is acceptable. Non-smoker, non-alcoholic, with more than a decade of diabetes. She is on sitagliptin 100 milligrams once daily. She had used GLP-1 receptor analog earlier, but she couldn't tolerate it. Metformin, she is taking 2 grams. She is on standard medications like empagliflozin 25 milligrams daily. There is strong family history of diabetes, but mother has suffered from CKD also. Now she is the one who is motivated to control, is a candidate for injectable therapy. Other injectable therapy has not suited her. Probably now the insulin is a treatment of a choice. I call upon Dr. Shalini Jaggi. I think if this patient comes to you, how do you handle? It's quite tough to handle sometimes these busy entrepreneurs. How do you going to handle this? Dr. Shalini Jaggi?
Absolutely, sir. This is one patient where clearly, she's crying out for an injectable therapy with 12 years of diabetes behind her, uncontrolled HbA1c is already crossed 9%. This is what I said, therapeutic inertia. Because,
Yes.
we just keep waiting for things to get better and we don't initiate insulin right at the time. Because, even if you're thinking of adding another OAD, then data has very clearly shown that up to 2 to 3 OADs, yes, you do achieve a good HbA1c reduction. So from monotherapy, when you're going to a dual therapy and then going to a triple therapy, A1C reduction is more. So 1% and then 0.8%. But when you add a third or a fourth or a fifth drug, the HbA1c reduction would be minimal, hardly 0.2 to 0.4%. And that is for this patient coming from 9.8 to a target of 7 that we want for her patient, because she's already getting neuropathy, she's getting tingling. So we need to bring her down to 7 as early as possible. And this is where insulin seems to be the best option for this patient. So I think it is time that we give up therapeutic inertia. We stop trading on the OADs, starting a sulfonylurea, or maybe adding an alpha glucosidase will not really make much of a difference. You need to bring the HbA1c down. You need to target both the fasting, and here the major meal, the dinner glucose level is so high. So maybe this is where you need to actually target the postprandial spikes as well as the fasting, and get her down to an HbA1c of 7 as early as possible, so that you can actually retard the progress of complications. She's already getting neuropathy. Look at her retina, look
Yes.
at her kidney profile, look at protein excretion, if the microalbumin creatinine ratio is going up. So I think this is just the right time for her to start insulin, so that you can stop the progress of complications that may be imminent if she continues on this
I
trajectory.
think, see, one thing, yeah. See, I think her fasting is high, even a post dinner is high. Does she
Yes.
require a 2 pricks? I think that's quite difficult for her.
Absolutely,
How to convince her
absolutely.
with only a single prick?
Absolutely. So this is where the co-formulation comes in so beautifully. Because like I said, you have a 30% SPART fraction, which will take care of the post-dinner spike, because dinner seems to be the biggest meal here. And then you have 70% basal component of degludec, which will address the fasting and the pre-meal glucose levels. So this is exactly the right patient, where with the OADs, you can just add one shot of IDEG-SPART with the largest meal. So here the major spike is at dinner. So just one shot of IDEG-SPART at night, along with the OADs that can be continued in this case. You can continue the gliptin, you can continue the SGLT, you can continue the metformin. Just add IDEG-SPART and up titrate the doses based on SMBG readings, and you can give her better control, because we know that postprandial control can easily be targeted along with fasting with one shot of IDEG-SPART.
Yeah. I think you have covered all aspects of the thing. Only the question comes is, if you would have started her on only on the basal, we would have ignored her post dinner spike.
Absolutely.
Yeah, with covering with one single prick. You have shown in
Yes.
your talk also how good it reduces the
Yes.
HbA1c. I think similarly, this patient does very well with a single prick of a IDEG-SPART given before dinner. Titrate, then
Titrate.
you can achieve a good control. That's what this patient comes back after 3 months with a titration started with a small dosage of a 10 units. That's what we want. When we start a therapy, we are not aiming at control at first injection. It is just to
Yes.
initiate. At the end
Yes.
of 3 months, with a titration with 18 units, she has come close to 7%. That's a great achievement. I think that's an absolute way of convincing this patient with single prick, achieving both fasting and a postprandial, and coming to a good glycemic
Absolutely, sir.
control. Yeah, I enjoyed discussion of both the case presentation, your even the discussions. I'm happy to hand over to the organizers.
Thank you, sir.
Thank you, sir.
Hello, Sambit. Now it's time to invite Professor Dr. Sambit Das, Professor of Endocrinology at the Swam Hospital, addressing now, as Alok said, we are changing gears. The next part is on the GLP-1 array. I request Sambit to give the talk, and I'll again request Dr. Sambit to talk on the addressing the weight of diabetes with an upstream approach. Addressing the weight of diabetes with an upstream approach. And
Kindly stick to your
I'll
times, please. We are late by 15-20 minutes. And Debmalya must be ready. And I welcome Dr. Kalyan Gangopadhyay to the discussion.
Yes, sir.
Sambit, please.
Yes, sir. So a very good afternoon, everyone. So let me share my slides first. Is my slide visible and I'm audible, sir?
No.
No, sir, your slides are not visible.
Alok will adjust the timing during question answer.
There is no time for question answer, only 15 minutes.
Yeah, so okay, let Sambit finish we have time up to 12:30. So by 12:30, we'll finish.
Yes. Because
Yes.
Kalyan will give a talk also, 5 minutes.
Yeah.
Can you see my slide?
No, sir. Just once stop share it and then share it.
Okay, I'm so sorry. Stop sharing. Now?
No, sir.
Shit. Can I just send you my slide or
Sure, sir.
it will
Sure,
be
sure.
like
Yeah.
Can we change the talk to Devmalya first?
yes, sir. Yes, sir. I think that would be better.
Devmalya, are you ready? Hello? Doctor,
Debmaljada, are you there? Professor
Yes,
Debmaljada?
sir. Yes, sir.
Yeah. So
present your
Sambit is
talk.
taking time.
Yeah.
Debmaljada, again, once again, hearty welcome. Since Sambit's paper taking time, Professor Alok, who is the presiding over the session, wants your topic to be presented first. Alok,
And
you
your
can
topic
introduce
is
some.
Beyond the Frontiers of Glucocentric Approach with Oral Semaglutide. Very important talk. Devmalya is a professor, Department of Endocrinology, KPC Medical College, Jadavpur, Kolkata, and conjoint professor, School of Medicine and Public Health, University of Newcastle, Australia, visiting senior consultant endocrinologist, NHRTIICS, GD Diabetes Institute, Amri, Kolkata, and details of achievement are plenty. We welcome you, Devmalya, for this session.
Thank you, sir. Thank you, Alok sir. Thank you, Ashok Das sir. Thank you for introduction and also, sir, for invitation as well. So I would be sharing my screen. Hope it's visible, sir,
Yes.
in full screen.
No.
Is it now visible in full screen?
Yes.
Okay. Thank you, sir. So today we will be talking about the not only the glucose centric, which we have been talking about with diabetes, but also beyond the glucose control, we will be talking about that. So oral semaglutide, we'll be focusing on oral semaglutide, especially with regards to the early multifactorial reduction in HbA1c. Then the GLP-1s, especially targeting multiple pathophysiology, as well as the benefits, which is beyond glycemic control. So we would start off with a case, newly diagnosed type 2 diabetes, 33-year-old lady, about weight about BMI about 29.5, obviously obese according to Indian standards and Asian standards, HbA1c 8.5 with high cholesterol and metformin 1000 milligram twice daily. History of diabetes in mother and also history who died at the age of 65. And again, we have the patient's concern of weight, hypoglycemia, and increasing HbA1c in this newly diagnosed patient with a high HbA1c as well as a high BMI. The patient is already on a metformin 1000 milligram twice daily. So if we see which, we need to, when we are looking into diabetes, we need to control blood pressure, lipids, and where required, antiplatelet agents. Lifestyle modification remains a very important option, very important therapeutic agent, with regards to at all stages of diabetes, even when we are talking about insulin. But very important, the long time back, that Steno-2 was a wonderful study which had a multifactorial approach of statin and glucose control and blood pressure control as well with the RAS blockers and also aspirin. And with that, there was about 50% reduction in mortality. The overall survival after 21 years in those who had this composite treatment was increased by about 8 years, and there was nearly 50% reduction in microvascular as well as macrovascular complications. And also CVD event, time to CVD event was decreased by was increased by 8 years. So that's, overall comprehensive benefit by comprehensive management. But very importantly, out of this, HbA1c, as we have known from this UKPDS study, with 1% reduction in HbA1c, there is 14% reduction in MI, both fatal and non-fatal, and 12% in stroke and 16% in heart failure. But very important, something which we always overlook is the peripheral arterial disease, which is decreased by about 40%. So that's a big role of glycemic control as well. So 1% HbA1c can reduce the microvascular endpoints by about 37% and 21% reduction in diabetes-related death and any endpoint related to diabetes. So poor glycemic control. Now we have not only data of the UKPDS, but even recent first-year glycemic control is significantly associated with long-term complications, including macrovascular complications. Now, not only glucose control is important, but weight is another aspect of diabetes management, which was not looked into because we didn't have good agents that time in the STENO2 trial. So even 5% weight loss can prevent diabetes, which has been shown in the DPP studies, can be helpful for NFLD, PCOS, and dyslipidemia. But if we have to have greater benefits, we need greater amount of weight loss. 10 to 15% can reverse NASH and have beneficial effect on obstructive sleep apnea. But for diabetes remission, we require 15% weight loss. And we have still the benefit, the higher the weight loss, higher the benefit on HbA1c, blood pressure, and triglycerides. So overall, weight also, is a very important aspect which has been highlighted from last year's ADA-ASD guidelines as well. So, legacy effect is something which we require. So immediately 1% reduction after diagnosis, as I was talking, the first year is very important because that reduces the risk of all-cause mortality and MI by about 20%. And over 5 years, significant reduction and significant benefit as well. But delaying that up to 10 years, not only that, even after 1 year also can lead to significantly lesser benefit and significantly increased risk of harm. So we have to get to target early on as quickly as possible. And as the UKPDS had shown, try to maintain it for as long as possible. And you have now data about 40 years of UKPDS follow-up showing significant benefit of glycemic control as well, which was there in the initial 10 years. So legacy effect on metabolic memory is very important. And we have the GLP-1s, which is an endogenous incretin hormone, which has multifaceted effect. It decreases, it actually modifies the insulin secretion in a glucose-dependent manner, decreases glucagon secretion, decreases hepatic glucose output, decreases gastric emptying, improves satiety, and also has significant cardiovascular benefit as well. Now, with regards to previously, we only had the GLP-1 because that being a protein, we couldn't apply it orally. Now, the oral semaglutide was the first oral GLP-1, which showed a significant benefit in terms of HbA1c reduction up to a tune of 1.5%, weight loss more than 5% in majority of the patients. But very importantly, what is very important that the early initiation of oral semaglutide right after the diagnosis of diabetes helped in achievement of control, compared to those who were initiated later. So the twin objective of weight loss as well as HbA1c reduction was achieved by early introduction of semaglutide compared to a later introduction. So almost 30 to 50% higher chances of getting those twin targets, as weight loss as well as HbA1c less than 6.5. And early on, we would like to go hard, hit hard, and try to bring the HbA1c below 6.5%. Now, we had recently presented this abstract in ESICON 2023, where we were looking into the real world data across India in the Pioneer Real India study, where we used SEMA. This is just the patient profile who were selected. And what was very encouraging was the fact 1 in 2 patients, that is about 50% of patients, were initiated within 1 year of diabetes diagnosis. But what is very important also and concerning is that about 1 in 2 participants had a cardiovascular medical history, and the primary driver was both HbA1c as well as weight as well. So very important, we need to initiate this early, as probably the practice is changing. Very important, we need to evaluate for cardiovascular disease, and this medication remains a very important agent for getting the triple objective: cardiorenal benefit, glycemic control, as well as weight reduction. So again, if we compare with DPP-4 inhibitor, there is significant HbA1c lowering, 0.8 versus 4.8 with sitagliptin. So that's quite obvious. That's similar, much more effective. The GLP-1, especially oral semaglutide, one of the most effective GLP-1s. Again, when we compare weight, again, we are all aware, HbA1c comparing to SGLT2, which was also similar, 0.8, 0.9% HbA1c reduction. With EMPA, it was 0.9, and again 1.4% HbA1c reduction with SEMA. So obviously, HbA1c reduction crosses 1%, nearly touches 1.5 in majority with semaglutide, which is not seen except probably with sulfonylurea and to some extent with metformin, not with the newer other agents like SGLT2 or DPP-4 inhibitors. And if the HbA1c is more than 9%, we can have more than 2% HbA1c reduction. Again, weight reduction is something which we do not expect with DPP-4 inhibitors, whereas we have about 3 to 5 kgs weight reduction with semaglutide, which was seen in this Pioneer 3 trial. Again, numerically more weight loss, 3 kgs versus 4.8 kgs with SEMA compared to empagliflozin. So though it didn't reach statistical significance, but there was numerically more weight loss, better weight loss. Generally, this is what is seen with GLP-1. And again, what happens with EMPA or all the SGLT2 is that there's some increase in appetite as well, which if we actually combine this can be a great combination in terms of weight loss as well as suppression of appetite. So, we can have a significant patients population who can achieve the target HbA1c in 60 to 70% with different combination, as monotherapy, as dual therapy, and also with insulin. And if we compare with liraglutide also, this is more effective in terms of weight as well as HbA1c reduction compared to EMPA, SITA we have already seen, and even with insulin. And that's something really great. So along with that, there is weight reduction through appetite suppression, and there is decrease in energy intake and food consumption as well. So energy intake, with ad libitum was significantly decreased with semaglutide as well. And there was decrease in food cravings, and there was controlled eating, especially with regards to portion size. But what is very important, that still the pleasure of meal was intact. So that's very important as well, because as I will be talking about, so otherwise there is some thought that whether these agents can be associated with some depression or any other suicidal tendencies, but that has been also addressed in most studies showing it's neutral. Again, there is a significant waist reduction, waist circumference reduction, which is associated with increased risk of atherosclerotic disease, cardiovascular disease. This is a very recent publication which was just published a week back in Nature Medicine, which showed that semaglutide was not associated with any suicidal ideation. This was a network meta-analysis, and again, in both subsets, whether it was used for obesity at a much higher dose or even as an anti-diabetic agent. So there was no high risk, there was no increased risk of suicidal ideation, which is very, very, assuring to all of us, reassuring to all of us. So in the clinical attributes of oral semaglutide, superior HbA1c reduction, weight loss, and better efficacy as well. In patients with CV risk factors, especially this 47-year-old male, 9% HbA1c with hypertension, dyslipidemia, already on triple agents, metformin, SGLT2, DPP-4 inhibitor, and the major concerns of HbA1c and comorbidity and our family history of CVD. So we have multifaceted cardiovascular benefit with regards to use of GLP-1, which we are all aware, from endothelial function to natriuresis and decrease in inflammation. And we had been reported, few of us, patients early on as well, including patients used early on, as well as with cardiovascular risk with these agents as well. So there was about, in the Pioneer Real, there was a non-significant 21% reduction in MACE. This was mainly a non-inferiority trial, not a superiority trial. So this was very, very reassuring. No cardiovascular risk and suggestion of numerical benefit. Again, what was important is that there was nearly 50% reduction in CV death and all-cause mortality as well. So that is really reassuring as well, though it was not a superiority trial. Again, blood pressure, there is about 5 millimeters of blood pressure reduction, which is associated, as we know, significant benefit of heart failure and stroke, apart from ischemic heart disease and death as well. There is a reduction in LDL and triglyceride, which, dyslipidemia associated with much higher risk of cardiovascular disease, especially in the background of diabetes and hypertension. And also there is reduction in CRP, which is a marker of tissue injury and inflammation compared, and even that, beats the empagliflozin in terms of reduction in inflammation as well. So if we choose, when it comes to the choice of anti-diabetic agents, especially when it's oral, which we are, now, we can use these agents much earlier, as we had shown in the abstract as well. So you have the benefit of glycemic control, weight loss, CV risk factor modification, pleiotropic benefits, and minimal hypoglycemia as well. So this is, in a nutshell, we have all the benefits, and we need to choose our patients and use them properly, and also apply the guidelines where it is appropriate and necessary.
Thank
Thank
you,
you for
Jabalya.
hearing.
Thank you for the nice talk. Sambit, can you present now?
Yes, sir.
Sambit's
Yes, sir.
talk
I
is
can.
addressing the weight of diabetes with an upstream approach. You have 12 minutes to go.
Yes, sir. Yes, sir. So, a very good afternoon, one and all, and I'm thankful to the team NUCD for this opportunity. And I'll be discussing on addressing the weight of diabetes with an upstream approach. Next slide, please.
Sambit, little
Yeah.
louder.
So,
Sambit, little louder.
okay. So now it's
Yes.
audible, sir.
Yeah, now audible.
Yeah. So this is the financial disclosure. Next slide, please. So the agenda of my discussion would be, I'll be discussing on type 2 diabetes burden, tackling the deadly duo with an upstream approach, oral semaglutide for management of type 2 diabetes. I think many part have been told by Dr. Devamalya. And the fourth is GLP-1 receptor agonist, some updated research or results and the recent guidelines. So next slide, please. So I think type 2 diabetes burden, we are well aware, and it is increasing in a mammoth proportion. So this is the people living with diabetes and pre-diabetes across the world, and this is the IDF atlas for India: diabetes with 101 million and pre-diabetes with 136 million. Next slide. And but the common triad of type 2 diabetes are very characteristic. One is uh, overweight and obesity, and it has been shown that 88% of people are overweight or have obesity at type 2 diabetes diagnosis. The second part is inadequate glycemic control, and it has been shown that 77% of patients with type 2 diabetes across India have an HbA1c of more than 7%. And then there is a cardiovascular burden. Like more than 70% of people with type 2 diabetes die of cardiovascular causes. Next slide, please. Type 2 diabetes has got 7 times increased all cause mortality risk if we have both the conditions like diabetes and obesity. Next slide. Coming to the next point, that is tackling the dual epidemic, and currently we call it as syndemic because diabetes and obesity both are epidemic, and combinedly they are called syndemic or diabesity. Diabesity is a terminology is used to describe the combined detrimental health effects of obesity and diabetes combined together. Next. And it has got bidirectional relationship. It's not like one thing is only influencing the other. It's in fact bidirectional. For example, obesity or adiposopathy can actually lead to sleep disorders, inability to be active, stigma and impaired mental health status, and adiposopathy can actually lead to insulin resistance and beta cell dysfunction. And finally, they may culminate into diabetes. Diabetes itself per se has got role in obesity, in that some of the medications which we use, like maybe pioglitazone or insulin or sulfonylurea, may tend to gain weight. Neuropathy may be associated with diabetes, so that the activity level goes down. Hypoglycemia stimulates the appetite, so the patient takes more food and gains more weight. And the stigma and impaired mental health. So both the things are bidirectional, and it's a vicious cycle altogether. Next. We also are aware that weight loss at any degree is actually beneficial, and the more the better. So for example, 0 to 5% weight loss can actually have beneficial effect on hypertension and hypertriglyceridemia. If 5 to 10% weight loss is there, we have prevention of type 2 diabetes, NFLD, PCOS, and dyslipidemia. If the weight loss is to the tune of 10 to 15%, we have improvement in CV disease, urinary stress incontinence, NASH, obstructive sleep apnea, GERD, and knee osteoarthritis. And if the weight loss is more than 15%, in fact, the results by the direct and other trials have shown even type 2 diabetes remission is also possible. CV mortality and heart failure with preserved ejection fraction have got beneficial effect if we lose more than 15% of the body weight. Next. And weight loss and diabetes control, if we see the look ahead trial, the more the weight loss, the better is the glycemic control. The HbA1c significantly goes down, and also the fasting plasma glucose significantly goes down. Next slide. The look ahead also tells that the outcomes associated with more than 10% weight loss is quite significant, because if you see the forest plot, then with the weight loss of more than 10%, the primary outcome, which comprises of CV death, non-fatal MI, non-fatal stroke, and admission to hospitalization, is reduced significantly, and also the secondary outcome were also significantly reduced. Next. And this is the trial which I was mentioning. That's the direct trial, where there was a community based weight loss program with low calorie diet, and they have found that people who have lost more than 15% of body weight have in fact 46% uh, patients in the intervention group could achieve a type 2 diabetes remission, and greater weight loss led to greater proportion of patients with remission. Next slide. So now the concept has changed, and the concept is like an upstream approach. So we have to target weight loss. Weight loss will disrupt the underlying pathophysiology. It will reverse or slow down the disease progression. With weight loss, we can have good glycemic control and improvement in cardiometabolic risk factor. Next slide. And finally, it can lead to prevention of micro and macrovascular complication. Next. And this is the upstream approach. So all this while with our guidelines, it was management of hyperglycemia, which is downstream. But now it has been found that the upstream approach is rather more important, because we have to address the obesity or adiposopathy so that we can reduce the risk factor for hyperglycemia, like and the comorbidities or hyperglycemia, like coronary artery disease, hypertension, NASH, osteoarthritis. Everything can be addressed if we are addressing the upstream pathway. Next. Next. Yeah, the next is about oral semaglutide for management of type 2 diabetes. Oral semaglutide, Dr. Sanya has already told, like it's a human GLP-1 analog with a longer half-life, and it is a very potent GLP-1 receptor agonist. When it is combined with SNAC, an adaptor enhancer, so it promotes semaglutide absorption across the gastric epithelium, and combinedly it can be pill. So the injectable semaglutide can actually be a pill formulation if it is combined with a snack. Next. Next. And semaglutide tablet offers the most efficacious oral treatment, because 80% of the people do not want an injectable preparation, so they're happy with an oral preparation. And it is the first and only oral GLP-1 receptor agonist available across the world, providing superior A1C reduction versus empagliflozin, as the trial has been shown. And 80% of the patients reported good or very good treatment satisfaction with oral semaglutide. Next. Change in HbA1c at the end of the treatment, that has also been shown across the different pioneer trial. It is around 1.5%. Next, the people who can achieve HbA1c of less than 7% is significantly higher with oral semaglutide of 7 and 14 milligram compared to other drugs. Next, the change in body weight, that has also been mentioned across the different trials or the pioneer spectrum of phase 3 clinical trial, that with the use of oral semaglutide at 14 milligram dose, we can actually achieve an weight loss of around 5 kg in these clinical trials. Next, sustained change in body weight over time. It is also pioneer clinical trials showed a consistent weight loss which is sustained. Next, and change from baseline in body weight by background medication, which is very important. Like whatever medication you use, if we are using over and above an oral semaglutide of 14 milligram, that is actually going to be beneficial, and there is a further weight reduction. Next, and proportion of patients achieving A1C target of more than 1% with weight loss of more than 5% is significantly higher with oral semaglutide in comparison to empagliflozin, liraglutide 1.8 milligram, sitagliptin, or with the placebo. Next, and there is not only weight reduction, glycemic control, but subtle markers of atherosclerosis like hsCRP, lipids, and blood pressure reduction has also been observed with oral semaglutide. Next, and there is a proven safety issues across the pioneer trial, because it's a large safety database, and almost 5700 people were exposed, and most common adverse event were only GI, and oral semaglutide was associated with lower rate of hypoglycemia, and no new unexpected safety findings with oral semaglutide was found. Well tolerated, similar to other GLP-1 receptor agonist. Next, so oral semaglutide doses administration, I think we all know that it has to be taken early morning in empty stomach with 120 ml of water, at least for 30 minutes. Do not take food or any other medication. And the schedule is, we start with low dose, go slow, 3 milligram per 1 month, then 7 milligram per next month, and then 14 milligram. But in clinical practice, we know how we can titrate it much faster compared to waiting for 1 month duration. Next. So the last part is GLP-1 receptor agonist and the recent outcome, which is this is the cardiovascular outcome in type 2 diabetes. It has been published as a abstract. Next, and it has shown that 5-year absolute risk ratio with CV outcomes were actually better with SGLT2 with GLP-1 receptor agonist for heart failure, for MACE, and for all-cause death. Next, that's a good data to tell that both combination of GLP-1 and SGLT2 are going to benefit us. Next, the dual therapy of GLP-1 SGLT2 demonstrated favorable effects in heart failure compared to other dual therapies, and GLP-1 SGLT2 dual therapy showed benefit in terms of reducing MACE. Next, similar outcome has been shown from the renal outcome studies also, where GLP and SGLT2 inhibitor next have actually shown that in it has got beneficial effect in end stage renal disease, and when the EGFR decline is more than 50%, but in chronic renal disease, probably an SGLT2 and DP4 inhibitor is going to help. Next. So that was the conclusion. Dual therapy of GLP-1 and SGLT2 provide greater risk reduction for end stage renal disease and EGFR decline. Next. Next. So just to highlight the ADA guidelines, that GLP-1 receptor agonist can be used in patients with risk factor for atherosclerotic cardiovascular disease, even with before metformin or irrespective of the metformin use. And when weight is a concern or hypoglycemia is a concern, again GLP-1 receptor agonist fares much higher than other agents. Next. So I think next. I think that's the summary slide. So diabetes is a very important complication, and an upstream approach lead to early intervention may be beneficial, and weight loss and good glycemic control has been a cornerstone of oral semaglutide use, and it should be used. Next. Thank you for the patient hearing.
Thank you, Sambit. for excellent talk, very clear. I welcome Dr. Kalyan Kumar Gangopadhyay to the panel discussion. He has to present some case and time allotted is 5 minutes. Then we'll all join, three of us, and Devmalya, Sambit and Kalyan will join for the panel. We have 15 minutes to go. Kalyan, please.
Okay, thank you, Dr. Kanungo. So this is a real case. So this is not a hypothetical. This is one of my real patients. So I've just got 6 slides to show really. So this is a 63-year-old lady with type 2 diabetes for the last 30 years, 30. Hypertensive. Most of the patients have got NAFLD or MAFLD nowadays. There was unclear history of TIA. Patient was obese, BMI of 34. Now, fasting sugar 253, HbA1c 9.2. There was no PP sugar, and LDL 133, BP of 148/82. Now, if this patient was just on tablets, then it's a very easy question. What will you need? Answer is insulin. What insulin you will plan on? Then we have to think basal plus or premix or co-formulation. So that becomes easy. But as what happens in real life, things are not that easy and not like that textbook like. So the patient was on glimepiride 4 milligrams, metformin 2 grams, canagliflozin 300, and premix 106 units. So this is 3 times a day premix. Now, mind you, this is how the patient came to me. I'm not a great fan of thrice a day premix. So this is how the patient came to me. Now, I keep telling myself, and I tell my juniors also, don't look at the HbA1c first. So for this patient, every patient, look at the LDL first. So LDL 130. Patient is on atorvastatin 20. 99% chance the patient is not taking it regularly. And indeed, she wasn't when I asked. Second, you look at the blood pressure. The blood pressure needs further optimization. Third, you look at the lifestyle. So diet, exercise, and smoking. Last, then you look at the HbA1c. Now, this patient was pleading with me, said that I'm taking 106 units and I take the insulin regularly. Still look at my HbA1c, what is happening. My weight is remaining the same. But in India, the weight issue is not major. Patients are overweight, but they're not that bothered about the weight. They're more bothered about why is the blood sugar not coming down. And that is why she came to me. So now what to do? So 106 units. So what will be the next step? The next step will be first to see the patient is injecting, to see whether the patient is injecting properly, to check the insulin injection site, to check the insulin storage. So I do that. So that's a list. So everything done, everything fine. Check the diet. Diet was, she was, erring on more of the fatty diet side. So that needs correction. But that correcting that won't get the HbA1c down to 7%. So I think I therefore thought about starting her on Ribelsus 3 milligram. Now you note, HbA1c is 9.2%. I did not change the dose of the premix insulin. If the HbA1c was say 7.2% and I start Ribelsus, then I will reduce by 20%. But because the HbA1c is already high, I did not change the dose of the dose of the premix insulin. I kept in the same. She pleaded with me that I'm not wanting 3 times, can we reduce it? That always the patients do complain. So 3 milligrams, then up to 7 milligrams, then up to 14 milligrams. Now, this is a little bit unclear. I'm sorry about that. This is as it is the photograph taken of the patient showing the blood chart. Now, see here, up to here was 7 milligrams.
That is not projected calendar.
Is it not coming up at all?
No, not projected.
Oh, can you see my slide?
No, we are not seeing your slide, Dada, but your presentation was very clear. That lady and what you did was very clear. You started from 3, went to 14. If you want to show the slide, you have to show, otherwise you can continue.
Yeah. Are you able to see this slide now?
No, the slides are not coming, calendar.
Oh, that's a bit odd. Wait a minute. I have to.
You have to stop sharing and then share.
Yeah. Okay. So I think.
Yeah, now it has come. You can go to the slide you were hinting at.
Okay, so I think so. This was the thing. So the patient, as I said, patient is on 2 grams metformin, glimepiride 4, Cana 300, premix 76 units, 106 units. Now again, so I've told all that. Now I've changed to Ribelsus 3 milligram. I've kept everything the same. So as I said, because the HbA1c is high, not change the dose of premix. Can you see that now? I hope
Yeah,
it's
now
visible
your
now.
handwritten chart is very clear.
Okay, so now you see, my apologies for the unclear slide because this is the photograph as it was taken. Up to here, I had given 7 milligrams of Ribelsus. From here, I had made it to 14 milligram. Now see, the blood sugar had actually began to come down. If you note, if I go back, the fasting sugar itself was 253. The PP sugar was touching 400. So here it has begun to come down, and after 14 milligram, it has come down further. So at this point, I was quite confident that now maybe I can think about changing it to twice a day. So I changed thrice a day premix to twice a day co-formulation. And as it typically as it happens, because the degludec moiety of the co-formulation, it takes a bit of time to kick in. So you can see initially the blood sugars actually began to go up after starting the co-formulation. But then at the end, if you look here, it had begun to come down again nicely. So what happened? So from this combination of cocktail of insulin and oral tablets, I changed to this. Ribelsus 14, glimepiride and metformin, it kept the same. Co-formulation 40 and 36. So 76 units down from 106 units. So her weight had come down not appreciably by about 6 kilograms. Blood pressure had come down, but actually I had added in another blood pressure tablet as well. So I would not say that it is only the GLP-1 which has got the blood pressure down. And very importantly, at least I have been able to reduce the HbA1c by 1.4%. So I've reduced the HbA1c by 1.4%, reduced the insulin by about 25-30%, and reduce the weight also by 6. So that is what was achieved by giving this Ribelsus. So the two slides which I'm going to show, the next slide, and then I'm going to finish. This is the Pioneer 8 study where type 2 diabetes uncontrolled on insulin were given SEMA 3, 7, 14. And so uncontrolled on insulin meaning 40% were on basal, about 40% on basal bolus, and about 17% on premix insulin. So when you kept on the insulin, you added semaglutide with 14, with every 3 milligram also, there was a drop in HbA1c, you can see 0.6. With 7 milligram, there was a drop in HbA1c of nearly 1. And with 14 milligram, there was a drop in HbA1c of 1.3. So these patients were chosen who were on insulin, but still not achieving target. So with the addition of semaglutide, you achieve 1.3 milligram, 3% drop in HbA1c, and also about 10 units drop in the insulin. So I think that's my case. So I rest it here and keep it here if any discussion needs to happen. So I hope I'm
Thank you,
finished on
Kalyan.
time.
Thank you, Kalyan, for nice case presentation. And we will continue with the panel discussion with me, Dr. Sambit Das, Dr. Kalyan Kumar Gangopadhyay, Dr. Devmalya Sanyal, and Professor Ashok Das are there. So my first question to Sambit: how does GLP-1 receptor agonist fit into the spectrum of cardiometabolic disease, and what are the mechanisms behind the myriad of benefits of GLP-1 receptor agonists in these disorders?
Sir, I think it's a huge question, and it almost covers my topic. So, but just to make it short answer, so definitely GLP-1 receptor agonist has got beneficial effect on all the system which we have discussed. Like it has got advantages in the cardiac outcomes. It has got advantages in the renal outcome. It has got effect on the NFLD. It has got effect on sleep apnea. So there are new data which are emerging. So in all spectrum, cardiometabolic spectrum, it's a very good drug either for initiation or with a combination with any sort of combination. And I have already shown a combination of SGLT2 and GLP-1 how it is going to benefit. And the mechanism of action we have discussed, like it is the glycemic control, it's the weight control, it's the BP control, it's the lipid control, it is the markers of inflammation which are coming down. So all can lead to reduction in the atherosclerosis and other things.
Thank you. Devmalya, in your
Yes, sir.
presentation, you have very nicely told, and the question by the audience is the cardiometabolic risk profile of patients with diabetes increases significantly when they are overweight or obese. How do GLP-1 receptor agonists fit into the treatment paradigm in these patients?
Yes, actually, sir, if we see from, as I was just mentioning briefly, for the last 2 years, all the guidelines, especially the ESD, ADA guidelines, have shifted from only a glucose or HbA1c centric to a weight as well as glucose management, because then we can have a benefit in terms of not only addressing the glucose significantly, weight significantly reduction, as we have seen with semaglutide. You have in majority of patients 5% weight loss, which has significant benefits, and also addressing the cardiovascular risk factors. There are early evidences also showing benefits, especially with oral. There are evidences already there with injectable, and we are awaiting the data of the oral semaglutide superiority trial as well. So put together, all is beneficial. And we also must remember that with agents like the older agents like sulfonylurea, even if we get our glucose down, if there is a significant increase in weight, the KGA1C paradox, then actually that glucose reduction is to some extent nullified by the weight gain as well. So we need to have address all the components, all the pillars of cardiovascular risk, including glucose, weight, blood pressure, and lipids, to have proper reduction in cardiorenal risk factors.
In some cases, in clinical practice, we have seen after using oral semaglutide, the weight reduction is not 5 kgs. It is sometimes 10 kgs, even 15 kgs. So the patient well-being improves, or the overall metabolic status improves. So that is what this molecule is really giving a positive thing. Dr. Kalyan, how can one explain the potential benefits in chronic kidney disease with GLP-1 receptor agonist?
Yes, I think I'll be honest here. So far, if you look in totality, the just give me a second. So far, if you look at in totality, the GLP-1 receptor agonist, the impact on renal outcomes. If you look at the meta-analysis, it shows that there is beneficial effect. But actually, the whole of the benefit is due to the albuminuria reduction. If you take out the albuminuria reduction, still there is benefit, but it is driven solely by rewind trial. All the others does not show any stoppage of the relentless decline of the EGFR. It's only the albuminuria benefit. But it's only the flow trial which might be a game changer, and I'm eagerly looking forward to it. A flow trial with injectable semaglutide, which was stopped because of benefit, CKD trial. So here might be the game changer here, that the GLP-1 might have an effect. So how it does, we really don't know. There are GLP-1 receptors in the juxtaglomerular apparatus. It might work through them. It might work to the receptor level. It might work via its anti-inflammatory effect, just like finrenone works. So multiple effects are there, not one clear effect like SGLT2 inhibitors. There is some effect on the NH3 receptor pathway, which increases the natriuresis. Then it works similar to the SGLT2 receptor agonist as well. So few postulations. Few postulations means we don't know clearly why, but so far the only advantage was albuminuria reduction, not stopping the EGFR decline. But with the flow trial, we will see a different picture. So let's
Thank you,
wait for
Kalyan,
that.
for this nice answer. Yesterday, there was an interesting interview of Professor Subrata Acharya of national repute by Professor Ashok Das on MASLD. Excellent, excellent uh, keepsake interview. Professor Das, Ashok Das, how do you see the impact of GLP-1 receptor agonist therapy in management of metabolic dysfunction associated with fatty liver disease or MASLD?
Sorry.
You are muted.
To make a long story short, Alok, these are the drugs of choice today. In fact, I am told 9 GLP-1 RA are undergoing clinical trial in the MASLD, and out of that, 4 trials are also biopsy-based. So, to be very brief, GLP-1 RA are one of the therapies accepted today or undergoing investigation today for the NFLD, and the results so far has been very rewarding, including the biopsy changes. But the entire thing will come into light when those papers are published.
Thank you. Dr. Devmalya, there are various drugs currently in practice for managing heart failure. How does GLP-1 receptor agonist therapy fit into the arsenal of medications for heart failure management?
Again, with regards to heart failure, I think that though we have seen that, if you look at the guidelines, probably the SGLT2 inhibitors are something which have a definite benefit with regards to heart failure and form one of the pillars of heart failure management. Whereas the main impact of the GLP-1 group of medications is on the atherosclerotic process. But as we see that, one of the major contributions from with regards to heart failure remains atherosclerotic cardiovascular disease as well, especially in diabetes, apart from a small segment of patient having cardiomyopathy as well. So we have to have the combination, especially with regards to the SGLT2 actually takes precedence over the GLP-1 when it comes to heart failure, which molecule which we select, that is as per the guidelines as well. Then with regards to if the patient is already having ischemic heart disease and atherosclerotic cardiovascular disease, obviously the GLP-1 also comes in. It has shown to be having a neutral effect. We do not have any dedicated trials, especially showing a significant benefit with regards to heart failure, but it's something which we also use along because of the cardiovascular benefit as well. But out here, probably just like as Kolanda was mentioning, in CKD, probably the SGLT takes precedence, but definitely the benefit, especially with regards to the associated benefits, because again, ischemic heart disease remains the most important contributor for heart failure. So we can derive, especially if we can start the patient early on these molecules, where the patient doesn't land up with ischemic heart disease and go to the stage of heart failure, then can be a significant benefit as well.
Thank you. We have two
Alok,
more questions.
I will agree with that answer. In the 4 drugs today for the heart failure is the SGLT2, spironolactone, ARNI, and beta blocker. And as the Melissa pointed out, the benefits are there, but it's little indirect than direct. Thank you.
We have 2 questions and 3 minutes to go. Alzheimer's disease is considered, Kalyan, Alzheimer's disease is considered one of the emerging areas where GLP-1 receptor agonist can produce a significant impact. What is the role of GLP-1 receptor agonist in this area? Kalyan, please.
Kolanda, you're muted.
Yeah. So I think, yes, so this is an interesting area, actually. So there have been animal experiments with GLP-1 receptor agonists showing their distribution in the brain. There are 2 trials, if I'm not mistaken, with semaglutide being undertaken. One is with Alzheimer's disease proper, and the other one with Alzheimer's disease and a multi-infarct state. The effect of the GLP-1 receptor agonist on the central nervous system, and this is where perhaps the GLP-1 wins over, the SGLT2 wins over the GLP-1 on a few counts, but this is where I think the GLP-1 receptor agonist wins over the SGLT2 inhibitors. It has got central nervous system effect. There are receptors in the brain which are stimulated by the GLP-1. So much so that there are 2 dedicated trials which are occurring one with Alzheimer's disease, pure Alzheimer's disease, other one with Alzheimer's disease and a multi-infarct state. And I'm sure the results will be quite positive. There are multiple trials with liraglutide with Parkinson's as well, as you well know. So mechanism not clear as to what it happens. I think the anti-inflammatory component again kicks in here, neuroglial component kicks in here, but I'm not sure about the exact mechanism, but there is benefit.
Thank you.
We
And the
discussed
last
yesterday,
question.
maybe just 1 minute. Yesterday regarding this cognitive dysfunction and diabetes calendar, and as you rightly said, neuroprotective effects of GLP-1 have been demonstrated, and possibly in the preclinical models by helping to dislodge the deposition of beta amyloid.
Yes, that was discussed yesterday. Sambit, can you share your clinical experience in managing type 2 diabetes with oral semaglutide in the context of organ-centric benefits?
Yes, sir. I think we have already shown the evidence-based practice where we have shown all sorts of evidence in organ protection with GLP-1 receptor agonist. Coming to my clinical practice, definitely it has played an important role. And in fact, compared to the clinical trials, which you also mentioned, that the weight reduction is still more, like it is around 7 to 10 kgs in some patients. The glycemic control is better, 1.5% at least the HbA1c reduction is there, and it can be given in all spectrum, like from the initiation to a combination with SGLT2, combination with metformin, combination with insulin, what Kalyanda has shown. So in all spectrum it can be given from the initial diabetes to even at advanced diabetes. So that's the experience.
Thank you, dear faculty members. I thank all the faculty members in this insulin and GLP-1 receptor agonist, a clinical update organized by academic support from Novo Nordics, Salini, Jagi, Mithun Bharatiya, Bhagi Sayar, and Sambit Das, Devmalya Sanyal, and Kalyan Gangopadhyay. All of you have done excellent because you are the excellent people of the country. Thank you very much. We go to, hand it over to Professor Ashok Das for the next session. Exercise in diabetes.
Your friends will pass on to the next session. It's my great pleasure and honor to invite Dr. Bharat and Dr. Bharat Panigrahi and also the doctor to joining him on the stage is Dr. Abhay Sahu. Abhay, are you there? Abhay is here. So I hand over the session to Bharat and Abhay, and the session is on exercise in diabetes. Over to both of you.
Thank you, sir. Thank you, your kind words. So, friends, again, good afternoon to you all. So, now we'll be starting a new session. Unlike the other sessions, we'll be talking of more on lifestyle modification. So, this is exercise and in diabetes. So, all of us know the management of diabetes. So, MNT and exercise. These are the key features that must be there, whether you take any drug or without drug or with drug. So this is the real platform on which all the drugs they act. So we have to maintain a proper MNT, medical nutrition therapy, and we have to also maintain exercise to get our goal. And all of us know exercise also acts for the prevention. Exercise also has the therapeutic effect. Exercise also has also the reversal or the progression inhibition, the progression of complications. So with all this, we'll start this topic now. I'll request Dr. Abhay to take 2-3 minutes to at least set the stage so that we'll move with the speakers. Abhay, please.
Abhay, are you there? Abhay?
I think Abhay is not there, and we straight go to the talk.
I think you can invite Dr.
Okay.
Sri Ganesh.
Sri Nagesh.
Sri Nagesh. Bharat, please invite Sri Nagesh for the first talk.
Yes.
Dr. Nagesh is very brilliant and young, dynamic endocrinologist from Hyderabad. He has got the YR Ready Gold Medal in January 2007. He
Okay.
worked
Okay. He's Dr. B. Sri Ganesh. So he's a consultant endocrinologist in the Nagesh Diabetes Thyroid Endocrinology Clinic. And this is his CV. So without wasting time, so I request Dr. Sri Ganesh to start his talk.
Thanks for the invitation, sir, and it's a great honor to be a part of such an August gathering. I hope my slides are visible now. Can you see them?
Yeah.
Yeah. For the next few minutes, I'll be talking about the role of glucagon to prevent hypoglycemia during exercise. To give you a brief context setting, as all of us know, there is no known cure for type 1 diabetes. What we generally do as far as diabetes management is concerned is giving people regular insulin injections from outside and exogenous insulin injections and careful dietary management so that you tend to be in a narrow zone of euglycemia. And to ensure that you maintain euglycemia at all times, exercise is an important component of prevention of diabetes and also in the management of diabetes so that you can reduce your insulin doses with its inherent risk of hypoglycemia. And multiple studies have actually told us that all-cause mortality is approximately 50% lower in people with type 1 diabetes who generally have an exercise equivalent to 7 hours of brisk walking per week. Generally, most of the recommendations actually tell you 30 minutes, 5 days a week. But as far as type 1 diabetes is concerned, the exercise has to be a bit more brisk. Usual recommendation is almost more than twice as is reported in the general type 2 diabetes exercise studies, and it is equivalent to 7 hours of brisk walking per week or 1 hour of walking per day. But does this really happen with a lot of our diabetic patients? These are all the imputed benefits which have been attributed to exercise in type 1 diabetes. It does lower the blood pressure because of decreased vascular stiffness and reduced insulin dose because increased insulin again has an effect on angiogenesis and atherosclerosis and vessel resistance. It improves muscle and strength and muscle function. We all do know that people with type 1 diabetes have a poor quality bone, and increased exercise because of its load bearing improves bone health, reduce risk of osteoporosis and fractures. Exercise, because of its effects on the GLUT4 receptor, improve insulin sensitivity and exercise insulin glucose uptake. Because muscle is one of those few tissues which can take up glucose independent of insulin, and this again causes reduced requirement for exogenous insulin, lowers risk of diabetic neuropathy, lowers risk of even nephropathy. Many studies have actually shown us that there is a decreased risk of nephropathy. And because your insulin requirement and insulin sensitivity actually improve, insulin requirement decreases, there is a possible role of beta cell preservation. And of course, like in all people, even people who don't have type 1 diabetes, it increases the aerobic capacity. These are all the various benefits which can happen because of exercise. But unfortunately, many of our patients with type 1 diabetes do not derive this benefit from exercise because more than 60% of our patients with type 1 diabetes remain sedentary. And this was actually one study in 2004, which did a randomized control analysis of barriers to physical activity. And this was what they actually found out. The most important reason was a fear of hypoglycemia. The other barriers which were expressed by these people included work schedule, which was interfering with the physical activity, the fact that they already had a loss of their control over diabetes and they were apprehensive about indulging in more physical activity. And most of these patients, because of their sedentary lifestyle, had a low fitness level, which again had a vicious control over. It had a positive feedback over their not going ahead further with a further increased fitness. They were sedentary, they chose to remain sedentary, and this proved to be the biggest barrier to physical activity. And if you actually look at all the various apprehensions which were expressed by these people, the most common of these remained hypoglycemia. Most of these patients were people with type 1 diabetes were actually unaware about the insulin pharmacokinetics. They had a significant number of severe hypoglycemic episodes in the previous year because of overdosing of insulin. And so they were afraid that if they started having exercise, they'd again have more hypoglycemia. The past few weeks, some of them actually had more milder hypoglycemic episodes, and they were afraid that if they actually went ahead with exercise, they'd have more severe hypoglycemic episodes. And they were unaware of the strategies to prevent exercise-induced hypoglycemia. You also had other factors like social support to engage from families and friends, higher HbA1c, which actually contributed more to people having lesser exercise. Males were less likely to exercise. People who were actively smoking were also less likely to exercise, and older people were less likely to exercise. But among all these factors, the single most important reason remained fear of hypoglycemia, as well as your knowledge of mechanisms which could actually prevent this hypoglycemia during exercise. And the reason for this is your typical physiology of what happens during exercise in a normal person as opposed to person in a person without diabetes, as opposed to a person without type 1 diabetes decreases. Generally, in a person who doesn't have diabetes, insulin is produced by the pancreas. So whenever you exercise, your pancreas decreases your insulin levels. It stops producing insulin or reduces your insulin secretion. When blood glucose levels go down, the counter-regulatory hormones, more often than not, glucagon, cortisol, and catecholamines go. They act on the liver to produce more glucose. This acts via both glycogenolysis and gluconeogenesis, and this causes a rise in blood glucose levels. The single most important barrier in people with type 1 diabetes is the fact that pancreas is almost taken out of the picture as far as insulin secretion is concerned. What you're depending on is an exogenous insulin. And more important than not, when you exercise, you cannot reduce the insulin. The first mechanism against hypoglycemia is lost. You cannot reduce your insulin levels. And second, when you exercise, blood flow to peripheral areas increases, especially if you exercise in the limb. Your insulin absorption from the site where the insulin is injected increases. More insulin increases the blood stream conversely, as opposed to less insulin entering the bloodstream. Then we do have a first stage where there is a rise in glucagon, cortisol, and catecholamines. Some amount of blood glucose is produced by both glycogenolysis and gluconeogenesis. But as you exercise further, because the insulin levels are not going down, the hepatic production of glucose is hampered. Secondarily, we all know that a lot of counter-regulatory responses are lost in people who have long-standing type 1 diabetes. So your glucagon production tails off after a few minutes, and the catecholamine secretion also comes down. As you exercise further and the blood glucose levels fall, you do not have a converse increase in blood glucose levels. This contributes to hypoglycemia because the muscle keeps on taking up glucose. And this is where the difference between normal people without type diabetes and people with type 1 diabetes comes in. And this is what actually contributes to a major increase in exercise-induced hypoglycemia and type 1 diabetes. And for this reason, multiple journals and multiple guidelines have actually given us strategies. Studies have given us strategies to prevent hypoglycemia. One of the commonest we have is what is known as XCARB. Because a significant amount of carbohydrate is lost during exercise or is utilized during exercise, they recommend carbohydrate ingestion before and after exercise by measuring your blood glucose levels. The commonly given dosage is 30 grams of carbohydrate for every 60 minutes of exercise, but this is again variable. It depends on the kind of exercise, whether you're doing an aerobic or a resistance exercise, and also on the weight of the person, the glycemic control of the person. Because if you're well controlled, you tend to ingest more carbohydrate. If you're poorly controlled, your counter-regulatory hormones rise up, and a lot of people with poorly controlled diabetes have a paradoxical rise in blood glucose levels after exercise. Now that CGMS has come in, a lot of these guidelines actually recommend looking at your continuous glucose monitoring, but again, this is not accessible to a lot of people. Many people actually also recommend changing the timing of exercise, doing it in the postprandial state rather than in the preprandial state, so that you do not have hypoglycemia. And also looking at your pre-exercise glucose trends. Check your blood glucose levels 1 hour and half an hour before you go ahead with exercise, or half an hour and just before you exercise. And if you have low blood glucose levels less than 140 or 150, take some insulin and then go ahead with your exercise. Take some glucose and go ahead with your exercise. And the most common thing which is recommended, reduction of pre-exercise boluses or cutting down your pre-exercise bolus. Use of insulin pumps where you can do this in a better manner. Or in fact, even doing a post-exercise insulin reduction. That is, if you do your exercise before your dinner or before your breakfast, cut down your pre-breakfast or your pre-dinner insulin level so that you can have less hypoglycemia before lunch or less hypoglycemia early in the morning. But while all these strategies have been recommended, they are not usually very useful. This was a recent guideline which actually looked at the fear of hypoglycemia and whether you have an adaptive response or a disruptive response to hypoglycemia. Whenever you have an adaptive response, you tend to take up both supportive as well as assertive roles, which comprises education about insulin techniques and how hypoglycemia happens in diabetes, looking at well-defined guidelines on exercise-induced hypoglycemia, taking proper use of technology if you can afford it and you have access to it, using newer insulins, ultra short-acting insulins and short-acting insulins, which cause less hypoglycemia, and thereby ensuring that you do not cut down on your physical activity, which is what contributes to your physical and psychological well-being and also a better quality of life. But while this sounds very good and attractive in theory, more often than not, these kind of supportive and assertive roles are not usually available to a lot of our type 1 diabetes patients. And this prompts them to avoid exercise. And this is where we come to the crux of our talk today, the role of glucagon. Generally, if you actually look at anybody with type 1 diabetes and you look at the responses, this is what happens in a lot of people with diabetes. Gradually, as you go further into type 1 diabetes, your duration of type 1 diabetes increases. Your glucagon responses are lost. You can actually see here, hypoglycemia did not elicit a glucagon response. Exercise elicited a very small glucagon response. Insulin withdrawal prior to exercise actually gave you a better glucagon response. Glucose administration actually did not give you a glucagon response. Amino acids and presence of hypoglycemia in addition to an amino acid oral mixture was actually what elicited the best glucagon response in people with long-standing type 1 diabetes. So as you can see, people who exercise, you might have an initial slight rise in glucagon, but later on as you exercise, this glucagon response is lost. And this is what has contributed to our concept that many of our type 1 diabetes who exercise need a glucagon response. This is a brief schematic of how glucagon responses are mediated in type 1 diabetes. There are a lot of factors which actually work on your alpha cell. Somatostatin, which prevents glucagon production. Neuronal stimulations. Catecholamines also have a role in, and catecholamines have a role in increasing the glucagon responses. The GLP-1 and GLP-2, GAP also have a role. And most important among these is the paracrine action of beta cells on alpha cell secretion. As beta cells are gradually lost because of autoimmune actions in people with type 1 diabetes, the paracrine actions of these beta cells are also lost. And this is what actually contributes to a major damping down of alpha cell responses and glucagon secretion in type 1 diabetes. And this is one of the most important factors for hypoglycemia of any form in people with type 1 diabetes, including exercise-induced hypoglycemia. And that is the reason why since 2004, after our understanding of glucagon in diabetes has gone up, many studies have actually recommended using glucagon. The standard dose of glucagon used in hypoglycemia is 1 microgram, 1 mg. But recently, once the newer methods of delivery of glucagon started coming up, we had what is known as a mini dose glucagon as a novel approach to prevent exercise-induced hypoglycemia. One of the first studies was done in 2018, which was a comprehensive study where they looked at using glucose tablets before exercise, giving a mini dose glucagon, and insulin reduction as the three parameters which could be compared. This was a RCT randomized control trial, and people were blinded, and they actually looked at this and compared to the controls. And if you actually look at this, among all of these, insulin reduction caused major rises in blood glucose level post-exercise. Use of glucose tablets actually did not contribute majorly, and you tended to have hypoglycemia. And the most consistent among these obviously remained use of mini dose glucagon. And if you actually look at the glucagon levels, which were checked in between exercise, once you started using a mini glucagon dose, there was a peak of plasma glucagon levels midway between the exercise, which is what is expected in any person with a normal physiology during exercise. And as you stopped exercise, because this was a mini dose, the glucagon level slowly came down so that you did not have a post-exercise hypoglycemia. And among all the groups, this was what was most consistent with plasma insulin levels, the plasma insulin levels remained stable, whereas the glucagon levels came up, which is what is expected in a normal physiology. And if you looked at occurrence of hypoglycemia, the controls had the least amount of hypoglycemia. People who had a reduction in the insulin rate actually had less hypoglycemia. Use of glucose tablets, in spite of giving additional glucose, if the exercise was severe and went on for at least 1 hour, you tended to have more hypoglycemia during the exercise and also during the recovery phase. Whereas among all these parameters, as compared to the controls, the best performance was done by mini-dose glucagon, where you had the least amount of hypoglycemia during exercise, and post-exercise recovery hypoglycemia was also the lowest. And they extended the study further and looked at the CGM metrics during the late recovery period. The nadir glucose was the lowest for the mini-dose glucagon. The mean glucose and the median was actually the best for mini-dose glucagon. Number of hypoglycemic events were pretty similar, but the amount of time spent in hypoglycemia was lowest for mini-dose glucagon. And the coefficient of variation was also the lowest for mini-dose glucagon. And most important, fear of overnight, especially people who exercise late in the evening. The biggest fear we have is of overnight hypoglycemia. And again, among these, the nadir of glucose was among the lowest for mini-dose glucagon. The number of hypoglycemic events were lowest. The percentage of time spent in hypoglycemia was again the lowest for mini-dose glucagon. Once again, underlining its superiority over reduction in insulin levels as well as use of glucose tablets. And taking this study further, a recent study was done just a few months ago, which again used ready-to-use liquid glucagon. The main problem we have with use of glucagon is the fact that it has to be injected. And it is only recently that we've got liquid glucagon as well as inhaled nasal glucagon. This study used a liquid glucagon and preventing exercise-associated hypoglycemia in adults with type 1 diabetes. This was again a mini dose using 150 micrograms as opposed to 1 mg, which is the commonly used dose. And they actually reported that incidence of hypoglycemia was significantly lower for those who took a mini dose glucagon, either with or without a 50% reduction in insulin basal delivery rate, because all of the patients in the study were on pumps, than those who did not take a mini dose glucagon. Once again, underlining the fact that there is a very good proof of concept for the use of a mini dose glucagon in people just prior to exercise. This is traditionally what we get for glucagon. We've got multiple pre-injectable pens, which give you a dose, calibrated dose. It can be as low as 150 micrograms to 1 mg. These are all the emergency medications. These are essentially used for hypoglycemia in children. They're usually supplied either as a 1 mg or a 3 mg intranasal dose. We've got a recent Baqsimi glucagon powder, which can be used as an intranasal dose, and a recent dasiglucagon, which is a stable liquid glucagon analog, which is not recommended for children below 6, but can be used in children older than 6. And this was what was used in the recent study, where they gave them a 150 microgram dose rather than the recommended 0.6 mg, which was 1/4 of the dose. This is the recent nasal glucagon, which has also been approved by FDA. I don't really know whether it is right now available in India, but this is being marketed by Lilly. And this can be a game changer as far as exercise-induced hypoglycemia is concerned. And recently, in the last decade, we've been focusing at insulin and glucagon dual pumps, because the rationale for this is that we've got a coexisting alpha cell dysfunction. And as we have already seen, an impaired alpha glucagon secretion in response to hypoglycemia. And we do have a blunted glucagon rise during exercise, as was shown in the earlier slide. So this was one study which actually looked at a proof of concept of prevention of hypoglycemia during and after exercise. If you used a dual pump which had both glucagon as well as insulin, you spend significantly less time in hypoglycemia with a dual pancreas than a single hormone system, which is what is commonly used, during an extended 60 minutes of continuous as well as interval exercise. And plasma glucagon levels were increased almost 2.5 times by the dual hormone system as opposed to the single hormone system, where we do not have any glucagon secretion. And more important than this, what it actually meant was that you had a reduction in carbohydrate intake, because the commonest thing done by a lot of people after exercise or just prior to exercise is an injection of carbohydrate. This can lead to a weight gain and a prolonged hyperglycemia, because this sets up a habit of defensive snacking in people who have fear of exercise-induced hypoglycemia. And this is where the advantage of a dual hormone pancreas comes in. It could reduce the need for pre-exercise, rescue, or post-exercise carbohydrates. And it also reduces non-nutritive carbohydrate intake because a lot of our children and adults with type 1 diabetes take this as an excuse to ingest more carbohydrate, which actually has an impact on their long-term glycemic control. And this study actually showed us that more rescue carbohydrate was required in the sensor-augmented pump arm than with the dual hormone system. This was illustrated by the previous slide where we actually showed that after recovery, you tended to have more hypoglycemia in the exercise arm, whereas you tended to have lesser hypoglycemia in the mini dose glucagon arm, and this was actually corroborated by the study. And most important for a lot of our type 1 diabetes patients who tend to have a significant amount of psychological distress, they tend to have less fear of hypoglycemia, and it improved their exercise related quality of life, which encouraged more people to get rid of a sedentary lifestyle. To conclude, as all of us know, glucagon response is lost early in type 1 diabetes. There are complex mechanisms why this glucagon response is lost, but almost all of them are coupled to a beta cell loss and the paracrine actions of beta cell. There has been a proof of concept that glucagon administration is of huge benefit in hypoglycemia. And exercise-induced hypoglycemia also we are getting recent proof of concepts. This needs to be administered just before exercise, and the doses are also much lower than what is given in insulin-induced hypoglycemia. Injectable glucagon was a major barrier to adoption of this therapy because of fear of injection and lack of knowledge of parents regarding the proper administration of glucagon. But now that we've got a nasal glucagon with a metered administration, this could be a very good mechanism for giving glucagon to children just before exercise so that they don't stack on carbohydrates. The dual pumps have again shown us an impressive proof of concept, but because the dual pumps have still not come into wide use or for commercial use, we have not been able to use this in a wider setting or in larger studies. The big question remains, what is the exact dosing we need, and does dosing need to change based on the intensity of exercise, the weight of the person who is using the glucagon, and the age of the patient, as well as the duration of diabetes? And we do not yet know what are the long-term effects of glucagon, because we do know that even though glucagon causes an initial hyperglycemia, this can be associated with later prolonged hypoglycemia, and whether we need to take some amount of rescue carbohydrates or post-exercise carbohydrates, and the requirement and the risks of long-term or overnight or late onset hypoglycemia with mini dose glucagon is still not fully worked out because we've got only small proof of concept studies. And this is where the requirement for more studies is needed. But on the surface, at least, this seems to be a very good and a physiological method of cutting down on exercise-induced hypoglycemia. And this is something which definitely warrants a greater amount of study and early incorporation into our exercise regimens with type 1 diabetes, which is sorely needed. With this, I come to the end of the presentation and stop here.
I think with permission of Dr. Bharat, I think this is the 100 years of glucagon, Nagesh. So I think I'm going to get back to you. Just send me or contact me after this. And following you is our dear Dr. Archana Sarda, who is an authoritative type 1. So big round of applause for both of you, Dr. Nagesh and Dr. Sarda. Over to Bharat, it was spontaneous because we're celebrating 100 years of glucagon.
Here we introduced Dr. Archana Sarda.
Yeah.
You have to see her work to believe her things. UDAN, the organization that is changing lives of type 1 diabetes in the country. And we are there at Aurangabad recently. Wonderful. And she is the top pioneer in managing type 1 diabetics in underprivileged society. And our question is how to manage hypoglycemia, learning from managing physically active type 1 diabetes children, on which she has so much of experience. Back to you, Archana, for your talk.
Thank you so much, sir. Thank you. It's an absolute honor to be here. And hello, am I audible?
Yeah, you're audible,
Yes.
Archana.
I'll just share my slides, please. Is the slide visible, please?
Yes.
Yes, thank you so much. And thank you. It's an absolute honor to be here on this platform. I follow this very diligently over the years, and it's a lot of learning. I've been listening to all the speakers, and my previous speaker was very interesting. I wish we had, as Sir said, 100 years of glucagon. I wish we had it, and that would mean I would not have to make the presentation that I'm going to make now. So my topic is learnings from managing physically active children with type 1 diabetes. What I did was, because I felt that it's, when I talked to lots of people, I realized many people in the space of taking care of children with type 1 diabetes are not really following any kind of a structured practice when it comes to exercise. We do have lots of structured nutrition. We have lots of protocols. We have carb counting. We have guidelines. We have so many things. But we do not have a specific protocol in each clinic where we follow physical activity. So I thought I'll go guideline wise by while taking the leaves out of the guideline, yet emphasize on each topic in a practical way what we can do in our clinics. So as far as the guidelines, and these are the ISPAD guidelines, and I'm going to be very specific and translate into what it means in day-to-day practice, is that, okay, first of all, there has to be an individualized management plan. Now, that plan has to include what kind of type and amount of carbohydrate would be needed for their activity. For that matter, first it has to include what is their activity going to be? What is the best time for that activity to happen? And then, as we discussed earlier, which is again, it's like being post-reactive or pre-active, but in both cases, carbohydrate adjustment and insulin adjustment, because these are the only two things we have till date. And my point is that, do we do this in our clinics? So even in Udan, where we have children who are working in the fields, they are running after the cattle, they are picking crops after they come from school. Their school itself, they'll be cycling to school, and that would be a few kilometers of cycling every day. So it doesn't always have to be exercise. It also often is a day-to-day activity level, which can be very different for an urban child versus a rural child. And again, in school, there are schools that would have games every day. There are schools which would have just once in a week, and some schools which would never have games. So my point here being, as per the guidelines, but also practically when a child comes, the way we take a recall for nutrition, we have to have an activity and exercise recall. Of course, if the person living with type 1 diabetes is sedentary, then as Dr. Sri Ganesh mentioned, that they actually need to exercise even more than people living with type 2 diabetes. And that is a different aspect that we will motivate them. But for those who do, in my case, when I see children, and especially I'm working with rural children, all of them are very active, including girls. If nothing else, they'll be dancing, they'll be going to get water from the well, they'll be running onto the mountains, and it's a lot of activity that happens. So first and most important is to document it, to understand, and then talk to them about how do you adjust carbohydrate with that activity, how do you adjust insulin with that activity and exercise, and of course, what is the best time, because it cannot be like grazing in food, like similarly grazing in activity. Now, also a plan which has to be taken with the school. A lot of talk across the country is happening about school care now with the CBSE board and the government GRE, which has come, where you can take your pump, you can take your CGMS, your glucometer, and even your phone, a snack into an examination. Similarly, it should encourage all of us to give letters to the school, whether it is a remote rural school or or it is a public school which has a structure, a nurse. But each one of them, in Udan, we send a letter and we do plan. We ask them for the week's timetable. We see whether the child is going to school walking, or what time is the break, when are their activities, what are their study hours. And all that is planned initially. And if there is any change, the teacher is asked us to inform. Usually in 3 months, there is some change in the cycle, and we have to plan this once in 3 months with the patient and patient's family and also the school. So initially, it should be, what is the initial exercise care that we want, the management? Care should be taken from very basics. Are there blood glucose meter and strips chosen which are suitable for where they are? Because that care starts from there. We have so many children nowadays who are going for evening classes. They're going for skating or yoga or something. But are they carrying their glucometer and the test strips for them? And if they can we can, those who do not know yet, but they want to train their children, they have asked them to go for a tennis class. Sometimes it's not even just for exercise because it's a trend, it's a fashion, it is cool to be doing this stuff. Sometimes they're doing the right thing for the wrong reasons, but they are doing it. Then it's very important we also let them know that there is technology available like CGMS and a pump, which might make it easier for them to go into a structured exercise program. So ensuring they have a monitoring system is first part before taking care of physical activity. And this is something we do in the remotest of our children. I mean, no matter where they are. I have children whose families they are nomads. So they would walk 20 kilometers a day because they don't stay in one place. They keep walking. They have these cattle which they take with them. And yet so accordingly, everything has to be managed, and that monitoring becomes a key factor. So we ensure that they have adequate strip supplies wherever they are. Again, keeping a record of their physical activity, food, and glucose levels. For example, I mean, I can imagine with all the technology that we were talking about, it makes sense that, we have a record and all. But what about a child in a village or even in a town? Most people are still on multiple insulin injections and would have a glucometer. So SMBG with multiple doses of insulin, they have to log. And I know they do not like to log. So at least initially, till we understand them, the easiest part is today you can log on the phone, and if children don't like to write. But at least for us to plan, we need a very high quality data, because otherwise, how will you plan the doses? How will you plan how much carbohydrates? How will you plan what kind of correction doses? Who will receive? And that cannot happen without this data. So first 3 months, we insist, and we sometimes, beg, borrow, steal, whatever way it is to convince them that a log is very important. And then we see those patterns, and that gives us the data from which we can extract that this is the pattern which is suitable for that particular child. Now, although the prevalence of diabetes complications is low, but still it makes sense as a protocol. It is a good guideline to give a letter to all the children, for their coaches, for wherever they're going, telling them, giving them permission to participate or whatever care is needed. So if a child is going to a tennis class or is training for a marathon, it's very important that we give a letter officially from our end, although we do see very few complications. Again, patients who have proliferative retinopathy or nephropathy should definitely avoid resistance training based exercises or anaerobic exercises, which could raise their arterial blood pressure. So that is something they are told initially itself. Now, once we have set the stage, so my point was that as per the guidelines, we can translate it into the highest resource to the minimal resource, but we cannot skip it. So we do sit with a child and create a conversation, create a plan, log for 3 months, get high quality data, and then guide specifically on how we can manage their exercise or even activity levels when it comes to rural areas. So what are the general situations at the guidelines? This is just for our knowledge, because often I find that even these are things not told to the students or the children, and then things go haywire, as we know. So elevated ketones is one thing we should all know about. And it's important to identify the cause, and it is definitely a safety concern. Ideally, exercise should be postponed until and unless until it is cleared. Still, high intensity exercise is definitely dangerous. When it is above 250, it is important they check their ketones. Now, I just want to say, often I get people say, how is that possible? I just want to tell you that I have right now maybe 1,300 kids in the villages. Each of them have a keto strip. I know we don't do the blood ketones in rural areas, but I'm just saying they at least do their ketonuria. They check it. And every time the sugar goes above 250, they check their ketones. And if it is high, they talk to us. So I feel if we take it seriously, it is definitely possible. And I'm sure this has prevented many complications, acute complications that could have happened. So focusing on ketone and avoiding exercise, waiting, finding the cause, seeing hyperglycemia, and not exercising when the sugars are high at that moment is also as important as we are focused on hypoglycemia. Hypoglycemia is something even children are focused about. Their families are focused about. Hyperglycemia is something, there's a misconception in the general public that, okay, my sugars are high, my child will run and the sugars will come down, or my child will exercise and sugars will come down. So it's good to exercise. I have heard people say, okay, your sugar is 400, why don't you start exercising? Your sugar will come down in a person with type 1 diabetes. So these are the things we need to make people understand. And unless and until we tell them, they think it's just common sense, which sounds logical, but is not okay. Now, a very nice discussion has already happened on hypoglycemia, but it's important that we put it into categories, into buckets. In a practical scenario, that severe hypoglycemia on the previous 24 hours is a contraindication to physical activity. So it's not just now. That is something I have to tell all my children all the time, because for them, suppose, like, for example, we had a trek last week, and one of the child in a village who was supposed to participate in the trek had a severe hypoglycemia actually for a very not okay reason, in the sense did not get food and all that, but insisted on coming for the trek. So we said no, and was very upset, and we had to explain why. But it's very important to understand that severe hypoglycemia is a contraindication. Non-severe hypoglycemia, which has occurred recently, can also, as we were talking about the counter regulation in the previous talk, and that can lead to deterioration of the hormonal counter regulation during physical activity, ultimately increased risk of recurrent hypoglycemia. So one hypoglycemia begets another, and hence again, we have to be cautious. Maybe we can't always deny a child from activity, but we have to be very cautious. So all situations of documented hypoglycemia prior to a physical activity, we have to be very vigilant in monitoring. So what we can do if we have to allow activity is very frequent monitoring. Like in Udan, we do these 25-kilometer treks. We do quite extensive physical activities together as a group, and that is what we do. We monitor very frequently, and that is a time they get trained during the camps to manage, because then they know that they can have a late hypoglycemia, how to pre, intra, and post exercise manage. So this is a hands-on learning that they get about all the three things. Now, children have to be encouraged to measure their blood sugars before, during, and after exercise. Now, let me tell you, I know what people living in this space are thinking, because my kids too, they do it when they are with me in the camp, and they do it for a week after they go away from the camp, and then it starts dwindling, because then they assume we know our body, we understand, they understand their symptoms. So it's really not easy to convince them to do it all the time, but it's very important we keep saying, and somewhere it makes sense, and then they are able to. Other aspect is, of course, to check sensor-based glucose values on a regular basis is very important. And if we have predictive alarms and low glucose alarms, all the technology can really help. Now, just having a CGMS does not help. I raised funds in between to give CGMS to all the children, and they would not just scan it. I mean, just not looking at it also. So it's not just enough to have it, it's very important to actually look at it. And of course, when you look at it, to interpret it. So these are very little things which do not translate from a guideline, which you think logically would happen. Hence, we have to ensure it. Again, high glycemic index snacks should be readily available. I know, as we discussed in the last talk, it's not the best solution. You end up having too much, it's lots of overnutrition in a way, but they have to be available. They, as a rule, they have to be available. There's a whole list available. Whatever is locally available, I always like not to give something very delicious or candy-like, because then it doesn't stay till it is really needed. Children end up eating it whenever they want, and that is only natural, so they get tempted. So it would be very important to define this and give it to them. In Udan, we insist on an ID card. Every child in the remotest of areas has to have an ID which talks about their diabetes, and this is absolutely essential. So a high glycemic index should drink or a pouch, whatever, and a card are two things that every person living with type 1 diabetes must have. We had a case where a child was traveling in a train and went into hypoglycemia. The mother could not get sugar from anyone. She was not carrying her glucose, and I think they bought it from some tea vendor, and they paid like some 500 rupees for 2 spoons of sugar. I mean, that's a really depraved humanity at times, but that kind of, I mean, at least they got it, and that was important. But these are all anecdotal things, but point is that we have to be very firm. We have to really, really insist, and this is very important. And communication from otherwise also, who are they going to call? Who is the coach going to call? Who is the teacher going to call? How are the children going to call? If the phone is not there, how are they going to reach out? So this has to be worked out. It's as important as insulin. It is as important as learning how to adjust the carb intake, and communication, ID, preparedness for hypoglycemia is extremely important. And this we had just talked about, so I'm not going to repeat what was there in the last talk, but activities lasting than 30 minutes are likely to require a reduction in the insulin delivery. So as spoken earlier, when exercise is planned at the peak insulin action, that is when the rapid action is administered and after the meal, then specific reduction accordingly can be made. So it's very important to time it. I think all of us as clinicians who are prescribing an exercise know the action profile of the insulin. We know what kind of activity is happening, what meal is happening. We just have to put it all together. But that effort has to be made. It has to be planned. And now, for that, we have to have a planned way of exercise. We also know that children often do not follow a system. But it's in Udan, we have designated specific times of play times and duration. And we have asked parents to watch that, okay, if they play for an hour every day and today they want to play for 2 hours. So that's where they tick in their mind, okay, this is more than an hour now, and this is the intervention that I'm going to do. So just training them for the red flags, that what are they supposed to look for and where are they supposed to take an intervention. And if they don't know what to do, they can always call a helpline and ask if that is important. So again, I'm not going to go into great detail. Point is that we would have to adjust prior, during, and after. So these are all 3 levels which are important. So adjusting prior and during the exercise, when we are using a long basin, or we are, it's very important that we reduce much earlier, right? If it is a planned activity and suppose you're using a basin like degludec, you would like to really do it a day before. Otherwise, you would not be able to reduce the doses. And so those are, again, things which need to be kept in mind. And what kind of adjustment will be done. For example, when the rise in blood glucose level after intensive exercise, we can give there's a rise, and then that time a small additional dose of rapid acting insulin, which could be 50% of the usual correction bolus, which would be given. Or again, it could be a different activity which would bring down the blood sugar. But again, who knows this? How many people know about it? That which kind of exercise is going to bring up the blood sugar, which kind of exercise is going to bring down the blood sugar levels. Now, these are things that we may all know theoretically, but do we chart it out for our patients? Do we tell them that this is how you maintain a balance? So it's time we create something very practical and share it with our patients and their families in a very local, activity-friendly way, so as not to also make it overbearing. I think so many instructions about exercise would make a person say that I don't, anyway, people don't want to exercise. And they would say, I don't want to do this anymore. Now, there are doses which need to be adjusted after or late evening after exercise as well. This is very important because nocturnal hypoglycemia risk really increases. As I was sharing, when we go for treks, we have to really give them a night snack. We bring down the night blood sugars. We lower the basal rate because nocturnal hypoglycemia is what we're expecting, or fasting will be low is what we are expecting. So more monitoring and more reduction, anticipating a reduction in the blood sugar levels in 24 hours after as well, and accordingly managing the doses post-exercise is also something we have to prepare our teams with. Now, what about the afternoon or late evening after exercise? For example, if they are on a temporary basal reduction of approximately, we want to reduce it at bedtime. If you reduce it for 6 hours, it helps reducing the risk of nocturnal hypoglycemia. 20% basal dose will help them. Again, a carbohydrate snack. I insist on a carbohydrate snack at bedtime because no matter what you do, sometimes I have seen like hundreds of cases, and the number at night does not always predict that there will be no hypoglycemia at night. So there's a whole lot of physiology to it. But as a dictum, I insist on a carbohydrate snack at the night if there has been an exercise before. Now, we were talking about how do you manage with the carbohydrates. So intake prior to and during the exercise. So it may not be required in a moderate intensive exercise if the blood sugars are okay and the exercise is like 30 minutes. We do not really need to add. And once we have seen the blood sugars pre, intra, post exercise or with a CGM, then we know that the child does not need it. So there need not be anxiety, and all the time mothers are giving their children more snacks. Eat because you're going to play. Eat because you're going to play. So these are things we have to set at rest. But for low to moderate intensity aerobic exercise of more than 30 minutes, then we have to think of adjusting the doses. Sometimes you have to increase when that exercise is going to give them hyperglycemia, or decrease accordingly. So adjusting the carbohydrate intake, adjusting the doses pre is important. Sometimes we have to give them in between also, as I said, with marathons and treks. Now, post exercise as well. So appropriate carbohydrate and protein should be with protein. This is not pure carb, should be consumed within 1 to 2 hours of exercise, because that's the time there is a increased insulin sensitivity, and that is the right time to have a protein and carbohydrates snack, and it will bring down the post-exercise hypoglycemia risk. Never forget the dehydration part, because that is a risk, and water or sugar-free fluids are also important, and that becomes part of the management in children who are exercising specifically, even who are playing competitive sports or are doing camp days or sports days in school. So hypoglycemia is, of course, the burning topic. That is something we all pay attention to. I'm just finishing my last slide.
Sorry to interrupt, sir.
Yes.
It's time.
Yes, last slide. I'm just finishing last slide. Right. So technology can help, and technology like pumps, CGMS, definitely we should tell them, especially if they are going to learn for next level of sports, especially competitive sports. So the last slide of the talk is that professionals, we must take this opportunity to learn and study, do camps, and that's where we learn, because this is a practical learning. No matter how much theory we know, we cannot translate it into action. It's important that we, in our clinic, create a system where we can discuss this and translate it into a local way where children can take care. So always carry an iCard with glucose tabs and let the children play. Just be more vigilant, more monitoring, and more education. I'm very sorry for shooting up the time. I could not see the clock. I'm sorry. Thank you.
Okay. Thank you, Dr. Sarada. My video is stopped.
No, it's working, Bharat.
Somebody else. Yeah. So now we are already late. So without wasting time, we'll go to the next topic. So the next topic is how to initiate an exercise routine for diabetic patients. There are two speakers. One is Dr. Utkal Kishore Khadanga and Dr. Alok Kanungu. So it's only 15 minutes. So Dr. Khadanga and Dr. Kanungu will at least we should stop within 15 minutes. Okay. So Dr. Khadanga, please start.
Welcome to NUCD 24. This is the 10th NUCD, and in this session, we have a very important guest, Dr. Utkal Kishore Khadanga, who will be speaking on exercise and diabetes. What precautions we should take, but who are allowed to do exercise, and all that. As you all know, physical activity and exercise has some definite difference. All physical activities are not exercises, but exercise is what is coordinated, regulated, and energy consumption can be measured. Dr. Khadanga, welcome to this event.
Namaskar. Thank you, sir.
Namaskar. Our viewers would like to hear from you many things because you are one of the front runner as a doctor, also an expert doctor, and also a expert health keeper. You have been running 42 marathons. You do every day 30, 40, 50 kilometers cycling, sometimes 200 kilometers, sometimes 600 kilometers cycling. And there is no event in the city that you don't, but you go to other cities to do, as you are telling, on this 20th, you have Mumbai Grand Marathon. So a doctor who is so exercise savvy and understand the exercise basics and everything, advanced things, my first question to him will be whether all diabetics need exercise or not, from type 1 to GDM.
So the answer is exercise is the one of the most and strongest pillar of type 2, type 1 or GDM management, of diabetes management. So all the patients who are diabetic or non-diabetic should exercise. There is no doubt about that.
Because we have all known, and it is a scientific fact, that if you do exercise, your longevity increases. Because diabetes and exercise are part and parcel of the treatment and its relationship. So, what are the factors that affect glucose response to exercise? How do you think so?
So the factors that affect the glucose response is the type of diabetes. The type 1 diabetic and type 2 diabetic, they respond differently. The duration of diabetes, the medications the patient is on, like whether the patient is on insulin or OHA, or which type of OHA he is on or she is on, and what is the metabolic control of the patient, whether the control is good or bad, what is the A1C status, how much insulin or what kind of insulin patient is taking, and where is the what is site of insulin and which part he is going to exercise.
A patient has come and sitting in front of you, 54-year male, and he is diabetic for last 10 years, and he has never gone for exercise or walking or anything. What will be your advice to him, and what will be the precautions that you want to suggest to him?
If the patient has led a sedentary lifestyle for a long period, I would ask the patient to start with 5 to 10 minutes of walking only. So the types of exercise, if you say, or intensity is low intensity, moderate, and vigorous. Low intensity is just walking. So let the patient start with walking of 5 to 10 minutes, and patient has to first know the physical status, like where he stays and where patient wants to go. The patient has to be motivated first. If I'm only telling to go and start walking 30 minutes a day, patient will never listen. So I have to tell him that what is going to benefit by starting exercise. Okay, what he is going to see after 6 months when start exercise with the blood glucose control and the body weight and the blood pressure control, and then start slowly, like 5-10 minutes of walking, let's say for 1 week, 2 weeks, then gradually increase to 15 minutes, 20 minutes, and so on, and keep a target of, let's say, 30 minutes after 2 months.
So counseling and telling patients in detail really helps.
Right, sir.
Who is only walking now, suppose the person says that yes, I walk 5 kilometers a day, and you see that he is not achieving his target, what other exercises do you recommend him?
Sir, I recommend what the person loves the most. We cannot, compel a person to go for swimming or cycling or strength training. The patient loves, he or she loves dancing. So I would recommend a patient go for dancing at least twice or thrice in a week, apart from the walking. So variation is very important. The patient is continually doing 5 kilometer walking, and there is no change. So we have to change the routine. So I may ask the patient loves a bit of weight training, so you can go and do a some trainers or the physical strengthening exercise with light weights or machines. Or the patient loves dancing, patient go for dance, Zumba. The patient loves outdoor sports. He can go play tennis, basketball. So it all depends what the person likes, and we have to imbibe with that.
That is very important, as you have rightly told. And if you ask physical trainers, they say yes, there is called aerobic exercise, there is weight exercise or resistance exercise. For viewers, would you like to explain a little better about these two varieties?
Right, sir. So basically, the three types of exercise. One is aerobic exercise, one is strength training, and the third one is balancing and stretching. So the aerobic exercise is basically recommended for all the patients, and as per the ADA guideline, or what we recommend, at least 150 minutes of aerobic exercise per week. But with that, we try to imbibe two strainers or the muscle training exercises at least twice in a week, apart from aerobic exercises. So that by adding this weight training exercises, that increase the muscle decrease muscle resistance, the insulin sensitivity increases, and the muscle mass increases. That helps in losing body weight, losing blood pressure and cholesterol. And uh, as per the ADA guideline, if I go as per the guideline, the young type 2 diabetic patients or type 1 diabetic patients or adolescents, it is recommended at least 60 minutes to 70 minutes of physical activity with aerobic exercise 5 days a week with 2 day times of this muscle training exercises. For adults, it is recommended at least 150 minutes of week per week of the aerobic exercise, at least with that two this muscle training exercises. And for the older adults, at least the balancing and stretching exercise is recommended.
These are our young children. They want to play. They want to do everything. They want to swim. They want to cycle with speedily because their friends are doing that. So after 10 years or 7 years, 8 years, till 15, 18 years, what do you recommend to our type 1 diabetes, and how do their parents know how to maintain the blood glucose during exercise?
For type 1 diabetic, I ask the type 1 diabetic patient to lead a normal life like any other peer group or any other friend with cut down of the sweets, but rest all food the patient can take apart from this easily or simple sugars. But activity, yeah, cycling, this running, swimming, everything he can do. And I ask them to add, 1 2 classes of this physical training or the weight exercise. Yeah, what you asked rightly said, sir, how the parents should take care of that. So they have to check a blood glucose before starting exercise. And before, if the blood glucose is less than 90, then I ask the parents to give a 15 to 30 grams of simple carbohydrate or glucose, and thereby 0.5 to 1 gram per kg per hour of continuous glucose if the patient or the person is doing exercise for 1 hour. And
So, tell me.
And if the blood glucose is up to 150, it's fine. Patient can continue with the same. If it's 150, 250, then no need to start or give the carb load. Patient can keep on doing exercise till the blood glucose falls to 150. Once it is 150, then patient can take glucose of 0.5 to 1 gram of glucose per kg per hour. If it is above 250, it is not recommended to exercise. We should check the blood ketone. And so that time we should be a bit careful.
Very nicely explained. About pregnant women,
So
what do you?
all the pregnant women, those who do not fall into very high risk category, they are advised for again say 150 to 175 minutes of exercise, aerobic exercise per week with 1 to 2 sessions of this muscle training exercises. And also yoga is advisable for them. And they should. It's nothing like once person is pregnant, they cannot do exercise and keep on eating and put on body weight. So exercise is a must for them. And even the GDM patients, it is advisable to increase those 150 to 250 minutes per week so that they will not put on the extra weight.
And up to which month they can do this?
They can do this exercise even up to 40th week of pregnancy.
Oh, till the they
Right.
can continue.
Yeah.
Oh, very good. When exercise is discussed, we diabetologists always think exercise is one part, but sedentary lifestyle is another part. The person, we measure how long he's sitting and not becoming active. What do you recommend on that?
So now this like the term has come, sitting is new smoking. Okay, if you sit continuously for 6 to 8 hours, so that puts on extra the comorbidities, diabetic and the cardiac comorbidities. So we have to sit and every 30 minutes get up and go for a stretching or bit of rotational exercises for 5 minutes and then come back to sitting. So sedentary habit that has to be discarded, and we can do this intermittent exercise that you sit for 30 minutes, get up, do some 5 minutes stretch, and again come back to your seat.
Some elderly people, it has been found that during gymming, drop down dead. Even younger people have dropped down dead,
Right.
even if not diabetic.
Right.
What is your word of precaution for that?
For non-diabetic patients, we do not recommend any cardiac checkup or any, this checklist before starting exercises. And what the reason behind these drop-down dates could be a lot of stress, lack of sleep, lack of rest, and maybe drug abuse could be a reason. So these are the reasons, and but nobody can explain that what happened. But that is what I can think of. For diabetic patients, it is always recommended to take doctors first from permission. Even the ADA 2024 guideline says for any diabetic patient, even the patient control is good, and if the patient is going to start even low intensity exercises, low intensity means just walking for 30 minutes, he has to take a clearance from his treating physician. So that's what I too recommend my patients, and patients who are going to planning to embark on a this vigorous exercise and or run a marathon. I would definitely ask them to go for a cardiology clearance. And what the cardiologists usually ask for a stress ECG test, or they may ask for echo ECG, and even few cardiologists ask for a CT angio for those patients who are going for a complete full marathon. So this is what is mandatory. They should go for this. Apart from this, they should check a urea creatinine level, lipid profile, and if diabetic patients should check a retinopathy checkup, they should do before that. So these are a few things we should keep in mind.
We see our gentlemen, they walk. They have groups, they go to the parks, they go for morning walks, but ladies are bound to the household work. And they have diabetes, they have truncal obesity, they have other problems. How do you advise our lady folk or the women with diabetes?
So when I asked, like, ma'am, do you do exercise? Now, yes, I do a lot of work at home from morning to night. I do a lot of, household chores. So that is like, that is day-to-day activity. That is not exercise. So for that, you have to devote at least 30 minutes to 40 minutes for yourself, which you are not doing day-to-day routine, in day-to-day routine. So you have to take out time and go for a walking or yoga pranayama. If you cannot go to outdoors due to some restrictions, you can do yoga exercise, some stretching, some balancing exercises you can do. Or
Any experience you have somebody while doing exercise met with some emergency and something was done for him? Any example?
Just last month, sir, I went for the Kolkata marathon, 25 km marathon, and that time a doctor around age of 55 years, it just I crossed him and he fell down, and immediately ambulance was brought, and he was declared dead. So he was running with a group of doctors. So I inquired what happened. After they were like with a lot of stress, and after the marathon I asked, and they said that doctor was he went to America. He traveled just 1 day prior, and he had to do the marathon. Though he was physically fit, but he was completely no rest at all, and he came for the marathon. And
So body needs rest,
absolutely,
mind needs rest,
absolutely.
muscles need rest before
Any
going.
exercise, we need number one, nutrition, rest, sleep, recovery, and also before that, before exercise, that pre-workout or warm up.
Hydration also.
Hydration also, sir.
Hydration is very important.
Very important.
So, do you recommend proteins, extra proteins for people those who take do exercise and they do not have renal problem?
So for body, those who go for bodybuilding or this muscle building exercise, they tend to take extra protein, and it is required at some point also. Those who are going for competitions, and if their like kidney function test, urea creatine, and clearance level is all right, so they can take a protein for 2 to 3 months with a break of again 3 to 4 months. So if
So,
patient asks me, I tell them, be cautious, go for good brands, because you have to look at the brands in India or domestic products. It has come like they have added steroids and all those things, and then they sell it for the faster. But I tell them, go for a better brand, take it for 2 to 3 months during that your competition time. Again, give a break for 3 to 4 months, and again take for 2 to 3 months. But keep on
so,
checking the kidney function test. Yeah.
so you will recommend anybody diabetic going for walk or exercise to carry some glucose, some biscuits, some water along with?
Absolutely, that's a must. That goes without saying. So any diabetic patient taking insulin or OHA is always recommended to carry some lozenges at least in the
And
pocket.
as the traditional teaching says, that if there is a doubt whether it is hypo or hyper, hypoglycemia should be given preference
Absolutely,
and
sir.
treated.
Absolutely.
So, Dr. Utkal, it was excellent talking to you. A man who is really in the paramount position. Your this all these medals suggest that how active you are in the day-to-day life in being a doctor. This will inspire other doctors also to advise exercise for them. And national update on clinical diabetes is clinically oriented program, and we are thankful to you. Thank you very
The
much.
last word: do what you preach. Once you preach your patients, you have to do that by yourself so that they will listen to you. Thank you so
Right.
much. Nice talking to you.
Thank you. Nice meeting. Stay well.
Thank you, Dr.
I
Utkal and
think
Dr.
Niranjan has
Alok.
joined. Niranjan has joined. Let us pass. Sambit has joined. So I'll request Bharat to carry on the panel discussion. This has been a revealing session. I'm extremely delighted to see Utkal and see all of you, and of course Sarda. I mean, the tips that you gave, Sarda, are great. Sarda, are you there? You should be visible. Make your video on, Sarda. I mean, it has been Nagesh is here. I mean, it has been a great session. Please, over to Bharat to please ask the questions.
Okay, thank you. Can you just add one line regarding to these people who are dying during exercise or during their marathon? So I'll just put a word. I think Professor Das will agree with me. These people have something undiagnosed hypertrophic cardiomyopathy. This is a cause
Yeah,
of this
that is
sudden
a known
cardiac
cause.
death.
Hokum is a
Yeah,
known cause, Bharat, as you
yeah.
rightly said, of sudden cardiac death.
It's a known. It's a cause of sudden cardiac death in those people who are undiagnosed. Really, that is a major problem there. Okay, coming to our uh, panel discussion. Rather, I'll be. I think most of the questions have been already discussed by
Yeah.
our previous
I, I,
speakers.
I have a question for
Yeah.
Utkal. Before that, I will like Nilanjan, my dear friend and my colleague, to please say a few words, Nilanjan, about the exercise and diabetes. Then we'll pass on to the questions.
Thank,
Nilanjan.
Thank you, sir. Thank you, Professor Das and all other panelists and my juniors in the panel. I thank Dr. Olive Kanungo for making me a part of this wonderful update. Well, exercise in diabetes, I think we've heard a lot in this session, but the thing is that exercise in diabetes is important, very important in type 2 diabetes, also important in type 1 diabetes, though the data favors its benefits more in type 2. Second, this exercise has to be complied with. It should be simple and has to be customized. Now, that's as my previous speakers have said, just as now the therapy, pharmacotherapy of type 2 diabetes is customized and individualized, even the targets for glycemic control are individualized. So also exercise has to be individualized. There are very many options from exercise. It's 2 o'clock. Very many areas. The exercise can be done at home, in a gymnasium, in a park, or in other public places. It can be aerobic exercise, even a resistance training where the person cannot, for example, do walking because of advanced osteoarthritis of the knee, can do some, upper arm ergometry and resistance training with bands. So there are various types of exercise, various avenues to do exercise, but that exercise should have to be done safely, keeping in mind the contraindications in consultation with the healthcare professionals. And the most important thing is that the patients have to be regular. And of course, in type 1 diabetes, those who are prone to having hypoglycemia, all those safeguards against hypoglycemia and even safeguards against severe hyperglycemia and ketosis in appropriate places, appropriate circumstances have to be taken. So I think exercise is one of the important therapeutic components in the management of diabetes as a whole and type 2 diabetes in particular, and also in its prevention.
Thank you. I have a question to Sardar. Are you there, Sardar? I mean, we know all about the story of the Phil Sutherland, who was a type 1 diabetic and who did marathon, and he has been this. His life has been taken as an example. Utkal, are you there? I think Nargesh must have heard about him, Phil Sutherland, who did a. I think I can see. Okay, so he was a type 1 diabetic, and he showed to the world that, as you rightly said, customized. That is the key word for the exercise, and he showed to the world that but by customized and by practice, he can do a lot of activity which was hitherto not allowed for the type 1 diabetics, but it was made available to him, and he was a champion. He did 3,000 miles cycling in the United States to become the first type 1 diabetic, and his life has been taken as an example of exercise in type 1 diabetics. So rightly said. Now, I would like to know that, I just had a talk by Dr. P.C. Manoria. I think all of you know him, past API president and cardiologist from the city of Bhopal. Now, he gave a talk about preventing gym deaths. I think I think any one of you, Sambit or Nagesh or any one of you, Niranjan, I think it is unaccustomed exercise, over enthusiastic, which produces this. I will take the name. They're my friends. Raju Srivastava, the comedian, the famous actor and the politician from the Karnataka, who was the younger brother of the chief minister. What do you more talk about preventing early gym deaths? Any one of you? Sambit, would like to take this?
I think this is a big thing which is coming up recently, and especially after in the last 2 years. So, a number of young people are dropping down death in gyms. So, as you rightly told, it's the unaccustomed severe exercise which has produced that, and there might be some underlying cardiomyopathy or hypertrophic cardiomyopathy that might be the reason, or there are some postulation that they were having COVID beforehand and that had created a problem, or some underlying cardiovascular disease. So this could be, but unaccustomed severe exercise is the main culprit actually.
How it will cause death?
Yes, Bharat, please. Bharat, please continue.
The modalities of death, how it cause death? Even if it's honest, it is not accustomed, but the end of the how it can happen? That has to be explained.
Bharat, the mechanism is complex. Like
Arrhythmia and
obstructive cardiomyopathy, we know something about the fibers and the tracts which gets
No,
affected.
that needs to VTBF and death.
Yeah,
If
but
somebody has
I'm
SCM,
talking
it
about,
will lead to VTBF and death. That's a cause.
I think what Utkal said was revealing. Utkal said about the doctor in Calcutta Marathon, Niranjan, he spoke of doctor who came back the previous day from a long flight, and maybe he has taken a long flight, and people caught money and take flights which are long sitting hours. Somebody going from Pondicherry to a very far off place, Bahamas, and he took 3 flights to save money for his entire family. And we found he was saving money for his coronaries. So, it is very important to have rest, nutrition, hydration, and to start low and go slow. I think that is the what I think there. Now, let us come back to the type 1. We have less time. 2 o'clock, a lot has been given to us. Now, before I start, all the experts are here. Would you like to speak anything? Nagesh, Sambit, Nilanjan, Dr. Alok, anything you have to speak first. Then I'll go for 4 or 5 questions and we'll wind it up. Anything you have to say, Nagesh, apart from the beautiful talk you gave about the glucagon. I'm going to get back to you because we are compiling a paper for the Epicon. You'll be one of the authors, Nagesh. So anything
Thank you,
else you
sir.
want to speak? Anything else, Nagesh, you speak about it?
Sir,
Nagesh is the award winner. I gave him the award of the best paper in one of the NIS. Remember, Nagesh?
yes, sir.
Yes.
It was in 2013, sir. Just after.
13, I remember. Nagesh, please
Yes,
start.
sir. Sir, as far as exercising type 1 diabetes is concerned, I think one problem which I face with a lot of my school children is the lack of time.
Yeah.
Yeah.
But you see, I just draw your attention to a paper by Dr. N.K. Singh. You know him, of Dhanbad fame. N.K.
Yes,
Singh.
sir.
He is the author of CME. He has put up that I'll read it out to you at the end of the talk. But I must tell you, he said that is a misnomer. That is a misconstrued. People say lack of time, but that is not the real case. I'm just telling in the words of Dr. N.K. Singh. But that is a problem. Let us accept it. Next, please
Yes.
proceed. Please proceed. What
Sir,
else?
the other problem which we have been facing is reluctance of people to adopt measures like CGMS, sir. Because especially as far as my experience with hypoglycemia is concerned,
Yeah.
the price initially there was a huge amount of interest in the CGMS, especially the flash glucose monitoring. But
Yeah.
right now we've been seeing that flash glucose monitoring is used more by non-diabetics than by diabetics.
Correct.
This, and
It is
one is
cheaper and it is easier to organize. That's why people do it flash.
and most people don't understand that it is not of great use in people who do not have diabetes. We are actually finding out that people with actual need and people who have type 1 diabetes are not using it properly. And the price of pumps has also not come down of late, and we do not have any national programs to use pumps. All of these factors and carb counting and checking blood glucose levels before exercise, I'm sure everybody has shared their opinion that most of our patients just don't do it. The only way we can do it is by doing a CGMS, and CGMS is still now unaffordable to a majority of people. I think we need to do something about the pricing of CGMS from a doctor's perspective.
I fully agree. We have given the proposal to government for the type 1 diabetes HGMS must be made free. And I think they're considering it. Good point you made. Good point you
There
made.
is an advertisement yesterday
Mhm.
that the CGMS of 8,000 rupees will be available in 1,900 for a selected period
Yeah.
by Healthify Me. So I don't know what is the quality of CGMS and all those things. Yesterday that advertisement I
Yeah.
read.
I think people are working on it. You're correct. I have also seen that advertisement.
Yes.
Yeah. Yeah. Good. Good. I think good point you have said. Any point you like to say, Sambit?
No, I think, sir, the exercise or the advice we give to patients with type 1 diabetes is definitely different from type 2. And it
Absolutely.
has been very nice talk by both Sharda ma'am and Nagesh. It was excellent talk. Time of exercise, type of exercise, duration, and what ma'am has told about some unaccustomed physical activities are to also to be recalled actually. Like we do dietary recall, maybe an exercise recall or any activities what they're doing other than the structured exercise is very important. Monitoring is important, but as Nagesh has told, pre, intra, and post I think no one does, but at least a pre-exercise glucose check is important. And educating the patient, like carrying glucose, carrying carb snacks and carrying the glucometer is very, very important, and hydration during the time of exercise. So these are few important points in type 1.
One of my patients, Prisa, she is 12 years, type 1, for 2 years onwards. Her mother carries glucometer, glucose, and food when she goes for dancing, and she does heavy dancing. So she has no problem, and many times she has been using CGMS also to see the impact of exercise or dancing on glucose level. Dr. Panigrai, please.
Bharat?
Okay, so I think we have discussed a lot also. So let me ask, what are the benefits? What are the benefits of exercise, especially both in type 1 diabetes as well type 2 diabetes? I'll go like this, starting from the prevention to the therapeutic to changes. So I'll ask Dr. Sambit. So how to see what is the role of exercise in prevention of type 2 diabetes? We have talked a lot on exercise.
I think prevention is an important component, the benefit of exercise, and we have learned from all the trials on diabetes prevention which has been done with lifestyle intervention, say it the diabetes prevention program or IDPP or Indian Diabetes Prevention Program or other programs also. They have taken lifestyle modification, especially exercise,
I think
has been quite promising. And
yeah, please continue, Sambit.
Sir?
Please continue.
Yes, sir. At least in the DPP program, they have shown 150 minutes of per week exercise or the brisk walking or moderate intensity aerobic exercise can actually reduce or prevent diabetes up to the tune of 58%. And the Indian Diabetes Prevention Program has in fact shown the exercise to be better than metformin or even a combination of exercise with metformin. So in all this aspect, exercise is very important for prevention of diabetes.
Thank you, Dr. Sambit. So one thing,
I think, Bharat, one thing I'd like to mention that in all the program, DPP of United States, DPS from the Finland, and IDPP from India, as Sambit beautifully put it, it has shown that the exercise scores above medication for the prevention of type 2 diabetes, for the primary, secondary, tertiary. Let us discuss the simplest one, pre-diabetes going to diabetes. But no, those exercise which are very, very good have been really monitored and has been with the coaches and have been with the reminders, calls, and lot of labor-intensive, labor-intensive for doing those exercise. That is why we brought in the concept that must be given chance for the first 3 months. If one is not able to achieve it, which is really difficult, then one can do, as Sambit said, exercise plus helped from the metformin, which has been approved today by the government of India for a very low dose, 250 milligram BD. And it is we are not medicalizing a condition of pre-diabetes, but it definitely helps in preventing 50% cases going into full diabetes. And we have the other examples of primary prevention. Those who do not have any pre-diabetes, these are also known. Those who exercise do not definitely stand a better chance not to get diabetes. And also secondary tertiary prevention in the rehabilitation and control of diabetes. Yes, Bharat, you were saying something.
To add one line, there are also people who are non-responders to exercise. So it has been seen, suppose somebody is not responding to aerobic exercise walking. So if it is not responding, then he can switch over to swimming, he can switch over to cycling, or he can switch over to resistance exercise. So there are also a group that are called non-responders to this exercise.
Absolutely correct. Non-responders do exist. And there is also a concept of exercise prescription. Now, exercise prescriptions become very popular. And if one is non-responders, one can go to the other. Dear friends, now it is 2:13, 2:14. We'll go to the next session, but not before I request Dr. Nilanjan. He started the discussion to give his closing remarks. Then we'll go to the next session. Nilanjan, all yours.
Yeah, so that was a very extensive session on exercise, and we got enriched with the talks of Dr. Nagesh and and the other lady. So
Archana Sadda.
Archana Sadda, with valuable inputs from Dr. A.K. Das and our two chairpersons. Of course, Dr. Alok Kanungo was there. So the bottom line is that exercise is something integral to the management of diabetes. We physicians write a prescription for medicines, but we often tend to forget writing a prescription for exercise or explaining that. We should take at least 2 to 5 minutes with the patient, explaining the need of exercise and what exercise the patient wants to do. And in certain cases, with comorbidities like orthopedic or neurologic comorbidities, we can also take help of our physical medicine colleagues who would be able to give better directions, better exercise, detailed exercise prescriptions to the patients who need them, and which I do in my practice. The three things that we need to know about or impress upon about exercise is the continuity and the regularity in doing the exercise, doing that safely. We have all talked about sudden cardiac death, but unaccustomed exercise can lead to orthopedic injuries, and that can lead to a situation that the patient is advised for rest, complete rest for 3 months. So, it comes to a full circle. You overdo in the beginning, ends up with an orthopedic exercise, and then everything goes for a toss. And not only that, exercise should be done with a proper footwear, proper socks, and in a proper environment, in an optimal temperature. Doing exercise in extreme heat or a sultry weather of 45 degrees Celsius should be avoided, or in extreme cold at the same time. The timing of exercise, because all cardiovascular events tend to occur more in the early morning hours. So it is probably, especially those who are more vulnerable, it is preferable to avoid the early morning hours for exercise. There's a myth that exercise is best done only in the morning. Actually, it can be done any time of the day, but morning being the most convenient one, we do advise them for exercise in the morning. But those who are vulnerable to cardiovascular events, we can even avoid the early morning hours for the exercise. So these certain small practical tips and practical knowledges imparted to the patients will actually help them derive benefits out of exercise, as much as we can think of pharmacotherapy, and at times, if not more. Means in early diabetes, or for the prevention of diabetes, a lifestyle modification containing of diet and exercise alone may be the only therapy that needs to be offered to the patient. So thank you very much for again making me a part. Thank you. Over to Dr. Kanungo and Dr. Ashok Das.
With permission, Dr. Bharat, with sharing the session, and Professor Alok, I thank everybody. I'll not take the names again to save time, but I'll also thank Utkal, who did a wonderful job in the interview. You agree with that? Wonderful job in the interview with Alok, Dr. Khadanga. It was great. And of course, the great job by all of you. Thank you very much. And I request crave the indulgence from the chairpersons, Bharat and Alok, to close the session. And I will like to invite now Dr. Eshan Swine and Dr. Alok Kanungo to go to the next session. Thank you. Thank you very much.
Thank you, sir. This session will be taken over by Dr. Surendranath Swai, and I will request Swayam Siddha, if you have joined, kindly join this session in place of me.
Swayam, are you there?
Yeah, I have joined, sir.
Yes,
I have joined, sir.
So you join Professor Swai, and both of you take over this session.
Surinder is the president of the Odisha Diabetic Association, the branch, RSD branch of the state. And Surinder, welcome. And you have been one of the Become Beacon Lights. Abhay, very delighted to meet you. Where were you? Thank you, Abhay. Thank you for joining the session. Delighted. You are indispensable. So Surinder is here, Abhay is here, and Swayam is here. And of course, Jayashree, the beautiful endocrinologist from the city of Odisha, and Jayashree, you are here. So handing over the session to you, will be in the background. Over to all of you to take this session forward. It's a very important session called the basal insulin, strong foundations. So over to the four musketeers headed by Professor Surendra Sain, the presiding officer.
Thank you, Professor Das. This is the 10th NUCD by the dynamic Alok Kanungo with their blessings and the coordination and the advice and the vision of Dr. Ashok Das, who is continuously supporting this NUCD adventure, and in the 10th year we are going. Thank you for this, giving me the chair. And today's topic is basal insulin, a strong foundation, helped by Sanofi Foundation. And today, so we are going to discuss different aspects of basal insulin. So basal insulin is the ideal one to provide steady peakless continuous insulin supply to system round the clock without risk of hypoglycemia, and insulin glargine is the first one in the series, and soon it was followed by insulin detamers and degludec. So insulin glargine is very popular. Then subsequently insulin detamers, both work onset of action within 2 hours and 24 hours around the work. And then degludec came and with the aspart combination, and then pegloticate lispro and insulin glargine of 300 units, then combination of basal insulin with glucagon-like peptide receptor agonist has come with liraglutide or lixisenaride. Now, the next topic is Dr. Abhay Sahu. Dr. Abhay Sahu, is one of the noted diabetologists and a popular diabetologist of the country, and in Orissa and particularly in Bhubaneswar, Abhay Sahu is very, very, very popular in home to home for diabetics treatment. And he is now the super consultant in Apollo Hospital and ex-head of the department of IMS and some medical college, some hospitals. So without spending much time, I invite Dr. Abhay Sahu. The topic is timely concepts advanced in basal insulin therapy. Dr. Abhay Sahu.
Tell me one word, Chairman Sir, is that one of the earliest endocrinologists from the city of Odisha. And as an endocrinologist,
Sir,
Abhay, please continue.
yeah. Sir, am I audible, sir?
Yes.
Yes.
Yeah. Thank you, sir. Thank you for your kind words. And now we'll discuss the topic about the basal insulin, timely concepts, advances in the basal insulin therapy. So, as we know that if we'll discuss glargine U300, then the most important thing is it is right balance of efficacy with low risk of hypoglycemia. It has low risk of hypoglycemia during the titration period, because we know that the titration phase is the phase where actually we starting or we're giving insulin from the initial part. If patient develops hypoglycemia within first few weeks of initiation, probably their motivation comes down, and a lot of the time they discontinue insulin. So as we know that this glargine U300 produces less hypoglycemia during the titration phase, that gives advantage to the patient. Third is it reduces the risk of nocturnal hypoglycemia. It is one of the best important fact. And also there are lower risk of hypoglycemia, even if high risk population, those are elderly population, those are having CKD patients, still they have risk of hypoglycemia is too less. And there is low risk of hypoglycemia with comparison to premix insulin or co-formulations. It has flexibility in administration at any point of time, plus minus 3 hours. Again, the injection which is used is actually absolutely painless and gives very less volume of insulin. That again, the pain point of view is quite significant. People see the evolution of basal insulin, as already Sir has discussed. The NPH was the first insulin which came to the market in 1946. Then among the long-acting insulin, glargine is the first in 1992. Then detamers came in 1996. Then in 2010, degludec came, and glargine U300 came in 2011. If you'll see the PKPD or comparing the different type of relative actions of different insulins, probably NPH has a peak. And if you compare NPH versus detimir, probably the peak is less and the effect is close to 24 hours. So it's absolutely not truly 24 hours, but close to 24 hours in detimir. If you will compare detimir with degludec, probably it is truly basal, that is absolutely peakless insulin, and the effect is remaining more than 24 hours. Same thing is happening with glargine U300, which is absolutely peakless insulin, with particularly having a effect for more than 24 hours. If we'll see what is this compact glanule, we will compare between glargine 300 versus 100. The advantage is in 300, you are reducing the volume up to 1/3. That means the total volume is 1/3 of the glargine U100. Since it is giving very compact and the area is very small, so the absorption will be very, very slow from that part. And again, we know that since the absorption is very slow from the subcutaneous depot, then it produces very actually slow onset of action and truly effective insulin duration for 24 hours. What are the advantages? Once we are shifting to that, the advantages is it has full day recovery. It is given once daily injection. It reduces hypoglycemia. It reduces weight gain. It has better adherence. It improves quality of life and patient satisfaction. And again, dosing independence of meal time, because as we have discussed, it is almost actually plus minus 3 hours you can give once you are discussing about glargine U300. Again, what are the reasons? What are the advantages? It is stable and prolonged PKPD profile, quite effective up to 24 hours. There is, besides having dosing flexibility of plus minus 3 hours. There is low risk of nocturnal hypoglycemia, as well as 24-hour anytime hypoglycemia. Then there is lesser fluctuation and even if more even distribution in the pharmacokinetics and pharmacodynamic profile. It has lesser weight gain. When we are giving this injection, the injection force in the pen is too less. It is very lesser force. And it is available both as a disposable and also reusable pen. So these are the certain advantages of particularly glargine U300 when we are discussing or prescribing to the patient. We have a lot of ample of data. If you see PKPD studies already is there, and RCTs, addition is from 2 to addition is actually RCTs. Among the real world data, Deliver and Atos are the real world data. Among the type 1 patients with high risk hypoglycemia, again, RCT is there, the real world data RCT is there. For the patient experience, again, real world RCT is there for PKPD. And a lot of studies are there particularly to just tell or to give us confidence that glargine U300 is quite safe and quite effective, having less risk of hypoglycemia and less weight gain. And if you see as it has over a concentration and glucose infusion rate profile after multiple doses of steady state, you see glargine 300 versus 100 given 0.4 unit per kg. U300, that is the green part is U300, which has clearly shown it has more stable and prolonged duration of action with the PKPD of glargine U300 is comparable with U100, but having very less peak or actually in comparison to U100, it is absolutely peakless. People see what are the chance of hypoglycemia. Anytime hypoglycemia on the left side and nocturnal hypoglycemia on the right side, which has clearly shown you take anything confirmed hypoglycemia of less than 70 or confirmed hypoglycemia of less than 50, all are favoring glargine U300 in comparison to glargine 100. And again, if you are taking nocturnal hypoglycemia, that also both are favoring glargine U300 in comparison to glargine 100. So what are the populations where we can give in type 1 diabetes and in type 2 diabetes? In type 1, we have addition 1, addition 2, addition 3, and addition JP2. That is in the addition JP is in the Japanese population. The addition 1 is with basal bolus. Addition 2 is basal insulin plus OHA. Addition 3 is basal insulin, insulin naive patients who have given basal insulin plus OHA. And addition JP is also basal insulin plus OHA in Japanese population. Whereas in type 1 patients, we have addition 4 where we have given basal bolus therapy. And addition JP1 is the Japanese type 1 patients where basal insulin plus mealtime bolus insulin among the Japanese patients. So what we have found, all those studies has clearly shown that if we take over a period of 12 months in comparison to glargine, the weight gain is less, or there is a 400 gram less weight gain in glargine U300 in comparison to glargine 100. Again, if we compare glargine 300 versus 100, the nocturnal hypoglycemia or anytime hypoglycemia, again, both are actually favoring glargine U300 in comparison to glargine 100. So it has more sustained or equal HbA1c lowering properties with comparable less weight gain and with comparably low risk of hypoglycemia in comparison to glargine U100. Again, ATOS is a study which is real-world effectiveness and safety of glargine U300 among the insulin patients, which has clearly shown that in ATOS, 1 in 3 patients were from India, 25% patient achieved HbA1c target within 6 months, and 45% patient achieved HbA1c target within 12 months. What they found? That there is a HbA1c reduction of 1.87%. The fasting has come down, SMBG has come down actually 65 milligram per deciliter. Then the documented symptomatic hypoglycemia was 0.13%. And there is weight is very, very minimally changed over a period of 12 months. And also there is low means of change in the insulin doses. These are lowest least changes, particularly with those who are given this. Again, if you see the HbA1c lowering property from the BRIGHT study, BRIGHT has clearly shown that in comparison to the baseline, the HbA1c lowering property at 12 weeks and also at 24 weeks is almost similar in glargine versus degludec. So it is a comparison with degludec. Both are having equal HbA1c lowering properties. But if you'll see the from the hypoglycemia point of view, as I have clearly shown here in this slide, that during the titration phase, the hypoglycemia is found to be significantly less in glargine U300 in comparison to the degludec group. So again, that clearly shows that probably during the initial 12 weeks, which is considered as the titration phase, that in that phase actually the high risk of hypoglycemia or it favors glargine U300. Again, if you see the nocturnal hypoglycemia, that also it favors particularly this glargine U300 in comparison to the degludec. So hypoglycemia is found to be less. Again, as I have already shown that. So the titration period predicts a long-term outcome in the maintenance period, because we know that the initiation, during the initial phase, if any patient develops any sort of severe hypoglycemia, well, this develops some sort of fear in their mind, and continuation or continuing that insulin for a long period is sometimes hampered, and they a lot of the time they discontinue insulin, they miss few of the doses of insulin, and that is one of the biggest reason of increasing the HbA1c level, uncontrolled blood glucose level, and leads to complication level. So the titration period predicts the long-term outcome in the maintenance phase. More than 80% of the maximum treatment effect occurs in first 12 weeks during the initiation phase. A early response predicts a long-term glycemic control with 12 weeks HbA1c level maintained up to 24 weeks. The early hypoglycemia doubles the risk of future hypoglycemic events, and also early hypoglycemia increases the risk of treatment discontinuation, as I have already discussed. So that shows probably in that point of view, probably glargine U300 is superior than also even if degludec insulin. Again, what BRIGHT has shown us that if you take a cutoff of less than 70, the incidence of anytime 24-hour hypoglycemia is reduced by 26%. If you see cutoff of 54, then the incidence of anytime 24-hour hypoglycemia is reduced by 37%. And if you take the then event rate of anytime hypoglycemia reduced by 23%, event rate of nocturnal hypoglycemia reduced by 35%. So a early hypoglycemic event during titration phase are associated with increased rate of treatment discontinuation as well as long-term hypoglycemic risk. And glargine U300 offers that benefit of less hypoglycemic events during the initial 12 weeks, and that actually ultimately translates with increase in the blood, in better blood glucose control and improvement in the HbA1c level. So use of glargine U300 in renal impairment patients, if you see the Edison one, Edison has clearly shown they have comparable HbA1c reduction versus glargine U100, but the risk of hypoglycemia is 19% less. Again, Deliver has shown comparable HbA1c versus glargine U100, but the 27% less hypoglycemia. But BRIGHT has shown that effective HbA1c reduction across eGFR of different groups in comparison to degludec 100 without increasing the risk of hypoglycemia. And ATOS as again shows the risk of hypoglycemia is very, very less, but the reduction of HbA1c is up to 1.9%, which is quite significant among the CKD patients. So in the renal impairment patients, particularly glargine U300 is found to be quite safe. Again, use of glargine in the elderly patients, again, another high-risk patients, Edison has shown comparable HbA1c reduction with 18% less risk of hypoglycemia. ATAS has shown a robust HbA1c reduction of 1.8% over 12 months with a very low incidence of hypoglycemia. BRIGHT, greater HbA1c reduction with comparable risk of hypoglycemia with degraded 100. DELIVER is showing comparable HbA1c reduction with glargine U100 with a 48% lower event of the hypoglycemia, and that is the important thing what actually has shown from the elderly point of view. So again, let us see glargine U300 versus premixed insulin. This is a RCT of insulin-naive adults of type 2 diabetes who were inadequately controlled with OHA, received either glargine U300 or premixed insulin. They have taken from the systemic literature reviews. Close to 6 RCTs who is taking to 3,300 type 2 diabetic participants, either given glargine U100 or premix, were eligible for this actually for this study, and to comparing this study compared to the premix insulin in this study. So what they found, that glycemic improvement and body weight changes versus premix insulin. If you see the HbA1c is 0.13 better reduction. If you see in final insulin dose, it is 1.31 more units is required. And if you see the weight gain point of view, there is a weight loss upper in comparison to premix. There is 400 gram less weight gain in particularly glargine group, in glargine U300 group in comparison to the premix group. Again, that if you see that all 24-hour hypoglycemia and 24-hour confirmed hypoglycemia, both are favoring glargine U300 in comparison to the premix, as I have already shown. So this is the thing what I have clearly shown. The incidence rate and event rate both are found to be significantly less in particularly glargine U300 group in comparison to the particularly in the their premix group. Again, here in this study, glargine U300 was actually compared with particularly IDEGASP. This is again the RCT insulin type 2 diabetic patients not controlled with OHA. They received either glargine U300 or the IDEGASP, and they have taken from the system review, and this meta-analysis was conducted, and what they have shown that HbA1c is almost similar. There is in both the groups, there is no differences there. The final dose of insulin, again, there is similar. There is no differences there with a p-value of 0.4. But that is the beauty that despite of similar HbA1c reduction, despite of equal amount of dosing of insulin, still the weight gain is higher in IDEGAS group in comparison to glargine U300 group, or in glargine U300 group gained 1.3 kg less in comparison to the IDEGAS group. So that's, it seems that actual weight gain is found to be significantly less with this IDEGAS group. Again, this is the study all 24-hour hypoglycemia, 24-hour all 24-hour hypoglycemia, and also nocturnal hypoglycemia. If we take together, probably the event rate will be different for particularly glargine U300 point of view. Again, glargine U300 and IDEGAS, the low risk of anytime and 24-hour confirmed hypoglycemia. Its efficacy was clearly shown that in among the insulin patients of type 2 diabetics who are inadequately controlled on OHA, commencing glargine U300 shows a comparable HbA1c reduction with a significant less weight gain and lower incidence of any time of confirmed hypoglycemia compared to the IDEGAS group. Again, glargine U300, if you see the CGMS or TIR, then this is the studies RCTs type 1 diabetics, in range, one care, glargine U300 versus IDEGAS, the HESL. We have ample of studies which has clearly shown that, particularly from the CGMS point of view or time in range point of view, they are also quite beneficial, or they gives a significant chunk of people to remain in TIR range. And again, the dosing flexibility point of view, as I have already told, there is a plus minus 3 hours of dosing schedule there. Despite a schedule of 6 hours gap, still the PKPD is well maintained within the, there is no difference, even if we are giving the same time or there is a gap of up to plus minus 3 hours, same level is being maintained in the blood. And again, from the pregnancy update, that Levemir is updated in India, particularly pregnancy point of view. Levemir is given in 2022. Treatment with Levemir can be considered during pregnancy if clinical needed. From the Lantus point of view, Lantus can be used during pregnancy if clinical needed. Tresiba, again, this is the recent level of update that from 19 to 19 1 year back, that the treatment with insulin degludec may be considered during pregnancy if clinical needed. And from the Toujeo point of view, again, Toujeo can be used during pregnancy if clinical needed. So again, as we have clearly discussed from the pregnancy point of view, all Levemir, Lantus, Tresiba, and Toujeo all can be safely used in pregnancy as from the mandate from particularly our country. And as I have already discussed, the device is quite easy to handle. And force what we usually classically give during the injection is too less, and that actually makes the person feeling a sense of easiness in while using this. And it is a dedicated cartridge of 450 units. So cartridge is pre-assembled in the cartridge holder. Clear-cut dosing display will be there. And it is a simple dose delivery, that is short dial extension, less injection force, non-rotation dose button with injecting, and 5-second holding time is for particularly this this pen. So summarizing my topic, it is effective and sustained glycemic control is utmost important. It is safe during titration and maintenance phase. There is lesser overall and nocturnal hypoglycemia. Weight gain is very minimal. It has a stable and prolonged action, and also it has a flexible dosing up to ±3 hours. Thank you.
Thank you, Professor Rawai, for your excellent deliberation with examples of different situations, how it should be delivered, and how is it disposed, and how to give. These are all very elucidated and very helpful for the clinicians to know how this 300 can be used in cases of different stages of diabetes. Now, I think we'll go to the second topic, and our discussion will be at the end. So the second topic is flexibility of basal intensification by Dr. Jayashree Swami. Jayashree Swami is a professor of endocrinology in IMS and some hospital. And I think by now everybody knows Dr. Jayashree Swami because of her presence in American College of Physicians and everywhere now. And the National RSSD also spoke nicely also. So let us not delay, and let us start. Flexibility of basal intensification, Dr. Jayashree.
Good afternoon, everybody. Thank you, sir, for the nice introduction. At this outset, I would like to thank Dr. Alok Kanungo sir and Ashok sir for giving me this opportunity. Let me share my slide here. Just a minute.
Just you can stop share and then start sharing.
Sir, it's not it's from this desktop.
Have you opened your PPT?
ଆପଣ ଆକେ ଓପନ୍ ସ୍ଲାଇଡ୍ ଓପନ୍ କରନ୍ତୁ
Sir.
ସ୍ଲାଇଡ୍ ଓପନ୍ କଲେ ଏବେ ସ୍ଲାଇଡ୍ ଓପନ୍ କଲେ ତ ଏବେ ସ୍କ୍ରିନ୍ ଶେୟାର କୁ ଯାଆନ୍ତୁ ସ୍କ୍ରିନ୍ ଶେୟାର କରନ୍ତୁ ତଳେ ଯୋଉଟା ଶେୟାର ସ୍କ୍ରିନ୍ ଆଣନ୍ତୁ
Sir.
Bas, now it has started.
Thank you, sir.
Wow, very good.
Sir. Good afternoon, everybody. Once again, sir, my topic is regarding the intensifications of the basal insulin. So, in a type 2 diabetes, when to consider insulin in type 2 diabetes? Number one situation, when A1C level is above the target within 6 months of despite dual and triple combinations, and when the patient is having sarcopenia, cachexia, and chronic infection, or the early manifestations of the diabetes related complication, or the patient is having subgroup of these patients, those who are having severe insulin deficiency, that means young and lean patient, and the last is patient is having uncontrolled glycemia or osmotic symptom. These are the group of these patients. They need insulin even if they are the type 2 diabetes. Then next questions, which insulin and which regimen is appropriate for them? If you look to the premix insulin, we have premix insulin and basal insulin. If you look to the premix insulin, there is higher risk of hypoglycemia and more weight gain, and higher insulin dose is required for this premix insulin. But it has been seen in different studies. The basal insulin is simple and flexible, low risk of hypoglycemia, better treatment satisfaction is seen if you initiate with the basal insulin. So basal insulin regimen is an ideal to start with in type 2 diabetes. So there is lots of evidence in the past 2 decades regarding the efficacy of the basal insulin. All are with the analog, long-acting analog insulin, that is glycemic target achieved with the basal insulin. In spite of this baseline A1C, it's more than uncontrolled glycemia, more than 8.5 or 9. And there are lots of studies, mainly Insight, Triple T, Apple, Laptop, Triple, LearnMed, and L23, and so many other studies. But all the studies are with glargine insulin hundreds, and it has been seen from all the studies, glargine 100 effectively control and reduces this A1C level less than 7.7% in type 2 diabetes patients. Those who have this baseline A1C above 9 or are equal to this 9. So as we all know, this basal insulins, it suppresses the hepatic glucose output and it has a good effect on the fasting glucose control. But the thing is that fasting and postprandial both contribute to this A1C level. And if you look to the A1C level of 8.5 to the 9, these contributions of the fasting and postprandial blood glucose is somehow more or less equal. But when this postprandial blood glucose increases, when the A1C increases, this postprandial glucose increases simultaneously. So, for the control of a postprandial hyperglycemia is essential for achieving this recommended targeted A1C goal. But the common problems, there are so many problems or challenges while achieving the glycemic goal by controlling this A1C. There is a good study published in 2012 with more than 500 patients, which shows that the most patients, around 7 to 8% are mono, and that around 7 to 10% of these patients, they are facing the difficulty in timing of the injection, and some of these patients, they are feeling embarrassing at injecting the insulin in public, and 15% of the patients, they skipped their meal, 16% of the patients, they are traveling each and every day, and 18% of the patients around, they are too busy. So what is the lesson learned from this study? The message from the study is that the flexibility for this basal insulin is required for a good for adherence of the insulin, so that we will achieve a good glycemic control. And if you look to these guidelines, ADA 2022 guidelines or any other guidelines, basal insulin you may initiate to start with, or 0.1 to 0.2 units per kg per the day. and we will target our fasting, and we will titrate, increasing 2 units every 3 days. And after good titrations, if you are not able to achieve this A1C, that means when you are giving basal insulin in the dose of 0.5 unit per kg per day, still you are not achieving your target A1C, then it is the time to add pandrial insulins. Then pandrial insulin in the dose of 4 unit per the day, or this 10% of the basal dose may be the starting dose of the pandrial insulins, and you may titrate this dose 1 to 2 units or 10 to 15 may down titrate your basal dose by 10 to 20%. This is what has been given by the ADA 2022 or any other guideline. It is the time to start this prandial insulin when you have not achieve your A1C after the adequate amount of the basal insulins. Next point is this is the pillar. As we know, type 2 diabetes is progressive beta cell deterioration is there. This is the pillar to start how to start the basal insulin. First, you will go for the basal insulin. After that, basal plus, and then if A1C is not achieved, basal bolus. Then coming to the concept of the basal plus, and it is one of these major meal gives the highest peak, and it contribute to most to the rise of the postprandial blood glucose. If you target this rise, the single dose of the prandial insulin will cover the major contributor of the postprandial glucose in a most flexible and physiological way, so that we will achieve our good glycemic controls. As you know, in type 2 diabetes, the first phase of the insulin secretions is deranged, so we have postprandial hyperglycemia. Along with that, we are very fond of taking carbohydrate diet, and we are remaining most of the period we are remaining in the postprandial hyperglycemia. So good glycemic controls for achievement of this targeted A1C, we should have this prandial control, along with that the basal insulins. In that context, for prandial control, we have regular insulin, regular human insulin, and regular analog insulins. If you look to the regular human insulins, there is great more variability is there, and chances of postprandial hypoglycemia is there, and in particularly in CKD patient, they are more susceptible for hypoglycemia. And this regular insulin is less consistent with a different anatomical site. Simultaneously, if you look to this rapid acting insulin, less glycemic variability, less chances of hypoglycemia, and it is suitable for the CKD patient. And if you look to the meal time compatibility, it can be taken 15 to 20 minutes after the start of this meal also. So this is the beauty of the rapid acting insulin analogs. In this category, we have glulicin, lispro, and aspart. So glulicin has a faster onset of the action when it is compared with that of the aspart, other regular rapid acting analog insulins, and it has early metabolic effect, early onset of the action, and faster absorption compared with that of the aspart that has been seen in the healthy volunteer. So this area under the curve, that is a twofold higher, greater in the glulicin group when it is compared with the aspart in that healthy volunteer. If you look to the type 2 diabetes, those who are obese, here there is also one study which shows that the postprandial blood glucose is lower with glulicins in obese type 2 diabetes patients, and this is beautifully described in this picture. So next, coming to the glulicin versus the lispro, and that is it is also better insulin concentration seen in the glulicins when it is compared with that of the lispro in type 2 diabetic patient. So another point is that when someone is with the basal insulin with the glargines, and for prandial controls they are with the aspart, lispro, or the regular human insulin, by switching these patient, this prandial insulin, lispro, aspart, and regular human insulin to that of the glulicins, This group of the patients, they decreases A1C further by 0.3%, and their improved treatment satisfaction both in type 1 and type 2 diabetes mellitus. So switching from that other insulins, both conventional and regular insulin, to these glulicyl insulins have a better efficacy and treatment satisfactions. So this has been seen in the real world evidence study, namely IGLU-S, and it is this prospective observational study for those who are evaluating the efficacy, effectiveness of glulicins after switching from that human insulin or to diabetes. Then what is the result of that study? At the end of this study, there is improved effectiveness of with the 43% in type 1 diabetes and 36% in type 2 diabetes, and they achieved this predefined A1C target within 1 year, which is beautifully described in these bar diagrams. And other aspects, safety concerns of this study is that there is no case of this severe hypoglycemia is seen in the glulicin group. And another important thing is that confirmed symptomatic hyperglycemia is seen in 5% of the type 1 diabetes and 1.6% of the type 2 diabetes. So by switching from other group of insulin to switch to these glulicins, there is good glycemic controls, reduction of the A1C by 0.3%, and treatment satisfaction is there, and without significant adverse effect. This was the pre-mix regimens. Here I like to quote all to target study. They compared the pre-mix versus that of the basal plus, that means basal and 1 dose of the glulicins. So what is the result of that all to target study? The more patient reached the target A1C in the basal plus regimen as compared to the premix regimen. And in other aspects, the more patient had hypoglycemia with the premix insulin when compared with that of the glargine-based regimen, which is basal plus. So it is beautifully described by these bar diagrams here. So this another important aspect is that in multiple regimen, what I have discussed till now, it is the basal and basal plus. So coming to this study regarding the basal bolus regimens, particularly I would like to quote here another study, that is rapid 2 surgery. These are these type 2 diabetes patients hospitalized for this surgery. Multiple daily insulin injections with the glargines and glulicins, that it has been seen that wound infection, complications, and length of ICU stay is comparatively less or significantly less in glulicin group when compared with that sliding scale regular insulin. So the basal bolus, particularly glargines and glulicins, represent a simple and effective regimen for the management of patient with general surgery, the type 2 diabetes. Next, coming to that, another important data analysis of the recent 2022, that is the Person Register 2022, this real world data analysis, which it has been seen that if you prescribing basal plus regimen, the A1C reductions is in the tune of 0.7%. If you are prescribing basal bolus regimen, the A1C reduction is in the tune of 1.7%. So good glycemic control is seen with the basal plus and basal bolus regimen, which has seen from the RCT and the real world evidence. The next important thing is that glulicin offers maximum window of flexibility. The flexibility point we have discussed at the beginning of this study, which was published in the 2012. But here, if you look to this flexibility or this maximum window period of this glulicin, it is 35 minutes. But this window period, 15 minutes before the start of the meal and 20 minutes after the start of the meal. But that thing is not with the Aspart and Lispro. But in newer Aspart, there is some flexibility there with newer Aspart, but that is in the tune of the 22 minutes. It is less in comparison to the glulicin. So this is the beauty of this molecule glulicin, which have the wide flexibility. So most of these patients, it is suitable for those. So coming to the practical considerations of the basal of the MDI or basal plus, what is basal bolus or basal plus. When to stop titrating the basal and when you will add the prandial insulins. It is
So I guess there is internet connectivity issues.
sorry, sir.
Continue.
Can you use your hotspot
Yes, sir.
from the phone so that you get the net?
Am I visible?
Yes.
Yeah. Sorry, sir, for this interruption.
No problem.
So now it's only one or two slides. Now that is basal. Now the what is the regimen by which we will start the bolus insulins? So it is the fixed single. You can give the fixed single dose combination in the dose of the 4 to 6 unit that is administered in the largest meal or targeting to the largest postprandial rise of this blood glucose. Or the second option you may have postprandial blood glucose divided in milligram per the deciliter divided by 18 into 2, or you may give the 10% of this basal insulin, or the next option you may have 0.05 unit per kg of the day. These are the 4 options available for this prescribing a basal insulin, a bolus insulin to a type 2 diabetes patients. So coming to the end of my presentations, which there is max glargine and glulisin combinations. They have a good glycemic controls in various settings, and it may be this basal plus or this basal bolus regimen. And maximum number of these studies are with basal plus insulins with the glargine and glulisins. This study may be the Jopal, maybe the all to target, maybe 1 to 3 study, or proof to the concept study, and so many other studies. So maximum number of studies and evidence are with us with the glargines and glulisins. So it is most studied basal bolus combinations therapy. So to summarize my presentation, initiates a lower risk of hypoglycemia compared to the premix insulin. So basals, rapid acting and long acting insulin analog mimic the endogenous prandial secretions of the prandial and basal insulin, and basal plus is an effective alternative to the premix intensifications approach, especially in terms of the better safety and flexibility. So for any sort of these patients, glulisins and glargines may be a good option for the good glycemic controls, for the flexibility, for the safety concerns, and less risk of hypoglycemia. So thank you for this patient hearing, sir.
Thank you,
Over to you.
Mr. Jayashree, for your excellent deliberation of using glycine with glargine, a basal plus regimen, how it is effective, safe, and giving euglycemic result and reduction of HbA1c is much better than any other combinations. So thank you, Jayashree. Now we'll go to the next topic, Journey of Basal Insulin, by Professor Ashok Das and Jan Panda.
Please put Dr. Panda's slide again.
Okay. Dr. Jayant Panda, Professor Jayant Panda.
Yes, please introduce him.
Dr. Jayant Panda needs no introduction. He was professor and ex-head of the department of SC Medical College and is a consultant in diabetes, metabolic and critical medicine. And I think everybody knows Dr. Jayant Panda. So let us start. Dr. Jayant, Journey of Basal Insulin.
Thank you, sir. Actually, our interview is recorded, and I think RX event will play the record.
Yes,
I'm there to take up any queries.
Yes,
Welcome, friends. Here is another beautiful interview with a doyen in diabetology and internal medicine, Professor Ashok Kumar Das. All of you know that Professor Das is associated with API, RSSDI, and almost all diabetic associations in the country and abroad for more than 40-50 years now, and he has been a father figure in the country in the diabetology as well as internal medicine. He was in the JIPMER Puducherry, and at present he is a professor of medicine and endocrinology at Mahatma Gandhi Medical College at Puducherry and the academic dean of Sri Balaji Vidyapith University at Puducherry. Without much delay, we'll go to the questions directly. And we have Professor Das with us, who is a doyen in the field. And let us learn about the journey of basal insulin from him. My first question to Professor Das will be, do you believe in concept of fix fasting first?
I think, Professor Jayant, it's a great pleasure and honor for me to be there, to be associated with an interview of a very, very common insulin, most commonly used insulin, that is basal insulin. I'm delighted beyond measure. Thank you very much for this generous introduction. Jayant, I must tell you that fixing fasting fast is termed as a conceptually, it's called initial agenda. Initial agenda in the sense that while we start treating type 2 diabetes, it has been advocated, let us fix the fasting first. As you know, that it is also well known that if you bring down the fasting, along with that, the postprandial also comes down. And the blood glucose oscillations are mostly marked by the fasting glucose oscillations. Of course, there are also evidences like Honolulu trial and other trials that postprandial are also important. But the most important is the fasting. To bring it down first gives us the means to also bring down the postprandial. It automatically comes down along with the fixing fasting first. So it has been termed as the initial agenda of type 2 diabetes management with the basal insulin.
Rightly told, sir. That's why many school of thought prefer basal insulin to initiate. Unfortunately, in India, it has not been very popular. And today, we'll give an insight.
I'd like to add here that today, any guideline, you take, for example, from the ADA, EASD, IDF, even our own RSD guideline has advocated basal insulin to be used in the very beginning.
Yeah, guidelines speak about that. But in the common practice, we see that people stick to premix or stick to basal bolus. So what do you feel? Would basal insulin suffice in patients with a difference on fasting and postprandial of less than 180 milligram %?
I think it's a great question, and I'm very happy that you asked me the question. You know, there is a concept called capital B, small e, and A, capital M. That is BAM insulin difference. What does it mean? BAM insulin difference means the insulin at the bedtime while patient going to bed, and the next morning AM blood glucose. If the difference is more than 50, that is indicative that basal insulin alone is not enough, and we have to add a postprandial insulin. Therefore, it has been said that even though one can manage the insulin values by using basal insulin, one should not go for the over-basalization. Professor Jayant, it is very important to remember that we start with 0.1 or 0.2 per kg body weight. For a 50 kg man, we start with maximum 10 units, 0.2 units per kg body weight. Now, if we are using up to 0.5 to bring down the fasting blood glucose, and beyond it also blood glucose is not controlled, when you use 0.5 units per kg and you are not able to control the fasting, and you are still increasing, that's called over-basalization. Now, this over-basalization gives rise to poor control, gives rise to risk of hypoglycemia, and also risk of the weight gain. The advantage of basal insulin may be defeated. Therefore, when we have a difference of 50 or more, it is indicative of adding one prandial insulin, like you give a short-acting insulin, a prandial insulin. Therefore, that's the answer to the question.
So, rightly you have told, sir, the postprandial and the fasting and decision to start the basal insulin. So, and next I'll want to know, do we see the difference in management with the ultra long-acting basal insulins and long-acting basal insulins using CGM specially on time above range and time below range?
I think it is a great question, Jayant. You have asked a great question. You know, if you want to go through the journey of the basal insulin, I'll make a long story short by saying it started with the NPH insulin. NPH is a intermediate acting insulin, but we use it as a basal insulin. You know that, Jayant. And it has to be used many times, twice a day, but people use once a day. And antipotal, they can give either a long short-acting insulin or oral. Now, the crux of the matter that NPH is the initial basal insulin. It gave way to develop long-acting insulin, NPH insulin, like detamir and glargine. And detamir is a long-acting insulin with action between 18 to 30 hours. And the Lantus or the glargine insulin, which is the most commonly used insulin in our country, is an action of about 24 hours. In some population, like pediatric population, some population may have to use twice a day. Now, this is the long-acting insulin. When we say ultra long-acting insulin, Professor Jayant, I would like to make it clear to my audience that it is an insulin which acts for a very long time. The number one is the degludec, and this insulin acts for about 43 hours, 40 hours and beyond. And the other one is Toujeo, which acts for about plus minus 3 hours flexibility, but it also acts about 30 hours. Therefore, Jayant, the ultra long-acting insulins are the degludec and the Toujeo. Toujeo is a development beyond glargine, and the long-acting ones are detamir and glargine, and NPH is the basal, the first long-acting insulin. And if you use these ultra long-acting insulin, namely the degludec and Toujeo, as you rightly pointed out, and do the CGM, the TAR and TBR, the time above range and time below range is absolutely fabulous. We keep most of the sugars between the range that we want for the most of the time of the day.
So very rightly, you have pointed out that the ultra long acting insulin has a clear advantage, and the time above range and time below range are almost acceptable to many of us. Which population you think benefit most from the ultra long acting basal insulin?
I think it is a very fabulous question. You know, what is the advantage of the basal insulin? Number one, it is peakless. Peakless. There is no ups and downs, peakless. And ultra long acting insulins are really peakless insulin. Am I correct, Jan? Both
yes, sir.
and Toujeo real peakless insulin. Even though glargine also has term peakless, it might have a little bit of peaks. Number two, this is the insulin which acts round the clock, 24/7, when we give ultra long acting insulin. And it is and also very important to remember that it has a better efficacy than the ordinary long acting insulin. And also it is a really once a day dose. We don't have to give twice a day at all. And it is a better control. So if you ask me, I like to use this insulin for majority of the people who can afford it. When also you are giving a larger volume of glargine, you want to bring down the volume. The volume comes down by 3 times if you give Toujeo. Am I correct, Jant? So
Yes,
therefore,
sir.
you want to bring down the volume of the injection from glargine. You can change over to Toujeo. You can bring it down. Of course, beyond the volume, Toujeo has a lot of other benefits. The new insulin is not only 3 times glargine. It is a new insulin, new ultra long acting insulin. Therefore, I like to use this insulin for the people who can afford it, who really want peakless insulin. The control is very, very smooth. And I'll give another example. Now, sometimes the patients go in the hospital or in the OPD for investigation in the morning. The morning insulin could not be given in time. Am I correct, Jant? The patient has to go for investigation fasting. Patient comes back late. Here you cannot give long-acting insulin any time of the day. But this flexibility does exist with degludec and Toujeo. Am I correct? If you have not given in the morning, you can give it in the afternoon. What degludec has 40 hours of the flexibility. So you can give it in the afternoon. So patient does not need insulin. So the benefits of the ultra long acting are definitely beyond long acting, and therefore we must use it whenever patient can afford it. But about the efficacy wise, about giving the insulin for the common people, I think the glargine suffices, long acting insulin.
Rightly, you told, sir, the degludec and Toujeo is really peakless, and the hypoglycemic, especially nocturnal hypoglycemia incidences, are very less, and there is a flexibility of dosing. There are clear advantages over the long-acting insulins, but in a human premix market, we have already discussed that Asians, especially Indians, prefer premix because of the less number of pricks and the dosing pattern. The benefit, what are the benefit of the basal only therapy is a preferred initiator?
Great question. The BOT therapy stands basal supported oral therapy. Now, what is this basal oral therapy? Now, BOT, as rightly said, BOT therapy is the basal supported oral therapy. This is while we add basal insulin once you have started oral anti-diabetic drugs and advance for a certain time. This is otherwise also advocated what we call BIDS therapy, bedtime basal insulin, and daytime sulfonylurea. Sulfonylurea stands for any oral drug. Now, I would like to emphasize that in our country today, the maximally used insulin is this, along with the oral. Am I correct? Along with the oral.
Sir.
People take de novo insulin twice a day, thrice a day, basal bolus. But majority of the people do this BOT, basal supported oral therapy. That means they add to the oral therapy this basal insulin. What are the advantages? The advantages are the control becomes much more smoother and much more faster and much more strict. Number two, the requirement of the insulin is much less when you give it along with the oral. Therefore, the cost is less, hypoglycemia risk is less, and the weight gain is also much less. It has been also shown the blood pressure also comes down. And it is very convenient because, it is said, why do you impinge on the patient's autonomy? If you can do it one basal, why do you want to give twice basal? Am I correct? Therefore, this basal supported oral therapy or the BIDS therapy, bedtime insulin, daytime oral therapy, has stood out in our country as a very important way of therapy. Now, I must also add, yes, please.
Rightly, you have told, sir, because when we shift from the oral treatment to the insulin, there should be a phase where both the mode of therapy should be there. The basal supported oral therapy really controls well, and the patient acceptance will also be good. Patient knows he will have a one dose of insulin along with the drugs he is already continuing. So what could be done to avoid insulin use in patients failing 3 or more oral drugs?
I think this is the message which we gave from our landmark study. You were aware of that. That we had found in about 6,230 patients that people sometimes keep on increasing number of orals, beyond 3, 4, 5, and 6. It was shown in that study published today that if beyond giving 3 orals, it actually defeats your own purpose. The blood sugar HbA1c does not come down, rather becomes worse. Therefore, we have advocated to give maximum 3 orals. Whatever the 3 orals, which DPP4, sulfonylurea, SGLT2, you choose the 3. To add the 4th, 5th, or 6th oral is probably counterproductive. Therefore, when the 3 orals are not effective, if you have not changed earlier, one has to change over here for definite purpose. Professor Jayant, I'd like to tell you one thing, that we have in our country 2 problems. Number one, we start insulin late. You know that. Average years of insulin, we are behind 7 years. You should have given us at least 7 years before. Not only in India, many countries, even in the United States, we start insulin late and intensify still later. Once we start with 10 units or 15, 12, 14, 15 units, we don't intensify. We don't monitor the sugar correctly and intensify. Therefore, this is a great occasion to say that you can start low. These basal insulins are very safe. They do not produce hypoglycemia, do not produce weight gain, very smooth control. And at right time, you should start. If you have not started the right time, then at least when the orals are failing and 3 orals are not producing the result, you must change over to insulin.
Very right, sir. After failing 3 oral drugs, there is no meaning in adding 4th, and there should be plan for at least addition of a basal insulin therapy. Then another very noble concept of combination of insulin with GLP-1 agonist. Which are the kind of patient we use in this combination and why?
I think it's a great question. The basal insulin are used in multiple ways. You rightly asked me about the BOT, basal supported oral therapy. Basal therapy usually once, sometimes as we discussed some time back, we can use glargine even twice if necessary. Then third issue, we can give basal plus. We give basal in the night. We give a rapid acting insulin in the morning, Aspart or Orpidra or glulysin, whatever we give in this. So that's called basal plus. And the final is the basal bolus. When you give one basal, and with each meal, we give a bolus insulin. But the question you have asked is the most latest advance in the combination of the basal insulin plus the GLP-1 RA. Jayant, I would like to add the purpose of adding a GLP-1 RA to basal insulin are manifold. But what has attracted me most are 2. Number one, there is no weight gain, rather there's weight reduction because GLP-1 RA drugs are weight reducing. Number 2, there is no even an iota of hypoglycemia. Number 3, 4, and 5, it is cardio-friendly. We call it cardioprotective. GLP-1 RA is nephro-friendly. We call it nephroprotective. Renoprotective, we call it, and it also takes care of the NASH, of etc., along with the glycemic efficacy. We have 2 preparations in the country today. We have the Iglar-Glixi, which is introduced by Sanofi. We also have Ideglira, introduced by the Novo Nordisk company. So this combination of basal with a GLP-1 RA is order of the day in people who can afford it to give it, because it takes care not only of glycemic efficacy, it also has cardioprotection, renal protection, the NASH protection, and of paramount importance.
And along with that, weight also can be reduced.
That's maximum benefit. You're absolutely correct. The weight reduction or weight reduction or the protection, not to gain into the weight. It's weight reduction which is paramount important. Today, in today's world, the diabetes and other NCDs, whether hypertension, coronary disease, the driver for these NCDs are overweight. So this takes care of it. You're absolutely correct.
Nicely you have described, sir.
Or Ideglira are wonderful.
Yeah, the combination of GLP-1 and the insulin.
Basal insulin.
And now regarding the devices,
Yes.
we prefer prefilled syringes over vials. You know, it's almost prefilled syringes has replaced vials. So what are the disadvantages of vial, you think? And really, is it needed that will promote the prefilled syringes?
I think this is $1 million question. You know, people prefer pre-filled syringes and carrying it in the pocket. There are 4 distinct advantages, Professor Jayant. Number 1, it is more convenient. The less painful, the needle is called hair prick. It is as thin as a hair, 0.4 millimeter. Just imagine 0.4 millimeter. It's called a hair prick, not needle prick. So more convenient, less pain. Number 2, it is the patient directly gets it, early goes into circulation, and also easy to carry and easy to transport. You can transport in a pocket. You don't need any ice box and all that. The disadvantages of the vials are that you have to overfill it. You know that because some amount goes in waste while you give the vials, because while you load it in the syringe and vials, you have to discard something while we're discarding the air bubble, and lot of insulin wasted in the pen fill. That wastage is zero. There's no wastage at all. Number 2, vials is little inconvenient to carry. Some people view it as a social stigma, Professor Join, to take out the vial and this needle, draw it and take it. Whereas one can just, while you're sitting in the classroom, you just put it and you can take it over the pant. Just put it, and it is very convenient. And also people like it. I remember that particular Hindi song, "Pahle Kyun Nahi Mile." People come back and tell me, "Sir, why didn't you start me on the pen fill from the very beginning? Why did you give me vial and syringe?" So that is the type of demand people have.
Sir, as rightly you have told, this penless injectables and a very smart way of delivering the insulin, it has become very popular, and that's why people prefer prefilled vials. Then we'll come to different kind of population and the basal insulin. First, I'll like to know about the basal insulin in hospital setting, including the critical care setting like ICU setting.
Yes, it's a very great question. People have a feeling that this drug has to be given in critically ill patients in the hospital. But it has been proven to the world that basal insulin, basal bolus insulin, basal plus insulin, all the avatars of basal insulin administration can be done in hospital setting. In fact, Professor Jayant, I must tell you that in the hospital today, the injection of basal, either once a day or twice a day, or giving basal bolus has become very popular. In fact, I just give an example, Jayant. You treated so many COVID. You have been the pioneer for our state. You have been the state task force chief. You know that it is very important to remember that in COVID time, what did we give? We gave basal bolus. Am I correct? Basal bolus was the order of the day for COVID with diabetes mellitus, and that saved many lives. Therefore, I'm very passionate to mention not only COVID, for every type of illness for which a patient is admitted inpatient, the basal bolus is the drug of choice. Therefore, it can be used absolutely correctly in the less ill patients, not critically ill patients in the hospital or also outdoor. At the same time, critical ill patients like COVID-19, we have a lot of experience. The basal bolus has turned out to be the best outcome, providing best outcome of therapy.
And then another group of patients, they require insulin and have to be on insulin therapy throughout or gestational diabetes mellitus. So what will be the role of basal insulin in GDM patients?
Important question. I think if you go to the DCGI guideline, the Director General of the Drug Control in India, DCGI approval, we have got approval for 2 types of insulin. We have got approval for the insulin aspar. We have got insulin detamil. But I will hasten to add, even glargine, the basal insulin, is used very, very largely, very, very widely for the GDM and pregnancy with diabetes. I must hasten to add, even though they have not filed, I think they have just filed application, the approval on the way. It can be used. I'll repeat 3 times. The glargine can be used, can be used, can be used. So we have approval for the aspart and detamir. We do not have approval for the degludec yet, but the glargine is used off-label, very maximally and very safe.
So it's time. And the last thing I'd like to know about the biosimilar vessels, because with proliferation of widespread of use of basal insulins, now we have biosimilar vessels in our market. So what is your opinion and your practice about biosimilar vessels?
I think my opinion is that I welcome them. You know, biosimilars are biosimilars in the efficacy, in their side effect, in their purity, and serve the purpose. No, but the glargine, which is from the innovator, like Sanofi, is the same price as the biosimilar from the other company. So somewhere we we do not have that price advantage, but very often we have price advantage also. Number two, this is called India manufacturing biosimilars for the whole world. Professor Jayant, as you're already aware of the fact that we provide biosimilars to the entire globe. So this providing a biosimilar at a very affordable price is a very welcome thing. I call it biosimilars provide 4 things. They are affordable because very often they are cheaper than the innovator. Very often. In this case, in the case of Lantus biosimilar, they may not, but they are cheaper. Number two, A is affordable. Number two, they're appropriate. We have discussed, Jayant, under your questioning, how the basal insulin is very appropriate for type 2 diabetes management. So this is appropriate. It is available, it is accessible. A. So biosimilars are affordable, appropriate, accessible, and available not only in our country, we provide to the whole world.
Thank you, sir, for that nice comments on the different aspects of the basal insulin. We are discussing the journey of basal insulin with Professor Ashok Kumar Das, a legend in the diabetology who has guided the whole world. And I'm sure after listening to this interview, your concept of the basal insulin will change and your approach will give benefit to millions of patients. Thank you, sir, again for your nice comments and interaction. With this, we'll end this interview. Thank you, sir.
Thank you. Thank you. Bye.
Thank you, Professor Jain and Professor Ashok Das, the doyen of diabetology, the legendary figure. Now we can go for the panel discussion, if the time permits, with Dr. S.S. Mangaraj as the moderator, Dr. Debarchan Jena, Dr. Ashok Das, Jayasree Swai, and Professor Abhay Sao in the panel.
So good afternoon, everyone. I think a lot of things already has been discussed in the preceding sessions. We had 2 nice talks and 1 beautiful interview in which Professor Das has summarized almost everything with regards to clinical care as basal insulin is concerned. But I think I would still ask some questions to Professor Das, sir, and Jayasree ma'am. So the first question would be, in your clinical practice, to Dr. Jayasree, in your clinical practice, usually how many OADs do you give to the patient before eventually choosing to shift your patient to a basal insulin?
Yeah, thank you. Thank you, Dr. Mangaraj. So in our practice, it is not shifting, it is additions of these basal insulins. We are, if you look to this type 2 diabetes patients in the Indian scenario, after 3 oral hypoglycemic agents, we are adding these basal insulins for a good fasting controls. But if A1C level is very high, and at this beginning, fasting and postprandial, both the blood sugar is high, so you can give you can go for this basal insulin at the beginning also. It is not that after so many oral hypoglycemic agent. You can start the basal insulin at the beginning also with the oral hypoglycemic agent if there is no contraindications. That is one point. Second point is it is the addition of the basal insulin. It is not this shifting of this basal insulin from the basal insulin. If you are want to shift these patients, nobody in our setup will agree for that thing. For shifting, we need basal plus or basal bolus regimens. Only in basal insulin, no blood sugar will not able to achieve our glycemic goal. So practical aspect is that after 3 years, not only me, all these physicians or these endocrinologists, they are starting these basal insulins after 2 or 3 oral hypoglycemic agent. All thing depends on the scenario, patient scenario. Over to you. Thank you.
Now, my next question would be to Professor Das, sir. So, sir, I think you have beautifully elucidated regarding the clinical utility of basal insulin. So, my question would be on the same. So, personally, how would you categorize your patients regarding your decision to put them on either basal plus or basal bolus on patients who are currently on a premix insulin? So, which subset of patients you would like to switch over to basal plus or basal bolus, sir?
I think the premix insulin is very widely used, Dr. Swam, as you rightly said. But we would like to change over to basal bolus or basal plus because sometimes the premix insulin can produce hypoglycemia. And the people who are not going to take the insulin at the same time every day. And of course, we also know that the premix insulin cannot give that sort of control which comes from the basal bolus. It has been hailed all over the world that the basal bolus is the one which is the best way of controlling blood glucose. So if you want, in any particular case, because of complications, because of the issues that is ingrained in the patient's profile, that you cannot get the ideal control, we'll go to basal bolus.
Absolutely, sir. So I think we could take some inputs from Professor Swai as well. So, sir, my question to you would be, initiating insulin comes with a lot of baggages also from patient perspective. Like there are a lot of myths which are associated with insulin use, like addiction, hypoglycemia risk, lifelong therapy. So how you deal with such stigmas when initiating someone on insulin in your routine clinical practice?
When the patient comes, first we must advise for lifestyle modification. With the lifestyle modification, the start with, as usual, with metformin and other oral hypoglycemic agents. And suppose the HB1C is not controlled and there is a postprandial hyperglycemia, etc., then add basal insulin to the regimen. Because this adding basal insulin causing more fasting blood sugar in a most normal level, and as well also it reduces, in addition, the postprandial sugar level is also reduced. So early initiation of basal insulin along with the other drugs will give a good HbA1c control, good metabolic memory, and good glycemic index in that patient. So one should not delay to initiate basal insulin in a case and don't go heightening the number of oral hypoglycemic and their dosage and don't wait so long. Instead, add basal insulin. So correctly, as Jayasri told, you can also initiate as early as possible with basal insulin with 1 or 2 drugs so that euglycemia as early as possible will prevent the complications, having a good metabolic memory, and reduction of HbA1c will be good, and the blood sugar excursion will be normal.
Thank you, Professor Swai, for this extremely wonderful managing the show. And the talk by Professor Ashok Das was a classroom talk. We all learned so many things from that. Concept was very clear. Abhay was very good, and Jayasri gave a very nice talk. I invite Swang to take over and moderate the session. We have 25 minutes to go.
I think Dr. Devarchan has joined. So if he's here, okay. So welcome, Dr. Devarchan. So my question to you would be, if you are using a basal insulin along with oral antidiabetic drugs, what would be your choice of those oral antidiabetic drugs on which top of that you can add a basal insulin?
So thank you, Swam. Thank you, Alok sir, Ashok sir, Jain sir, for making me a part of NUCD. So my question, your question is which OAD combination is preferred along with basal insulin? So considering the multiple pathophysiological defect of type 2 diabetes mellitus, other oral agents can be continued along with basal insulin. First is metformin, which should be continued if there is no contraindication. And next, after metformin, we can add one DP4 inhibitor, which has secretagogue action on insulin. And also about SGLT2 inhibitors, if they are indicated and there is no high side effects, you can continue one SGLT2 inhibitor also. And for prandial control, you can add one AGI, that is alpha glucosidase inhibitor agent for prandial control also. And those who are on pioglitazone, you may down titrate or you may discontinue pioglitazone due to fear of weight gain or hypoglycemia. And last but not least, about the potent sulfonylureas, you can continue at a lower dose, or if the patient develops hypoglycemic episodes, you can discontinue sulfonylureas also. So considering the duration of diabetes and the presence of comorbidities, those who have long duration of disease and having comorbidities, in those group of patients, you can prefer one metformin, one DP4 inhibitor, and along with one SGLT2 inhibitors. And those group of patients which are of short duration of disease and they have not developed comorbidities or complications yet, in this group of patients, you can continue one sulfonylurea, one along with metformin and voglibose or acarbose, etc. So these are my preference of OADs along with basal insulin.
Okay. So my next question would be to Professor Jayashree. So once you have initiated your patient on a basal insulin, what is the clinical decision regarding up titration and intensification of that basal insulin or OADs for achieving the glycemic control?
Regarding that basal insulin, you may look for the HbA1c and fasting blood glucose. If your fasting is in the target range, the titrations, we all know the titrations. Once it is the 10%, 2 units every 3 days, or weekly twice, 2 units or 10% extra of the dose, or to start with the 10 units if you look to the start of the basal insulins. But thing is that I would like to go for the HbA1c and fasting. If fasting is in the good control and A1c is still above the target range, so in that case, I will think to titrate the oral hypoglycemic agents targeting to the meal postprandial rise of the blood glucose, or in that case, I may go for this basal plus. These are the 2 points in clinical practice, that is HbA1c and fasting blood glucose. Sometimes, if the fasting is in the target range and A1c is not controlled, in that case, postprandial blood glucose, I may go for the postprandial blood glucose. So it may guide us for the additions of the basal, additions of the bolus to that point, targeting to this highest postprandial rise or highest largest meal. These are the 2 points.
So next question would be to Professor Ashok sir. Sir, I would like to have your take on what do you been your clinical experience of using Glargine U300, the newer generation basal insulin, with regard to only two endpoints, their safety, with regards to hypoglycemic endpoints and efficacy?
I think, Swam, that's a very interesting question. I personally feel that the TUGO provides two things. Number one, smoothness of control and the flexibility. Now we have at least 6 hours of flexibility plus minus 3 hours, either way. Number two, the volume of the drug is also considerably less. It is 1/3 of the volume that we use when you use the Glargine. From these 2 points of view, this drug has stood head and shoulder above the ordinary Glargine. It has also stood above the other drugs like the Degludec and the other drugs which provides longer flexibility. Therefore, in my practice, the use of TUGO has been for 3 reasons. Number one, flexibility. Number two, volumic less, and for the smoother control.
Fine enough, sir. So I think we would all agree, and we have seen the presentation by Dr. Abhay, where he had clearly elucidated the addition trials and shown the safety efficacy of the molecule vis-a-vis insulin degludec, IDEC asp, or even Glargine U100. So
And
that
also,
usually
one point which also were very clearly shown that at least during titration, the hypoglycemia has been much less compared to the other long-acting insulins.
yeah, absolutely, sir. I think one more question to Professor Swine. Sir, your take on the behavioral and lifestyle modification prescription, which you prescribe to your routine patients. Your pulse of wisdom, which you tell to your patients so that they follow it on the long term.
In the behavioral pattern, in the lifestyle modification, it works very much because those people are unwilling, they should be motivated, psychologically counseled that their exercise is very much required and their diet control. The diet and exercise, the fulcrum of the lifestyle modification, which is the initial mantra for reducing diabetes in all sections of diabetic patients. So there, the psychological counseling, making it getting up, giving motivational speech and taking their mind and gradually escalation of their exercise module as like 5 to 10 minutes, as Dr. Khadanga was telling. So that is the rule, actually 10 to 15 minutes early, then subsequently gradually increasing every week 5 to 10 minutes. Then he will go to the actual 30 minutes or two or more than that, and 150 minutes in a week, which is prescribed, and with strengthening exercise and aerobic exercise and my muscle resistant exercises, you will go on. And diet control is one of the basic steps he must adopt, reducing the carbohydrates, the sugars, the cold drinks, this easy sugar available in the fruit drinks and all that. He should avoid and reduce, curtail his diabetic diet where carbohydrate will be lessened, increasing protein and fats and vitamins, and fruits, salads, and vegetables will be more, so that there is a balance between the diet and exercise, which is a motivation for initial starting a diabetic patient with drugs, or when the drugs don't work, or combination drugs with insulin will definitely reduce the diabetic pattern and the hyperglycemia and reduce the metabolic complications.
So a quick take from Dr. Devachan.
I just still one word that, our Professor Sanjipi Moses, SGPM, you know him. He used to say very important thing. He said that insulin is the only hormone which can be matched to the diet. I think we agree with that. That does not mean that you take more food, take more insulin. That is not the way. Way is that you can always adjust the insulin doses and it can be matched to the diet. Therefore, the diet plays a very important role, as Professor Swine has already said, in the diabetes therapy. And the second issue that we must always remember, that in all ages, all stages, the exercise and diet has a very important role to play. Whether one has got a CVD or one has got a renal affection because of diabetes, or for the negative point of view, if one has got a proliferative retinopathy, exercise is usually one has to be careful. Head lowering exercises are not indicated like Sirsasana. And so the diet and exercise swam, I will mention that has a role to play in every stage, with every complication of diabetes mellitus. It has a specific indication which has warranted. And I think that interview which Utkal gave with Alok was really revealing. And I was really surprised that the way that he has developed his aptitude for exercise therapy in diabetes, and I really congratulate him, congratulate Alok for bringing him. So therefore, it is absolutely fundamental, as Professor Swine said, to the diabetes therapy, diet and exercise from the very beginning till eternity. I won't say end, till eternity, in every age, every stage of the disease, and that must be adhered to.
Absolutely agree to that, sir. So my last question to Dr. Jena would be your take on premix versus basal. Which patient subset would like to choose for optimal glycemic control? You have many agents available in the market. So if you compare between premix agents versus basal, which subset of patients would you like to use basal or premix so that your glycemic control improves?
So using a basal insulin takes care of the fasting and the absolute prandial blood sugar level, but it doesn't take care of the post-meal peak, which is responsible for the cardiovascular complications in a diabetic patient. So for a complete fasting and postprandial control, you should prefer premix insulin. And our patients, they are taking a lot of carbohydrate, and also they have high PPG, and the complication in a long duration of diabetes, the complication and comorbidity are more, and the HbA1c, more patients have HbA1c of higher level, and those who need a total and tight glycemic control in this group of patients for a better quality of life, you should prefer premix insulin. And why should you prefer premix insulin? Because it is a time tested, and it is in use for a long period of time. We are using premix insulin, and they have a very good safety profile, and also they are highly effective in controlling fasting and postprandial, also HbA1c, and there is also added advantage of low cost, and for a average patient it is very useful, a premix insulin over basal insulin for a complete glycemic control and thereby preventing complication. So that's why I will go for premix over basal.
I think we had a wonderful session on basal insulin. I would like to congratulate Ashok sir, Alok sir, and Jan sir for having this beautiful session in the two exciting day of events. I think we are now closing on to the penultimate session for NUCD 2024. And one final word from Ashok sir and Alok sir with regards to basal insulin. Just a take-home message.
I would say that, I agree with what the Devarchan said, but we use it for the purpose of saying that since our physicians feel that they did not have enough of training tools to control, and they feel that giving the premix will be simpler because one can only monitor only one sugar. If you're giving in the morning, monitor the evening sugar, or giving in the night, morning premix, morning the fasting sugar, it may be easier to try. But across the guideline, Swam, Devarchan, whether it is ADA, EASD, or even our own RSDI guideline, the basal has been held as the initial therapy. Am I correct? But
Yes, sir.
RFGI says both. As you rightly said, the version from the Indian point of view, but otherwise, even our own RJ guideline, across the guideline, it is the basal which has been held in type 2 diabetes as the initial. But having said that, one size doesn't fit all. So wherever indicated, where you do not have the ideal monitoring of a basal plus or basal bolus, one can take recourse to that. The ultimate mantra is by hook or by crook or by hook and crook, you have to control blood glucose. Over to Alok. So I wanted your comment, Alok. At
Final take on basal insulin. Basal insulins have changed the way we are treating uh, diabetes for long time, and even pre-mixed came as a boom in the some time when, as Professor Das has already told, that where monitoring is a problem, pre-mix was the choice. But basal insulin is more scientific, and now developed basals have come like Glargine 300 or Toujeo and other things. Quality of life is much better with Glargine 300 or Degludec and all those new basals. And once they are available, and since the insurance scheme is available to almost 90% or 100% people of the state, now drug cost will not be a big problem or a challenge. BSKY or Ayushman Yojana and all those things provide better quality of drugs to people. So I'll prefer basal bolus or basal plus therapy or co-formulations with basal and short actings. So that solves the problem. Premix has a place with the mass. I don't deny that, but available facilities are in favor of basal insulin alone.
No hypoglycemia, no weight gain. Very safe
Yes.
and very simple.
Devarchan, we don't disagree with you, but this is the thing. You give Toujeo and forget it, and if you give Glargine and you forget the patient, he will never give you hypoglycemia, get hypoglycemia.
Yes, sir, I
So, and in type 1 diabetes, we cannot give premix, and we should not give premix. So, those are the things, and let us call it a day with basal insulins. It was an excellent session. Thank you, Soeng, for doing this so wonderfully well. Professor Swai, Professor Das, Joyasri ma'am, Dr. Abhay Sahu, Dr. Devarchan, everybody was great. Thank you.
Thank you, sir.
You will pass into the next session. Over to Alok to go for the next session. It is
Please call Devashish.
Devashish, are you there?
हाँ सर नमस्कार.
Namaskar, Devashish. Good. You are our light, the beacon light for the technology.
सर नमस्कार. Happy New Year. जय जगन्नाथ.
Happy New Year. Jai Jagannath.
स्वाई सर नमस्कार. जय जगन्नाथ.
So I will hand over to Devashish to do the context setting, because he is the man for the technology, go-to man for the technology in diabetes, and has been the pioneer in the pumps, had been the pioneer in the Medtronics, has also modified the way Medtronics looks at India. And also today he is India, tomorrow he is in Singapore, next day in Malaysia, next day in the United States, carrying on the work of technology in diabetes. Over to you, Devashish, to set the context. And we have wonderful people like Devashish, Jyoti Dev, Jyotdev Kesakdev, Manoj Chawla, Bansi Sabu, authority on CGMS. And we have Arvind Gupta, we have Rajiv Chawla, and we have Rajiv Kovil. So with these words, over to Devashish to carry forward this session. I'll be there.
Thank you, Ashok sir. Thank you very much. I again welcome all the attendees who are watching us on this platform. And as Dr. Ashok sir said, this is the technology session, and all of us know now technology is a part and parcel of our life, whether it is medicine, whether it is just ordering any food or making movie tickets or booking air tickets, anything. Now technology is part and parcel of life. So technology, so medicine is also not very far. I think technology is now inbuilt in the management of health, both from a health perspective and also from a disease person perspective. And in diabetes now, technology is now ingrained in various different forms. As all of you know, continuous glucose monitoring, blood glucose monitoring systems, you have automated insulin delivery systems, you have digital health apps. Now, then you have artificial intelligence and machine learning programs. Then you have now wearables, which can, there are multiple sensors which can detect your heart rate when you are just walking or sitting somewhere, can pick your temperature, PO2, and can send that data by cloud over to a physician, or someone else can analyze, and you can get the data. And your physician can get the data. So I think technology is revolutionizing, and with the new, I think all of you know, with the new artificial intelligence, generative artificial intelligence, that is ChatGPT. Now we have also some platforms can give you prescriptions, although there are legal implications in that, legal and ethical implications, but there are options which can be used, generative AI in diabetes management, or in general about any health scenario management. With that note,
before you proceed further, you know, coming back to diabetes and technology, I'm very excited and very happy. You know, every system, every branch of medicine has developed around technology. Endoscopy for gastroenterology, cardiac cath and EP electrophysiology for the cardiology, the CT scan, MRI scan, functional MRI, the PET scan, neurology. So today we are very happy, Debashish, that you and your colleagues have brought diabetes to that platform or beyond. That diabetes itself is technology driven. Over to you.
Yeah, thank you. So I will not take much of time. I think now let's proceed. We have a wonderful series of talks, and I think the first one is by Dr. Jyoti Dev, who will be speaking on, and I'll just, you can see his, I think most of you know him. I say him, he's a technology man of diabetes in at least in India and nearby countries, and he has been utilizing technology for better patient outcomes, especially in diabetes, I think in my knowledge, for last 3 or 4 decades or more. He is based out of Thiruvananthapuram, Kerala, and he is a very leading research oriented diabetes physician, and this is just his some of the credentials you can see on the screen. I know him personally for last, I think, at least 3 to 4 decades. It has been very nice to be working with him on various projects. Now, so we will now, I think, because he was not live, so we had recorded his session. So Dr. Jyoti, we'll see now Dr. Jyoti Dev.
From Trivandrum, from Kerala.
Yeah.
First of all, let me express my sincere gratitude to Dr. Kunango sir, A.K. Das sir, and Jayendra Kumar Panda for giving me one more opportunity. Let me start sharing my slides, and this is a lecture on continuous glucose monitoring, TER, and the new digital tools for managing diabetes. Of course, this is related to technology, and I don't have anything to disclose pertaining to this lecture. In the last 1 decade, we, the diabetologists, physicians, and endocrinologists, we have witnessed the launch of more than 24 new drugs for diabetes. But the question remains, did those drugs make a difference in the outcomes? Of course, there has been phenomenal changes in the outcomes, but with respect to the hemoglobin A1C and the average hemoglobin A1C globally and within India, it is still remaining very close to 9%. So the newer therapies by itself is not a solution. And still, millions are developing the avoidable complications of diabetes. And this is adding on to the burden of treating diabetes. And the solution, according to the global authorities, for a better outcome in diabetes is the intelligent integration of technologies in diabetes. Technologies in diabetes can be broadly divided into technologies for monitoring and technologies for insulin infusion. So I'll be discussing both, since the technologies for insulin infusion are also related to monitoring the glucose. So let us look at the data of a doctor who belongs to our own community, our own fraternity, and he is 47 years old, 3 years of diabetes, is definitely obese, with an A1C of 8.8%. So obviously it is very high, and he is on the following medications. He is on biphasic analog insulin, he is on metformin, glimepiride, he is on a gliflozin. And during the interview he said, I am also a doctor like you, and I am very busy traveling. I have to teach my students. I have to go for rounds at least twice a day, and I cannot adhere to the instructions on monitoring. I have started using a glucose meter, but I cannot. It is not possible for me to adhere to the instructions on monitoring diet or exercise. And somehow we convinced him on the use of a continuous glucose monitoring. And we did it because we thought that let us be more practical. Let us be more realistic in bringing better targets for him. And we observed him for 3 months. And this is at the end of 3 months, the hemoglobin A1C has come down from 8.8% to 6.8%. And this is 90-day TAR, it is 98%. So it's good. So let me now move on to the connected glucose meter. So whenever we discuss about technologies in diabetes, we have to touch upon all those modalities. The connected glucose meters have been around for more than 8 years now, and they are the glucose meters which connects to the mobile health application via Bluetooth. And for the ordinary man who cannot afford a continuous glucose monitoring device, of course, this is the solution. And this is a solution, and some of these applications such as My Sugar, they have a plethora of additional values, and this is the green monster which responds to your touch, your glucose levels. You can log in your vitals, you can take a picture of the food and then upload it, and the entire information on the oral medications, the injectables available in the market, all of them are available in the mHealth application. So this can be considered as a partner in diabetes care, as a coach in diabetes care. And there are a couple of branded glucose meters which are the connected meters. So let me now move on to the current status of continuous glucose monitoring. This is important. Although there are multiple classifications available, this is the simplest classification for CGM. Number one, it can be a blinded CGM, where the patient can deploy at the doctor's office, come back after 7 days or 14 days to download the information. Or it can be an intermittently scanned CGM, where you can scan either with an NFC-enabled phone like this, or you can scan with a reader. And whenever you scan, you will get the interstitial glucose value. Unlike intermittently scan, a real-time CGM will display the glucose levels all the time. And it keeps on changing once in every 5 minutes or once in every minute, depending upon the make of the CGM. Integrated CGM is currently not available in India. Integrated CGM is an open interface where the sensor can be wirelessly connected to a third-party application such as a mHealth application, the phone, a dosing algorithm, or with another insulin pump for automation. And these are the 3 popular devices in India: the Guardian Connect, which is the real-time CGM, the Libre Pro, which is the professional CGM, and the Libre, which is the most popular CGM globally, number one CGM globally, and that's the intermittently scanned CGM, which is relatively inexpensive when compared to the other CGMs globally available. And this is from Dr. Benshi Sabu and the team, strongly recommending the use of time in range as a target in type 2 diabetes. And this is an urgent need. Of course, continuous glucose monitoring is the recommendation for type 1 diabetes, for insulin users. But in type 2 diabetes as well, if you are looking for an option to prevent the avoidable vascular complications, this is the solution. This is the technology solution. And for the last 25 to 30 days, in India, we do have the digital tools. And this is the Libre link up in the mobile phone. And this is from my own phone, where I can open the Libre link app and I can click on the scan button, and then I can scan my sensor. And the sensor will immediately give
148 milligrams per day.
report. So this is how the TIR will look like between 70 and 180, 98% of the time. And I can share this information with up to 20 more people in real time. And that is with the Libre Link Up app. So you can ask the bystander or the family member or the dedicated staff who can be a nurse or a diabetes educator to download Libre Link Up app. But in the hospital, when you have thousands or hundreds of patients on sensors, this is a solution. The libreview.com, and this is the cloud-based diabetes management solution, where the entire patients will be, you can see the data is populated. I can click on a particular patient and view, and I can generate the CGM metrics. And this is a rule of the day, the CGM metrics, which is now complementary to the conventional metrics for glucose management. And if a doctor friend is questioning you, why are you introducing a new metric when I'm happy with my glucose meter, when I'm happy with the hemoglobin A1C, which is providing a 3 months average? This is the answer. 3 beautiful girls over there with exactly the same hemoglobin A1C of 7%. All the 3 of them are having the same A1C of 7%. But look at the glucose variability. There are significant differences between them. For the third girl, despite an A1C of 7, it is 100% time between 70 and 180. Whereas for the girl on the left, it is only 40% time, which is within the range. And 20% it is below, and 40% it is high. No wonder millions of our patients, despite a near normal A1C, tends to develop vascular complications of diabetes. And this also is an explanation why the patients are developing or they are exhibiting mood swings. They are having the complaints of energy, low level of energy, and so on. So this is going to have a direct impact on the quality of life. Though this is a very familiar slide and all of you are masters of TR metrics, but there could be at least 1 or 2 doctors who are listening to me who will have some benefit on reviewing the same data. This is international consensus, and this is a very, very important slide. For people with diabetes, type 1 and type 2, with relatively less complications, you have to aim for a TAR more than 70%. And 70% translates to 17 hours in 24 hours. And this is level 1 hypo below 70 and level 2 hypo below 54. And this is less than 4% and less than 1% respectively. 1% corresponds to 15 minutes in 24 hours. And you can see that in the presence of complications, irrespective of the age, you probably need to target only more than 50% in range, because the hypo-induced consequences could be more worrisome. In the presence of GDM or type 2 diabetes, be very aggressive. More than 90% or 95% within range. But remember, the lower limit of 70 is replaced by 63, and the upper limit of 180 milligrams per deciliter is replaced by 140 in the presence of pregnancy. And this is the frequency of repeating continuous glucose monitoring, the South Asian recommendations from our group representing multiple countries. Again, very important. Even when diabetes is within control, even when the TR metrics are within the acceptable limits, you have to repeat the CGM at least once in every 6 months. However, if they are exceeding the recommendations, the time below range is more than 4 or more than 5%, based on the clinical judgment and the affordability of the patient, we have to repeat it more frequently, once in 3 months and once in 2 months. And this is a recommendation on intermittently scanned use of continuous glucose monitoring, intermittently scanned continuous glucose monitoring if the patients cannot afford for a continuous use. And this is the broader view of the ambulatory glucose profile report consisting of TR metrics, the AGP graph, and also the daily graph. And this is the evolution of insulin delivery devices over the past, I would say, 100 years. And now, with the availability of more reliable and affordable continuous glucose monitoring devices, automation is no longer a dream. And these are the 3 popular advanced hybrid closed-loop systems available globally, of which only 780G is available in our country. And this is capable of adjusting the insulin delivery once in every 5 minutes, both basal and border. So when insulin is needed more in the presence of hyperglycemia or impending hyperglycemia, based on sensor glucose levels, the insulin infusion automatically increases. And these are the patient responses. Ever since the diagnosis of type 1 diabetes, I have slept peacefully at night continuously for 8 hours. And this is no longer a dream. And most of the patients on 780G, even today we are having an admission for a 780G deployment, and most of them are having a TER consistently above 90%. That is also exceeding the recommendations. And these were all possible only because of the newer generation of continuous glucose monitoring devices. And this is DIY artificial pancreas, one of our own reviews, which is referred to by all the major scientific organizations in their yearly guidelines. In India also, the space is expanding. Patients and the caregivers and the relatives and also the doctors along with the engineers. And we are expanding the space for digital health and diabetes. And this is Dr. Mohan on the current status in India. Every time we discuss about technologies in diabetes, the question is, isn't it expensive? And this is the answer. When you're using a continuous glucose monitoring device or an automated insulin delivery device, it is associated with, for example, 780G, an incremental gain of 1.95 quality adjusted life years compared to conventional management of diabetes. Use of technologies invariably reduce the cost of diabetes care. Telemedicine, smartphone with mobile health applications, and remote monitoring. And with every complication, there is an escalating cost in diabetes care. Earlier, we used to teach our doctors. When I was a teacher in the medical school, I also used to teach. The complications of diabetes is related to duration of diabetes. It's no longer true. Almost all of them are preventable if you are intelligent in the use of technologies. The accidents are avoidable, provided you are choosing the right technology and suggesting the right technology for your patients. The life is going to be much more easier for not only the patients, but also for the doctors. And this is an invitation to the World Congress of Diabetes and diabetes technology and therapeutics. Some of you may be aware of DTech, and the next DTechon is going to be this year 2024 in Kerala, in Kochi. Please get registered, and this is going to be an exclusive technology congress for diabetes. Thank you very much, Dr. Kunungo sir and the team, for inviting me and giving me this opportunity.
Yeah, thank you, Dr. Jyotidev. It was although Dr. Jyotidev was not live, but it was a very nice recorded session, and you heard him. And now we go to the next session by none other than Dr. Manoj Chawla. I think most of you know him. He is a leading physician and diabetologist from Mumbai, and he has been in the forefront of using technology in the management of diabetes, and he has published many papers and also done a lot of clinical trials. Now, today he'll be speaking here on cautions to exercise while using artificial intelligence and other technologies in the management of diabetes. Now, I welcome Dr. Manoj to deliver his talk.
Hi, evening, Dr. Devashish, and good evening, everyone at NUCD. Warm greetings from Latur in the Marathwada district of Maharashtra, where I am today at the DCC conference. So, joining in here virtually, let me also wish Dr. Jyoti Dev a very happy birthday today. And probably that's the reason that we had his recorded presentation. Hopefully, he's enjoying his day with family. Well, I've been asked to speak by Dr. Alok Kanungo, and big thank you to him on the cautions in AI. And my disclaimer is that yes, Debashish said that I have been at the forefront in the use of technology in diabetes. I am not a person known for conversations on artificial intelligence, and which is why I did take up this topic so that I learn more about it and also draw some cautions to the use of artificial intelligence, which is growing by the day. So over the next 15 minutes, let me try and throw some focus on how AI is, what AI means and how it is available in different aspects of healthcare, and where we should be cautious of what are still the limitations in the same. So what is artificial intelligence? Well, any technique which enables computers to mimic human behavior. It's something that we are actually teaching our machines. Machine learning, which goes along with AI, is a subset of AI techniques which use statistical methods to enable machines to improve with experience. And we'll be using these terminologies, AI and machine learning, throughout the conversation ahead. And deep learning, which is subset of machine learning, which makes the computation of multi-layer neural networks feasible. So world has become tech savvy, society is changing, IT is the trending word, and so is artificial intelligence. Computers, smartphones, internet is revolutionizing our fabric of life. And we also, as healthcare providers, can't stay away from use of technology or AI and continue to stay updated. So AI and technology is making its way from day-to-day life to medicine world. Well, in our daily life, whether it's your biometrics, your language translators, the navigation, the Google Maps that you've been using, social media, all are forms of actually artificial intelligence. So for many people who think that this is a new term, no, all of us have been exposed to artificial intelligence, including your internet search engines are all using AI for a long, long time. Its integration into medicine is seen in many fields now, and it's increasing, whether it's your AI chat box, your virtual assistants for your electronic health records, the robotic processes for surgeries, AI platforms in medical imaging, wearable devices, and so on. However, let's get down to understanding that what it means to be a good doctor, and all of us are clinicians and can't really stay away from being good doctors. As medical professionals, we do need minds like a detective at times. We have to have the mindset of a detective, and something does not add up, or your gut instincts tell you that there is something else, there is very often likely an alternate explanation. And I'm sure many of us have used this terminology or conversation with our patients where we say that human body and biology is not mathematics. 2 plus 2 will not always add up, and there will be various computations, and which is where the human touch and human presence still continues to be supreme as much as AI would advance. What we need to do is still continue to be a good listener, use all your senses and skill sets, have your ears open, have your eyes open, have the heart and the empathy for your patients, and the mind to actually assimilate all the data. The data analytics can help us, but you are the one who has to actually make the final decision based on your empathy and your intuition towards patient's diagnosis. So sit and face the patient while listening and note both their verbal and non-verbal language. They are more likely to follow your advice if they feel you have listened well to them. So for those many people who feel if AI is going to enter so much into medical profession, what would doctors do? Well, you will not be extinct. These tools are only meant to assist you, and hence you should also be well aware of how to use it to your best, to your and your patient's best advantage. So have empathy, because people will forget what you said, people will forget what you did, but they will never forget how you made them feel. And that's an important aspect for us to remember. So you look at the developments in diabetes world, we talk about the dietary modification from early starvation diets before insulin was discovered, and then insulin changing everything. In the blood glucose monitoring, the early use of Benedict's reagents to measure the amount of glucose, to today, SMBG and self-management. In the digital and technology use, the use of pumps, CGMs, and then moving to data analytics and actionable insights has been a progress. And of course, in artificial intelligence and machine learning, there is integration of AI and ML into the diabetes management. There are predictive models for glucose movements through the day, recommendations for insulin dose, and clearly unlocking previously inaccessible or unthinkable avenues there. So recent advances in technologies in healthcare, well, telemedicine has become a household name. So is mHealth. A lot happens on the smartphone. India has the second largest population with smartphone usage. So that adds to our strength of reach. Various smartphone applications, machine learning technology applied, where you're actually teaching your machines to
Stuti, I think Manoj.
Yeah, I think he's not audible. Some network
not moving also.
Yeah, not. Yeah, some network issues, it seems.
Yes, sir. He's been traveling, so might be there must some network issues.
Can you phone him and tell him to maybe advance or something, do something?
I think he got dropped also, I think.
Sir, I'll call him.
Call him and tell him, and then otherwise you have the next speaker also ready, and he can again come back from wherever. It's a very interesting topic, so we would like to listen to him. But if he's taking time, we can go to next speaker and then come back to him. What do you say, Alok?
Yes, yes. But let Stuti confirm.
Yeah, Stuti is going to call him.
Rakesh, welcome for the next session. Kalpana has joined.
Rakesh, I am not seeing you, Rakesh. Where are you?
No, he is.
Sir, I am there since morning.
Oh,
Good
really?
afternoon, sir.
Kalpana, I know. You came long
Yeah.
back.
Good.
Kalpana madam, namaskar.
Namaskar.
Kalpana, good. Rajiv, good afternoon.
Hi, Rajiv.
Dr. Rajiv, good afternoon.
Rajiv, I think Delhi is 3 degrees, so Rajiv is coated and booted and uled.
Sir, Dr. Manoj Chawla is here.
Okay.
Manoj, let us start where you left. Manoj, we will start where you left.
Yes, sir. So apologies for the loss of connection.
Fantastic talk where every word is important.
So technology can ditch even a technology man.
Yes. And which is what I'm saying, that you can't depend so much on artificial intelligence. Your own means are important, sir.
Yeah, true.
Okay. So I'll start. You can see my slide, hopefully, in the full screen mode now.
Yes.
Right? Slide seen, yeah, thank you. So hopefully I don't have this loss of connection again. So I was talking about how AI can aid in this, analyzing this complex data, identifying patterns, lead to more effective management. CGM use of analytics is one such example for machine learning and AI. The multitude of decisions throughout the day can actually overwhelm the patient. Imagine the number of data points if they cannot be analyzed and cannot throw up easy understanding, it would be difficult. For example, for that matter, even AGP, which is a software, is a form of artificial intelligence. So AI in diabetes, the current state, where is it largely used in diabetes? It's in the diabetic retinopathy screening and reporting of the data, clinical decision support system, patient self-management tools, and risk prediction and stratification. If you have to categorize artificial intelligence in diabetes care, well, there are 4 large essential categories: automated retinal screening, and you have a number of articles on the same. Most common clinical application is for detection of retinopathy, maculopathy, so on. Clinical decision support systems, AI there, is used for detection and monitoring of diabetes and comorbidities like neuropathy, foot screening, wounds, etc. Predictive population risk stratification is used for identification of diabetes subpopulations at higher risk for complications, screening, hospitalization, readmissions. And patient self-management tools are an example where you have AI-improved glucose sensors, the automated insulin pumps, dietary tracking devices, and so on. So what are the benefits of AI and technology in management of diabetes? Blood glucose control strategies helps in prediction of glucose, detection of adverse glycemic events, insulin bolus calculators, risk and patient personalization, detection of meals, fruits, etc. So a lot of applications where AI can actually be used well for diabetes management. Artificial intelligence has emerged as a powerful tool in clinical medicine, but one must remember and always question, is digital technology a boon or really a curse? And I wouldn't say it's a curse, but is it a boon we can say blindly? Probably not. Are we overlooking the drawbacks is the question we are asking. At the center of it is diabetes care, further substantiated or helped by digitalization of health data and Internet of Things. But there are some obstacles yet which we have to overcome. There is a huge data divide in terms of who can provide the data, how much you can get from different populations, data privacy issues, lack of awareness largely of how to use this data, limited infrastructure and funding, and lack of policies yet, which continues to be a problem. And this was a wonderful paper by Dr. Jyoti Dev, Dr. Mohan, etc., who thought this up. Now, quickly, I will talk about the common artificial intelligence approaches. These are maybe some terms which are new for many, but it's still early days with AI, I would say. So multi-layer perception. Let me focus on the limitations. We've spoken a lot on the strengths, and you can read the strengths here. But when you talk about multi-layer perception, which is essentially used for prediction models, well, greater number of parameters have to be estimated without convolution, less effective than many other deep models. One other artificial intelligence means is convolutional neural networks, CNN, are used for retinal screening, but requires again a large amount of data to train, computationally intensive, many parameters require fine-tuning while using this model. Then you have random forest used for retinal screening, can be slow in prediction. Fuzzy logic or fuzzy system as it's called, again used for retinal screening, decision support sensors, and artificial pancreas requires an expert curation of its algorithms and rules. Support vector machine SVM used again for retinal screening and patient self-management tools does not scale well to large data, hard to interpret and not used much. Logistic regression is again a prediction model. Only binary classification can be sensitive, again not used much. Natural language processing used for prediction models require a large amount of human annotated records to train, so difficult to get all that. K nearest neighbors algorithm, computationally intensive, sensitive to outliers or localized data, and hence not very accurate. So these are the different approaches. Now let's also look at some other drawbacks of AI. So when you talk about data collection and algorithm developing concern, there is inaccessibility of relevant data. There can be a lot of data coming in to the system, but it has to be relevant. An effective application of information technology and AI in healthcare requires a paradigm shift from treating patients individually actually to improving healthcare. So I think one of the limitations today is we're trying to use AI for more individual care, whereas it should be used at this stage for more healthcare overall improvement. Social concern when it comes to the consequences and efficacy of AI, though still there, an individual who's new to it or naive might lead to unrealistic expectations, and current capabilities can be overestimated. And hence, I get a little cautious when every other day there is a conversation about AI in newspapers, print media, social media, that it seems to be a little too overrated currently. There are ethical concerns about accountability and data privacy and security issues. And of course, the lack of data validating the effectiveness of AI-based medications, it's still very, very early days. So data security will always continue to be a concern. Because of the advancement of AI, users may mistake artificial systems for people and provide their consent or more covert data, raising serious privacy concerns. So, there was a joke recently with for AI. In fact, today the machines are asking us to prove us to be humans and not robots when you're giving out your passwords and doing the entry. And how do we prove that we are humans and not robots? By identifying those images of traffic signals or cars on the road and so on. So it's funny, but that's what is happening, that the machines are asking humans to prove that they are not machines and humans. Patient consent is a key important data for privacy issues. Well, many may be surprised, but all of us use Google. But Google has also been accused of using the data wrongly. So in 2018, Google acquired a AI healthcare company called DeepMind. And it was then later discovered by NHS that a lot of data for patients with acute renal impairment was uploaded to create an algorithm to treat patients without their consent. This came under. So is this the holy grail? Well, it's tough really how to figure algorithm can reach a certain specific conclusion. The absence of standard guidelines for moral use of AI and machine learning in healthcare has only served to worsen the situation. Three most important barriers which are identified is by the healthcare practitioners. Well, I don't understand how to use technology tools to improve my health. It's too overwhelming, the data, and lack of information, training, and support. For the system barriers identified again by the providers is we don't have enough staff. Data from remote patient monitoring integrate into the health record. For example, you'll need a separate software to look at the CGM data. Many EMRs are not yet being integrated by the CGM or other data coming in from the patients. And even the health records are not designed to integrate this, but things will hopefully change. This was a scoping review to look at use of digital health technology. The use of various, today patients are wearing the wearable devices. They can do telemedicine consultation, text messaging. The primary outcome was to see physical activity being given to such patients and for health coaching to see what's happening to their quality of life, and also measuring some biomarkers. Well, the findings were not in favor. It did not show any great change in quality of life or clinical condition. Pointed out in this scoping review was that the sample size was small, varying objectives and digital health tools. Some were using wearables, some were not. Different approach to measuring outcomes. Access to care was poor, and study withdrawal by patients because they were not satisfied. So let me reach towards the conclusion and say that artificial intelligence and technologies today cannot be looked upon as just one step and done. So many think that it's one button and I'm going to get the solution. Is not. That still continues to be one of the biggest flaws of AI. It requires much more input from the human perspective still. So it's not just one step automated yet. So lack of a humanly act still would bother it. It still requires the human touch there. Sorry, there was another slide which got missing, and my concluding slide there was to say that whether AI today is a boon or not, it's still early days, but we need to remember that machine learning is still an automated machine system learning, and artificial intelligence is nothing but a coded software. So though it is making great advances today and in helping us with data analytics, the fact remains that you will still require the human touch, the human input And the idea is for humans to use artificial intelligence to its advantage and not get overwhelmed or driven by AI. So with that, let me conclude my talk and thank Dr. Kanungo and Debashish and team. And hopefully, I have thrown some light on this emerging question about criticality of looking at AI in medicine and diabetes specifically. Thank you.
Thank you, Dr. Manoj. Very, very enlightening and lecture. I think we will anyhow. We have the panel discussion. We'll keep the questions at the end of the panel after the next session by Dr. Bansi Sabu. So I request you to be there, or maybe you can rejoin after 15 minutes, whatever works for you, so that you will be there on the panel.
Thank you.
Yeah. So our next topic is by Dr. Bansi Sabu. I think all of us know him. There's no need to introduce him. So this is a interview format, and he'll be interviewed on the topic of acceptability, wider acceptability and use of CGM devices in general, but especially for diabetes management from an Indian perspective. With that note, I think now I'll ask the
Welcome to NUCD, National Update on Clinical Diabetes. And with this session, this technology and diabetes, we have none other than Dr. Bansi Sabu, the tallest figure in the field of diabetes and technology, with whom I'll be discussing the different aspects of CGM and how the common people will be able to use it. Welcome, Dr. Sabu, to this meeting.
Thank you.
So, for the viewers, our doctors, would you like to say something shortly about CGMS and how do they change the lives?
So first of all, Dr. Alok, I am very much thankful and grateful to you for giving me this opportunity. And as I'm a regular faculty of your NUCD since last 10 years, being it physical or being it face-to-face or on virtual mode, I'm really thanking you for giving me an opportunity to talk to you about the continuous glucose monitoring, as it's a very important topic. In last 5 to 7 years, the complete paradigm is shifted as far as monitoring is concerned and the diabetes management as per the monitoring. Now, few things before I talk about the CGM, which one should know that the monitoring in our country is really very, very poor. And I'm sure you will also agree with this, that many of our patients, they continue to take the medication, but they don't monitor it. So that's number one point. And that I personally feel that's one of the very important reasons that 2/3 of our diabetic patients are not under good control. Now, the second big problem is the hypoglycemia is always a limiting factor for a tight glycemic. So just giving a simple example, suppose our patient is having HbA1c of around 8 or 7.5 or 8.5. It becomes extremely difficult for our doctors to intensively now achieve this 7.5 to 8.5 to below 7 or 6.5 because they are worrying of hypoglycemia, and definitely the number of episodes of hypoglycemia will definitely increase when you are trying to achieve a control which is around 8 or 8.5 when we want to take it less than 7 or 6.5. Now, I am lucky that I am the part of International Consensus of Continuous Glucose Monitoring in 2017. Rather, I was only one from Asia who was part of these global experts, more than 40 experts from all over the world. And we decided that who should be on a continuous glucose monitoring. So not all type 2 diabetic patients. As you know that Dr. Alok, it's not possible that all type 2 diabetic patients, but definitely all insulin taking patients, all type 1 diabetic patients, if they can afford and if they have access, they should be given a continuous glucose monitoring. Then after 2 years, in 2019, again, I was the part of that expert consensus, which has been published in Diabetes Care. And we all started talking about time in range. Again, I was part of it. And we have come out that those people who are using continuous glucose monitoring, more than 70% of the time, they should be in time in range. So I mean, out of 24 hours, in 70% of the time, most of the time, their sugar should be between 70 to 180, and that is what we call its time in range. So these two important landmark papers which were published, and I was lucky that I was part of these two expert consensus group in 17 and 19, and which is accepted by all over the world across all the bodies, now accepting that it is not only the A1C which is sufficient for our patient. They should do a time in range, a new way of monitoring glucose in our patient. So I mean, using continuous glucose monitoring will give you a 24 hours glycemic pattern, a glycemic profile, and in that you try to find out that how much time a person is remaining in time in range. If it is more than 70% of the time, it means you are doing reasonably well if there is no hypoglycemia. If it is not, then you change the therapy in such a way that less and less hypoglycemia or negligible hypoglycemia with increasing time in range. That is our concept of treating patients with diabetes. Now, question always come when we are talking about continuous glucose monitoring and time in range. Everyone will accept that, yes, if you're type 1 diabetes, your geriatric patient, your insulin taking patient, your patient who is ill or who is using insulin, if they can afford, they can put on CGM. But what about routine garden variety of type 2 diabetic patient, whether they should use CGM or not? That's an important question. So last year, me, Dr. Anup Mishra, Dr. Jyoti there, we had come out with a one paper which that how frequently the people with type 2 diabetic patient should also do the continuous glucose monitoring. In India, since last 6-7 years, we are using flash glucose, which is a cheaper alternative. It's not like a CGM. You can flash it and you can get it, and it's pro. And that gives that paper in which we talk that those patients who are not controlled, it can be repeated once in 2 months to 3 months. But those who are relatively well controlled, it can be done even once in a year also. So it's not necessarily that your all type 2 diabetic patient should be on continuous glucose.
So you mean to say all type 1 diabetes patient should be on CGM, and
if they can afford.
If they can afford, and some selected type 2 patients can also be in CGMS if they are not able to control their glucose level.
But if they are on insulin and if they are geriatric, if they are at higher risk of hypoglycemia, if they are hypoglycemic, unaware, they have multiple comorbid condition, they should be given a choice of CGM continuously. But the condition in India, if they can afford.
As you know, the doctors know that there are few types of CGMS. Would you like to say something on that? There's 3 types of CGMS.
Yeah, so there are 2 varieties. One is a professional and one is a real time. So professional one means you will get the data retrospective. A pro, it is iPro or it is what we call it. It's like one is Medtronic also have a pro, which is, and the second one with the Abbott, which is Libre Pro, which we commonly use. What happens? The monitor is with the doctor's clinic. Patient is put on a chip, which is a sensor. Patient had to come to the clinic again, and professional one, they give the report of last 4 days, 5 days, 7 days, 14 days, whichever number of days patient was put, and that data is come out. This is known as professional. The other is a real time. It means the person has not to come to the clinic or retrospective data. They can do it continuously and they can see. Now again, in a real time, there are 2 varieties. One is a flash glucose monitoring and other is real time. Flash glucose monitoring means you have to every time flash it to get the data. And other is a real time when without doing anything, your mobile shows a continuously report coming from that. Luckily in India, we have all varieties of continuous glucose monitoring available.
Like Dexcom.
Dexcom is a continuous glucose monitoring.
Medtronic Guardian.
Medtronic Guardian. We have Libre, which is Abbott Libre Pro and Libre both. In the same way, Medtronic also we have a professional one as well as real time. So now these are the major companies in the world which are available. But in the world, there are multiple other companies and many of these companies are not available. Problem also in India, they are more costly. That's the reason patient has to pay from their pocket. They may not agree for that and they don't want to measure. But many times the patient and doctors, both of them, they don't agree to measure continuously. And that's the reason we have to educate the people. It's not always the cost which is a major challenge. I feel 30% of our Indian patients are very affording and they can afford. The problem is here the education and awareness, and the NUCD or any such organization which we are doing these type of different educational program. Our primary idea is to educate our colleagues, our primary care physicians, our junior doctors, or the practicing doctors in the villages. They should also know the newer and newer technology. And at the same time, it will also increase the awareness about using these newer technology. India is otherwise very techno savvy. We are the one who are highest user of, the phone, phone users, smartphone users in the world. We are highest. We are using highest number of time WhatsApp. We are using social media very high. So it means we are techno savvy. But the problem is we are not using these technology when it comes in health. So using technology in health will definitely improve the care for diabetic patient as well as other health problems.
Yes, some doctors have already started using electronic medical records. And when they are using CGMS, can that CGM data be integrated to any of the EMR, or
Yes.
what is your opinion?
So electronic medical records data, now recently the two companies to whom I am working with them, the way this is not right platform, but because for the audience, Eka Care and HealthFlix both allow that a continuous glucose monitoring data can be incorporated in the electronic medical record system. So which I am using, and it is very friendly electronic medical record system, and where you can easily incorporate the data of CGM inside your electronic medical record system.
How do you recommend CGM for pregnancy and GDM?
So I think the usage of CGM in GDM or a hyperglycemia in pregnancy is very, very high, because that is the condition where you need a very tight glycemic control. You need someone who is pregnant. The sugar should remain between 63 to 140 most of the time. More than 90% of the time, their sugar should remain in this tight control. And when you want to keep someone in a very tight control, and many of these patients, other than nutrition therapy, they are on insulin therapy, and the risk of hypo is also very high when they are on insulin therapy. So you want this very tight glycemic control, and to achieve this, the best option is to get them a continuous monitoring. By most of patients who are pregnant and having hyperglycemia in pregnancy, whether they are pre-gestational diabetes or acute gestational diabetes, I recommend them very strongly, and many of them are using, and we get successful outcome of the pregnancy also.
Being the leader of RSSDI, you have taken many positive steps to bring type 1 diabetics into one platform. But how can we provide those poorer diabetic children who are given free insulin, free glucometers and all those things? What is your thought that how can CGMs be introduced to the poor India?
So the one first very important question which you are saying, Alok, that how we can provide these newer technology to our patients who can't afford it. I will put it underprivileged children, these type 1 who can't afford it. So let us put, like in India at present, we have, as per the latest data of IDF, around 226,000 type 1 children, which is below the age of 20. I'm not talking of adult type 1, which is another 5 to 6 lakhs. So as a doctor, as a diabetologist, as a community of diabetologists, whether from RSSDA, Diabetes India, whether you and me, if we all started using continuous glucose monitoring for our type 1 and type 2 who are in need, and those who can afford. So let us put, in India, we have 10 crore people with diabetic patients. Out of them, 5 crores are under the care of different people. Out of 500 crore, there are around 2 crore people who are relatively going to the physicians community, and a larger, who can afford also. And out of them, 20-30% of the patients are real afford. So like you can understand, out of this 2.5 crore, it means your 50 lakhs people or 5 million people are affording. Now, if we get these 5 million people a better device, a better monitoring system, a patient who can afford and they can buy and they can use it. So what will happen? These industry will also have a handsome amount of earning. And I'm sure if they will have a handsome amount of earning, they will put a lot of money for these poor children by providing them free. I give an example. How CDIC started. You and me had given a lot of patients the non-notice insulin, and that's the reason they are providing today 4,000 children free of charge insulin. We started giving them first a vial. Now today we are giving them pen, and probably by next year or 2 years we will be giving them analog also. So the point is, industry is one side earning, and they want to give back to the society for providing free. Like you and me providing so many children free of charge consulting. Why we can do is because you are 80% of the patients, they are paying you, and that's the reason you can give back to the society these.
Mansi, do you have any idea whether our top science institute like Indian Institute of Science or IITs are planning any such device in a cheaper version?
Yes, so IIT is working on it, and maybe in India we may get within 1 or 2 years a device which will be not only insulin pump as well as continuous glucose monitoring, which will be made from it, and that may be definitely cheaper. But as I told you, as the number of users will increase, the cost of these devices in India will also be decreased because import will be high. More number of companies will be in India. Like the the number of cars user in India, number of mobile users in India, and definitely cost decreases. So these devices cost will decrease always when we will be using it more and more.
Do you find any scope of this CGMS maybe periodically in pre-diabetics and obesity patients?
Yes. So during nutrition counseling, particularly for pre-diabetic patients, when we don't want to give them a medicine, we want to control them only by nutrition counseling. They definitely get the benefit of using continuous. Because a person who is having HbA1c of 6 point, I'm sure his occasional post-meal glucose is the condition that is leading them to 6.4 HbA1c. Their fasting will be always normal. So if we put them on this, it gives an educational and a motivational too. Because while seeing your report, you will find, oh, my breakfast is increasing my sugar to 180. Let me change my breakfast and it will help me decrease my 180 to 120. So, this becomes an educational as well as motivational tool. So I use it for many of my pre-diabetic patients to whom I don't want to give them a medication. Now for non-diabetic or obese people, just to give them an idea that how different type of high carb or a simple carb diet can increase your sugar level, even if it goes 140 because they are not diabetic. But it should not go more than 110 or 120. Why it should go if you are using a complex carb or if you are not using a simple carbohydrate? So just to educate them, sometimes we use it, but there is no data strongly. But definitely for pre-diabetic and for a nutrition counseling,
it can be used.
Really helpful, and it is really helping, and there are a lot of data also.
Thank you, Bansi. This is a wonderful discussion. You are the best in the country to speak on CGMS and new things. And as you know, we are doing only blood glucose test in the laboratory. Then these glucometers came, and then now CGM is coming. And in 5 years or 10 years, this will be routine practice for our clinicians to treat diabetics with CGMS or any advanced instrument also. So our doctors should be aware that this is an equipment in their hand to give a better quality of life to their patients. Thank you, Bansi, and welcome to NUCD. Thank you.
Yeah. Thank you. Thank you for giving me an opportunity.
Thank you, Dr. Bansi. We saw this recorded session, and I think we had fabulous speakers who spoke on different aspects of technology, starting from Dr. Jyoti Dev, Dr. Manoj Chawla, Dr. Bansi Sabu, and now we come to the panel discussion on technology. So I again welcome Dr. Manoj, Dr. Rajiv, Dr. Alok, Dr. Ashok Dashar, then Dr. J.B. Kanwar, and also Dr. Kalpana Dash. She's also there. So to just be on the panel so that we can have another meaningful discussion on technology and how we can leverage it in better patient outcomes and maybe ease of use and ease of managing not only diabetes, also how can we make their quality of life better? I think these are the basic principles of using technology. Now I'll start with the first question to Dr. Manoj. Dr. Manoj, we all know the benefits of CGM, but in a real life scenario, sometimes we also find, at least I have seen in some of my patients, and you might have seen, sometimes these devices overestimate hypoglycemia, and in panic, sometimes patient might not have, but then in panic they take a lot of sugars, thinking because the device pops up and says, oh, you are in 40 or 50 milligram per deciliter. So how you encounter, are these common, and how to manage them, how you manage the expectations of the patients in a clinic setup?
So great question, Debashish, and I think it's important today that when we adopt and embrace technology, we also understand limitations of each technology as we move ahead. As we today understand that SMBG also has its limitations, and which is where came in the aspect of calibration using ISO certified meters and so on. HbA1c also has its limitations, and so does CGM. So no tool today is perfect, but because it comes to a certain level of accuracy, less than 15% MARD as warranted by FDA, only then does it get its approval. The problem with overestimation of hypoglycemia was seen more in the earlier sensors. As they have evolved today, the current sensors don't cause this problem much, but it happens still at times. And there will be variations. There will be some individuals where the interstitial fluid glucose is not the best parallel running to your plasma glucose. So in some individuals, you will see this problem persistingly where it's too different and you can't use the technology. But in majority of the patients, you can, though being aware that on day 1 and day 4, you may still see some readings which are not matching to the plasma glucose. Having said that, today that's why it's important that though these technologies are available for direct use, today real-time CGM, the Abbott one, patients can buy it from Amazon, they have self-learning tools and they can use it. It's still extremely important that the doctors are involved in advocacy of such technologies to actually train the patients and their caregivers in terms of what to expect. And when this doesn't happen, it leads to disbelief in the system, as we saw this happen many years back with glucose meters also. Patients often tell us कि हमारे पास 4 glucometer पड़ा हुआ है, but we are not using it because we don't believe in that. And that properly happened because of improper training. So yes, every technology has its strengths, has its limitations. The doctors should also be aware. And importantly, the doctor and their team, your educators, should counsel the patient about what to expect, when to react and when not to overreact in such situations.
Absolutely. I think the key is expectation, knowing the limitations of the technology and setting the expectation of the user, I think is the key. You're absolutely correct. My next question to Dr. Rajiv Chawla is, sir, in your experience in Delhi, now a lot of these sensors, now we have these variables which can pick your heart rate, can tell you that, okay, you're getting a MI or a arterial fibrillation, or it can pick your PO2 and all that. In real life, in your experience, which of these these variables really, what you say, accurate in terms of at least what they predict or what they say? We can catch your fibrillations early, we can manage them better. What's your experience of these variables?
Dr. Devashish, I think unfortunately most of these AI-based apps or devices are still not validated. There are many, starting from a simple iPhone, which can pick up your heart rate, your blood pressure, your rhythm, cardiac rhythm, and now there are AIs which can get you. I think the recent conference we attended one was in Mumbai, Dr. Shashank's one, where there was a presentation that it can predict your total diabetes risk without even entering anything, just based on your BMI, based on your family history, based on your face reading, it you may say. It can predict immediately within 2 minutes that you are at a greater risk for developing diabetes. So unfortunately, all these are still not validated in our population. But I think it is very, very encouraging that technology is coming a long way. Dr. Jyoti also talked and Manoj also alluded to use of AI, but then diversification and the bits and falls in that technology, how AI can be many times non-decisive, then the data privacy and uh, data theft itself, and of course, validation of that data into our own ethnicity. But I think every day we are listening, there are close to now 10,000 apps which are available. My own nephew, just to share with you, is a graduate from BITS Pilani, and he has already come out with a app which works more like a precision model. What Dr. Manoj was exactly saying, that it can help you almost to reach to a diagnosis, and it can predict that what is going to be the best medicine in that particular profile of the patient. So it has not only the predictive value, it also has a precision in terms of giving you the therapy. But only thing is, we need to have validation of these apps and very judiciously, very prudently use these apps in the larger interest of the patients.
Dr. Manoj, any comments on that?
No, I think I agree completely on this aspect that Dr. Chawla said, and it's getting better and better, more precise tools being formed, and it's the same journey, I think, for all technologies, that embrace it, adopt it, but have right real expectations, and as doctors, enrich your own understanding of these technologies and don't shun them away just because it's difficult for us to understand. There was a typical tendency in the past that it's probably not for us to adopt, but I think none of us can stay away, and we all need to adopt and be well prepared.
Thank you. My next question is, now we see a lot of these technology apps companies, they come and say that we can reverse the diabetes of patients. So because this is a huge issue, we all know reversal of type 2 diabetes is not that easy as compared to remission. Correct. So so when patients come to you, or when you encounter such people coming to you and talk to, what is your advice, or how do you handle them when these technology companies say and that, okay, we can do a reversal program and can.
So if that's from me, I'll go first, but I do feel a little passionate about this topic, so allow me to express it. So one, we need to understand that these digital therapeutic companies, their means of advertisement and attracting patients may be questionable, because they are putting reversible, they are trying to send messages. If you see their videos, oh, are you still taking those medications prescribed by your doctor? Come to us, and blah, blah, blah. So that's their way of commercial message to attract patients, and that's their call. But the fact does remain that what they are doing is something that you and me have not woken up to be able to do. It is no rocket science what they are doing. They are utilizing largely the premise of CGM and monitoring aspects, which allow the individual subscriber to such technologies to see. So you and me are using CGM, but they are packaging CGM as part of the whole journey. They have coaches who will call up the individual, who will do a little push. It could be through the app, the AI-based thing, or an individual human touch point. Now, when patients come to us, we typically call our patients after a month or 3 months or longer. We'll have that conversation with them. Our educator will have that conversation with them. We have not scaled up commercializing it, thinking that I will engage 10 educators who will start talking to my patient every 2 days, 3 days, charge them 50,000 rupees for a 6-month package. You start doing the same thing and you will see almost similar results. So they are not doing something which is out of the blue. So they are doing what seems is possible for us, but we haven't done it because we are afraid of being labeled commercial and so on. So it's fine. So I have also matured to, from earlier to just shun away all these technologies as rubbish or digital therapeutics, to understanding that they're actually filling a void for what you and me can't do. There would be some of our patients who have been with us, we've been guiding them, but they're struggling. And they suddenly come to you and tell you, you know, I joined this Falana digital therapeutic company, and today my A1C is better. I have lost some weight. Do I have a right to discourage them? No. If they have done well, it's your choice. You are ready to pay. So maybe it's the patient who was not, you know, who did not benefit from listening to the doctor and educator once in 2 months, but was happier being pushed by an individual every second day because he or she needed that push. So if it's working for that individual, I'm happy for them. And as I said, we may question the commercial push from these technologies, but they are actually, their premise should be to work along with doctors as an ally, because you and me don't have the infrastructure today to scale it up. If we do, we can use that as well. So that's my thought on it. Would love to listen to Dr. Chawla sir's.
I think I absolutely endorse what you have said. Only thing is that these apps, not only they are using CGM data points and they are trying to incorporate that, they are continuously engaging that health coach and delivering the message what we unfortunately not been able to do as a clinician. You very rightly said, because there is a commercial angle attached to it. So there are 10 people sitting in your center itself collecting those data points, and then every day doing a hammering, maybe through a diet educator or through a dietitian or a consultant, to reinforce the benefits of diet restriction and motivating them for regular exercise, and that finally ultimately delivers as weight loss or maybe a remission. So if we forget about the commercial angle behind that, I think it is a important, it is a appreciable concept. Health coach as such can deliver and can get you an HbA1c reduction of 0.5, 0.6, 0.7 without up titrating your doses. This is what we did with the one Fable app, me, Dr. Shalini and Dr. Amit Gupta, and that data is already published in IGMR last year in, I think, 22nd August issue. And there we have involved around 140 patients, and through a Fable app, which was again doing a CGM, collecting all those data points. There was a continuous health coach involved in that, and finally delivering into within 3 months. It was a 24 months pilot study, and in 140 patients, we could get an HbA1c reduction of 0.66 without further up titrating the dose of anti-diabetics or oral anti-diabetic drugs. So I think concept is not bad. Only thing is how we can incorporate that minus the commercial angle. If we can incorporate the same concept into our ethical practice, I think this can be a wonderful tool.
Thank you. It's really good to hear your views on that. I fully agree with you. I think what they're doing, it's actually they're using what we could not do, utilizing more and more of CGM and engaging the patient continuously through dietitians and coaching. But the commercial side, how they do it, that's
So,
little.
Devashi, just quickly to add to that, so it's not so difficult anymore because of the real-time CGM and the app now being approved and the connected system. We have started doing that. So by now already, I think we have about close to 80-85 patients who are using real-time CGM regularly and sharing the data with us. We are not commercializing it, but we are having a small fee for every interaction, say every 15 days when we are looking at a data and giving our thoughts on that. So it's working for the patient, it's working for the center because we are spending time on the data and getting a small fee, but the patient is staying connected and finding it so much easier. Similar with those who are using the 780G pumps also, those type 1 patients, of course, where we are able to see their data continuously. So if we get a little more aware in this, our patients will not look around.
I think you need to then obviously engage an educator or a healthcare worker who is going to be regularly in touch, because as a clinician that may not be possible getting in touch round the clock on 80 patient or 100 patient sample. So obviously if you can hire 1 or 2 diabetes educator or healthcare delivery persons, and they are good enough to then reinforce not only on diet, up titration, down titration of your doses, of course it can come out to be a good concept, and it can be a reality to either do remission or at least weight reduction along with better HbA1c reduction without maybe uptitrating the doses or without even the need of insulin being added to those patients, which can be an incentive for the patient that you be on this therapy in this model for 3 months and it might work well for you. And finally, if you deliver those results, it comes as a good incentive for the patient also.
Thank you. Moving to the next quick question to both of you. Now, are you using any particular apps for, especially for type 1 or insulin dependent type 2? Carb counting is very, very important. And India being a very diverse country, we have different type of diets. So do you engage or do you have any partners where you use some apps which can get, you take a picture of that app food and it will tell you, okay, this is the estimated carbs. This is for the carbs. And similarly for some exercises which you want to engage your patients.
Manoj?
Sir, simple answer, no, I don't.
Same here, yeah.
My experience has been carb counting is a little overrated, and patients honestly don't do it continuously, and it hasn't helped. And that's the reason why patients on the earlier insulin pumps, in spite of us training them, not all of them did well. Many of them struggle with high A1Cs, and that's only changing now when they are switching to the completely automated 780G systems. So unfortunately, no, I've not had great experience with these pumps, and that's why I'm not using them anymore.
But we are regularly getting it done through our diabetes educator as well as our dietitian, because they are sort of more educated on that. We are not honestly being able to spend that much time with every patient on carb counting and sort of re-emphasizing on diet and all that. But our professional dietitian does it on daily basis.
Great. Now, I coming to the next part, the AI and ML. Now, we have these automated insulin delivery systems by Medtronic. You have from Tandem, then you have from other companies. Although in India, we don't have much apart from Medtronic. Now, we also know the do-it-yourself. Now, from a physician perspective, how do you see that do-it-yourself? And when some patient asks you, I want to do that. So what's your advice or recommendation for it, especially for a type 1 who want to use a artificial pancreas or a AID, but it's a do-it-yourself technology?
Manoj, were you part of that do-it-yourself study by Bansi and Jyoti?
No, so that wasn't the study, sir. That was one patient experience which they published as the case report.
IJJDC, I reviewed that paper and we finally got it published. But I was quite impressed with the content, what Jyoti talked about today also, little briefly on that experience. And do-it-yourself can be very, very handy in our country. But honestly, I have not used it yet.
My thoughts on the same, Debashi, are, do-it-yourself is, why not? So especially in our country, we are not, it's a self-pay market. Nobody is validating the payment. It can be questioned in the US and EU where it's coming through insurance or through the state paying for it. So you will have to follow the validation path because nobody will own up in case there is a problem in the DIY systems. So do-it-yourself systems is where the individual will use pump from one aspect, will use certain bypasses and hacking of the system to get connected to a CGM and then do automated delivery. So here there is absolutely no issue. If you have those hacked systems available for our patients to use and they are paying for their own treatment, nobody can stop them. Yes, a word of caution that those algorithms are not completely approved, but which is where, again, the patient has to know the limitations of that and be on the watch. For many of them, it turns out to be better and cheaper than the available systems that they have.
And it has not been widely validated also on many patients and through multicentric experience also.
Do you have any such patient, Dr. Manoj or Dr. Rajiv, who are using it do-it-yourself?
No.
Yes, I have. So it's like this, that do I know people who are doing it? Yes. Were they my patients in the past? Yes. Do they continue to be my patients now? No, I have not seen them. I have seen one of the two of them socially. But when they're so into it that they don't need to really come down. And that's how it happens with type 1s who grow up, that they are handling things. And I'm very happy to see that they are handling things. We just advise them to do some other screening for aspects on a yearly basis. But most of them then don't land up following up, and they don't need to very often.
Yeah, same here, absolutely. My all pump patient, most of them they have already outgrown and they have become so smart that they hardly come back to you and seek your opinion. But once in a while, here and there, you keep seeing that they are doing well, and one way you're happy that at least they have been taught enough and they are now self-reliant and they have been able to handle their own sugars and keep it within the good range.
Correct. Now, I know, I think this will be my last question. So this is little different. Now, Dr. Manoj, we know glycated hemoglobin technology. We also have a point of care of glycated hemoglobin. So I want to ask you, is there a role of glycated albumin in diabetes management, especially from a point of care perspective? And are there guidelines or recommendations to use glycated albumin? Are they standardized, and do we have a reference to use? I'm telling from a technology from point of care, glycated albumin.
Well, I'm not sure if point of care is giving us the other glycated albumin or any of the glycated other protein calculations, be it fructosamine or be it the other ones. The advantages of some of them is the shorter duration of period that they would point out the overall control for. But then again, they have not been validated as markers for either complication reduction or good control. So, except so in pregnancy, earlier days when you used to think that yes, we would love to do a fructosamine. But today, with better monitoring and CGMs available, I really don't see the larger role of other glycated proteins in our routine monitoring. And then again, whether they are being offered on point of care, I honestly am not aware, Devashish.
I think
And is there any guidelines on that, Dr. Manoj? Because I didn't come across any strong guidelines on use of glycated albumin.
These have not been standardized in our country, although theoretically, yes, glycated albumin is a wonderful tool of at least last 7 days or a very recent trend of hyperglycemia, more so in pregnancy versus fructosamine or HbA1c, which is not very useful. But only problem is these assays have not been standardized in our country, and that is why we don't have many studies on glycated albumin even in pregnancy, although it seems to be a very good tool.
And there is no recommendation, sir, from any of the...
Not yet. No data yet, actually.
No.
Yeah, thank you for getting that feedback. Now, before I close, it's my last, I want a final sentence from both of you. Now, what you advise to new doctors, physicians, and diabetologists and endocrinologists who want to use technology in different forms. We have different forms of technology in diabetes management. What will be your wisdom of pearl, 1 or 2 liners, take-home message from both of you?
I think use of technology is very, very fascinating, starting from, as I think Manoj said, in early days when even a glucometer had to be calibrated, and early days when we were doing only a Vanadix test or maybe simple urine sugar test, to have come along the long way in use of AI, in use of so many apps, many web-based or other apps to not only monitor and also to sort of incorporate that information to have a better precision medicine in diabetes. We are much wiser from use of AI in retina for many years, and now with availability of AIs in not only monitoring but also in sort of delivering in terms of getting a tight glycemic control is, I think, the future. But only thing is we again need to be very, very prudent. We just cannot be robot in hand of technology. Our clinical prudence should be final authority in taking all those decisions and incorporating these AIs judiciously in best interest of the patient.
Dr. Manoj.
Well said, sir. I'll just add to it that for young physicians entering into this field, learn and embrace all technologies coming into the healthcare field. This is for your own understanding and for you to be able to help your patients better, because if you don't recommend, they will still adopt it. So you should be well versed in these technologies, but not forgetting that your human touch, your empathy, and your clinical outlook and your attitude towards your patient should still be extremely human and that's what will help the patient. Make technology work for you. Don't work for technology. Thank you.
I think very well said, done. Very well said that ultimately it is empathy which goes a long way. It is your rapport with the patient. What I normally tell my DNB student, just putting a hand on the shoulder of the patient that I am with you and we will manage it well. That goes a long way, and we should not be totally dependent on technology. Of course, we should be embracing technology in making better decision making and moving towards precision medicine.
Thank you, sir. Thank you very much. So we come to the close of this session on technology. I think it was very well said. Technology, we should know the strengths and the limitations of technology and how we can utilize technology in diabetes management for better patient outcomes, better quality of life, ease of managing diabetes, and definitely if it is more affordable, and it should be affordable, accessible, and utilizable, simple to use, so that it will be easy for our users to use it. So, and as Dr. Rajiv said, technology is part and parcel of our lives nowadays, whether it's medicine or general life. We can't avoid them. So we should utilize them for the better patient outcomes and better management of our people living with diabetes and other comorbidities. With that note, I thank you, Dr. Rajiv Chawla, our other speakers, Dr. Manoj Chawla, Dr. Jyoti Dev,
and
Dr. Bansi Sabu, Dr. Ashok Kumar Das, Dr. Alok Kanungo, and for this fabulous session. And with that note, I hand over to the organizers for the next session.
Thank you, Dr. Kanungo and Professor Das and Dr. Devashish. Thank you.
Thank you, sir. Sir, ଆପଣ mute ଅଛନ୍ତି. Sir, ଆପଣ audible. Yeah.
It was absolutely fabulous session and a very balanced session. You know, I'm not into it, but I have been asked to examine the twin health system. So my opinion, honest opinion, was that ultimately twin health is nothing but tenacity of purpose to implement diet, exercise, regularity of medication, all that. So as you rightly said just now, reversibility is in our hands, whether you want it or don't want it. So it is intensity of purpose. Thank you. Thank you. Great session. Has Rajiv left, Rajiv?
I think, sir, he has left, sir. Sure. We now go to the next session, sir.
Yeah, next session. And I think Rakesh has joined. Rakesh, welcome, hearty welcome. And
Dr. Rakesh, good evening.
Good evening, sir. Good evening, Dr.
Great session today. And it's a little offbeat session because we're going to discuss diabetes and bone and diabetes and the muscle health, but driven by Dr. Rakesh Shah and Jayant Panda. And we have, instead of Nikhil, who is not well, nothing serious, but he could not participate today. So we have Dr.
Hi, Rakesh.
Hello, good evening, sir.
Good evening. Behra, who is MD DM, will be doing his part. Then we have Kalpana, who is already here.
Good evening, sir.
Good evening,
Good evening,
Kalpana.
sir.
Good evening. Good evening. One of the earliest DMs of the country and absolutely fabulous. And we have Sanjay Badada. He is the head of endocrinology at the he will be doing a interview with Dr. Kanwar, Devi Kanwar, who is also from PGI Chandigarh, and we have a panel discussion. Without taking much time, it's a great pleasure and honor on my behalf, on behalf of Dr. Alok Kanungo and Jayant, to start the session and to hand over the session to Rakesh. Jayant, please join and let us take it forward. Rakesh, yours. Kalpana, good evening. How are you?
Sir.
Fine.
Thank you.
Kalpana, good evening.
Good evening, Dr. Kalpana. Good evening.
Good evening.
Good evening. Good evening. Good. Over to Rakesh.
So good evening, one and all, and thanks to Professor Das for inviting me into this program, and also to Dr. Kanungo and Dr. Jayant Panda for inviting me to be part of NUCD 2024. And I'm very happy that Dr. Das has included this session, which is very important because we have dealt over the last 2 days. We have spoken about various aspects about management of diabetes, about the various complications of diabetes, and this is one of the very important complication which is being recognized. I mean, more and more information is coming in, and we are realizing how much bone health and muscle health have an impact on diabetes. Not only, I mean, not only their complications of diabetes, but they also have a significant impact on the disease itself in the form. I mean, in the evolution of the disease itself. So that's why I think this is very important that we have this session today, and we are going to discuss three important aspects, I would say. One is about the bone health itself, which is very important. Then we are going to discuss about the muscle, because all the time we speak about the fat being involved in causation of diabetes, but today we are speaking about how the muscle also, the loss of muscle is very important, and not only the excess of fat, but also loss of muscle is very important, and how we should measure that, how we should look at its impact on the various complications of diabetes. And finally, Dr. Kalpana Dash is going to speak to us about amyotrophy, which is one of the important, I mean, not so often seen, but a very troublesome complication which can occur in some individuals with diabetes. And we will have these three presentations, and we have an interesting panel discussion subsequently, where we can interact with all the three speakers and Dr. Ipshita, where we'll discuss about the various aspects of these complications. So without much more, I mean, without taking more time, I will invite.
Rakesh, I think Kalpana will give the first talk.
Okay.
So at the time Dr. Kishore joins.
Yeah, so we'll have the first talk
Kalpana.
with diabetic amyotrophy by Kalpana Dash. Her slide is going to come up, and as Dr. Dash said, already introduced her, as she's one of the very senior endocrinologists, one of the earliest DMs in endocrinology. She's an adjunct professor of endocrinology at Apollo Hospitals Education Research Foundation. She's associated with the Sugar Clinic in Raipur, and also Bilaspur. And she has many accolades to her credit. So over to Dr. Kalpana.
Thank you, sir. Thank you very much. Let me just share my slide. Can I see my slides?
Not yet, ma'am. Not shared.
Yeah, now it's coming up. It's coming up.
Now it's in?
Yeah.
Yes.
Yes, ma'am. We are seeing that.
Full screen. Yeah.
So first of all, I must thank NUCD, the organizers, Dr. Das and Jayant and Dr. Kanungo. So Dr. Kanungo and Professor Das has been very kind to me. For the past 16 years, I have been attending this meeting and participating. So good evening, everyone. I'll be talking on understanding the diabetic amyotrophy. As Dr. Sahai said, this is really rare. So I'll start with a case presentation. So there is a 49-year-old man who came with left buttock pain and left leg pain, who was planned for a spinal cord decompression surgery. And he had acute burning pain, which was radiating down from his left buttock to the left lateral leg. And he also noted significant weight loss, about more than 13 kgs. And on examination, he had decreased muscle bulk of the left thigh, decreased strength of the left hip, left knee flexors, and as well as the extensors. And MRI scan was done, and it showed mild canal narrowing with cord flattening in the lower thoracic spine. And biochemistry revealed severe hyperglycemia, and EMG was also done. He had evidence of acute and chronic denervation in the lower extremity muscles, which was consistent with diabetic amyotrophy in the setting of a newly diagnosed diabetes mellitus patient. So finally, he was diagnosed as a case of diabetic amyotrophy, and he was started on basal bolus insulin regimen, and patient improved and surgery was cancelled. So this case report describes a typical case of diabetic amyotrophy, which is a very rare neurological complication of diabetes mellitus, and this also can mimic the spinal cord stenosis and does not require surgery. So this is the moral of this case. So on follow of this patient, the patient's surgery was cancelled and the endocrinologist was consulted, and all serological parameters of autoimmune diabetic disease was done, and they were all negative, and patient was discharged with basal bolus insulin regimen. After 2 weeks, the blood sugar was good, and he reported improvement in the leg pain and also weakness. So let us have a look at about this entity. So this entity, that is diabetic amyotrophy, was first recognized by Leiden in 1877. The original description, we call it as a diabetic lumbosacral radiculoplexus neuropathy. This was attributed to Bronze in 1890. And later it was termed as diabetic amyotrophy by Garland, that was 1950. And this is also known as Burns-Garland syndrome. Also, we call it as proximal diabetic neuropathy, diabetic mononeuritic complex, multiplex, and paralytic neuropathy. And Burns-Garland also described 12 patients who had presentation like asymmetrical, progressive, and diffuse lower extremity pain with motor weakness, which was accompanied with muscle wasting, weight loss, and also areflexia. So it had clear relation to the recent onset diabetes and also uncontrolled diabetes, and complete recovery was found with appropriate glycemic management. So let us have a look at what is the pathophysiology of this entity. So mechanism, although it is still a subject of debate, but there are evidences that probably this disease is because of the ischemia, metabolic derangements, and inflammatory etiologies. Probably it is an autoimmune mediated inflammatory state resulting in vasculitis, and that causes ischemic nerve injury. It also has been documented that probably there are abnormal sphingolipid metabolism, which has a critical regulatory role in the immunity as well as inflammation, and which could explain the pathogenic mechanism for the injury. And nerve biopsy also has shown that there are degenerative changes secondary to microvasculitis, with ischemia and inflammation further ratified by elevated CSF protein. And neurophysiological studies, they have shown that a multifocal process which involves the lumbosacral plexus, nerve roots, and the peripheral nerves, peripheral denervation changes. All these mechanisms was because of this, diabetes. So what is the presentation of the disease? So mostly this occurs in the setting of diabetes mellitus, so mostly in elderly age group. The median age of presentation is about 65 years. Normally this patient, they present as a subacute presentation, and there is progressive course, and often their unilateral neurogenic process that occurs in the setting of diabetes. The distinctive history of the unilateral neuropathic pain is there, which is followed rapidly by atrophy of the muscles and also weakness. And this complication most commonly occurs in cases of well-controlled diabetes mellitus, and there is significant weight loss in almost all patients, and there is also areflexia, which is present in most cases, and even in some patients they can progress to paraplegia. Clinically active for a relatively short period, so that means it has a self-limiting course, and it can patient can recover even in within 2 years of its onset. There is progressive worsening of the disease with gradual recovery, but with some decrement if impairment may be there. In contrast to the diabetic peripheral neuropathy that we normally see in day-to-day practice, this diabetic amyotrophy, they are often having a newly diagnosed diabetes in the background, and there is short period of exposure to hyperglycemia. They are having a better glycemic control than the diabetic peripheral neuropathy. They are less associated with other diabetic associated complications like all microvascular as well as macrovascular complications. But at the same time, these patients, they are thin built, they are having lower BMI than the average diabetic population. So these are all differentiating points that you can differentiate this entity from the diabetic peripheral neuropathy. You can also find other findings like the patient can have numbness, tingling sensation, paraplegia, quadriplegia. There is also change in sweating. There can have foot drops also, having features of dysautonomia in the form of like orthostatic hypotension. Patient can have diarrhea, constipation, and also change in sweating. And this is basically by the diagnosis is basically by exclusion only. So it occurs both in type 1, type 2 diabetes mellitus, but type 2 diabetes mellitus patient, they have a relatively higher prevalence than the type 1 diabetes mellitus. So here is a prospective study of 33 patients with diabetic amyotrophy patient, and 21% of these patients, they presented with this neuropathy as the first symptom of their underlying disease. And most severe symptoms were at the onset were pain, that was about 82%, weakness was present in 80% of the cases. They are mostly distributed in the proximal musculature, that includes hip, thigh, buttock, and the back. Symptomatic treatment that improves the quality of life, that can be sufficient, but there are also thoughts that but early use of immunomodulators in the form of steroids, maybe IV immunoglobulin, that has been proposed as a superior therapy. However, the patient, this disease has a self-limited course. So this is I just got the case series that is about 113 cases from the European Medical Journal. So I'm just delineating all the symptoms. The cardinal symptoms included the abrupt onset of the severe proximal leg pain in thigh, hip, back, and followed by progressive weakness and atrophy within weeks. And pain was unilateral in 70% of cases, but whenever it was bilateral, it was usually asymmetric, and minority of the cases they complained of symmetric back and leg pain, and the pain was characterized by deep aching tingling sensation with or without burning. Proximal muscles were more involved than the distal muscles, most characteristic strain accompanied by various muscle atrophy, and distribution of weakness and atrophy was unilateral in 25% cases, but maybe it is bilateral in 50% of the cases. Overall, the involvement of the other leg occurred in approximately half of the cases, typically within 6 months. A small number of cases, they progressed to severe quadriparesis, and sensory loss was common but revealed symmetrical. It is not asymmetrical. 20% of cases, they had dysautonomia in this series, and majority had areflexia prior to the onset of diabetic amyotrophy. 50% of the cases, they had clinical evidence of diabetic polyneuropathy at the initial evaluation. So basically, the diagnosis is mostly based on clinical findings in a recent onset diabetes mellitus. Laboratory investigation, you can do like biochemistry tests, including HbA1c, liver function, electrolytes, including CRP and ESR. Of course, diagnostic studies in the form of CT, MRI, EMG, they are also required, but biopsy has no role. Even you can go for a CSF evaluation, because majority studies, they have shown that there is elevated protein levels, pleocytosis, suggesting inflammation in the CSF. So next, this is the findings in the electrophysiological studies. In the NCV, they have found that asymmetrically reduced sensory and motor action potential amplitude in most of the affected muscle sites, and EMG showed widespread patchy involvement, fibrillation potentials, and high amplitude motor unit potential. Imaging showed that that is X-ray, CT, MRI, suspecting the compression useful for exclusion. So you have to exclude other conditions that causes such kind of neurological symptoms. In MRI, T2 signal can increase with varying severity, and biopsy is described extensively to aid for the diagnosis, but this is not an integral part for the diagnosis. So what are the differential diagnoses? As I said, the diabetic peripheral neuropathy is one of the most important differential. Apart from that, we have nerve root compression. You have to rule out that. Infiltrative pelvic malignancy, CIDP, vasculititis, sarcoiditis, other infections, and post-radiotherapy. These all has to be excluded. But most important differential that should be excluded is the condition that is called as diabetic muscle infarction or diabetic myopathy. I just discussed about this condition, having MRI patterns and the current trends I found in one of the article. So this is a condition that is typically present with abrupt onset of pain and swelling of affected muscles. So this has to be excluded. This has to be differentiated from diabetic amyotrophy. This is most frequent among type 1 diabetes patients, but however, in this series, type 2 diabetes patients are more prevalent. So it's a spectrum of disease having muscle inflammation, ischemia, hemorrhage, infarction, necrosis, fibrosis, as well as fatty atrophy. So it is seen with long-standing diabetes and also poorly controlled diabetes mellitus. So you will find a palpable painful mass which was present in 34 to 44% of the patient. Fever was present in 10% of the patient, associated with high incidences of diabetic complications, unlike diabetic amyotrophy. So this is associated with all complications. Diagnosis is very important with typical clinical presentation and MRI findings, so that potentially harmful biopsies should be avoided. So MRI reports in this study, in this series, was actually collected, that is on the lower extremities, and collected from July 1999 to 2006, and reviewed and compared with clinical parameters for patients with diabetic myopathy. Clinical parameters like types of diabetes, A1C, CK level, ESR level, presence of complications including nephropathy, neuropathy, retinopathy, they were all noted, and the distribution of muscle involvement, imaging features were also reviewed. So what was found in this series was that, just a minute. 16 patients were remised over a period of 79 months and period 2020, including 21 extremities, that means 11 thighs and 10 calves. 88% patient had type 2 diabetes mellitus and only 12% had type 1 diabetes mellitus. 4% had disease in more than one location. Anterior compartment of thigh was more involved in all patients. Muscle infarction, necrosis was seen 8%. And the creatine kinase level, ESR, A1C level, they were all elevated in majority of the patients. Coexisting nephropathy, neuropathy, and neurotenopathy was present in a significant number of patients. The imaging findings in this series was found that there was subcutaneous edema, which was present in all thighs, that was 100 patients, and subfacial fluid was present in 91 patients in thigh as well as the calf muscles. And MRI finding was that there was pattern of diabetic muscle ischemia, there was ream of enhancing patterns of muscle infarction and necrosis was found, and hemorrhagic infarction also were found. Muscle necrosis and hemorrhage was seen in T1 weighted images, appeared as areas of hyperintensity within the affected muscle on T2 images. So you can see here the muscle ischemia, diffuse edema, subcutaneous edema, and myocyte necrosis in the thigh muscle. And also you can see here type 1 diabetes mellitus with bilateral myopathy of its thigh showing muscle ischemia and subcutaneous edema. So next, let us discuss about the treatment of diabetic amyotrophy. Obviously, the glycemic control is the key to treatment, and with symptomatic management, prognosis is always good, and the treatment is centered on symptomatic management. Pain management is a must, and management of hyperglycemia. Improvement in mobility is required, and pain management you can do with simple paracetamol or NSAIDs. Amitriptyline at night can be given. Selective serotonin receptor inhibitors are choices of treatment. Also, in severe cases, you can opt for opiates, and also sometimes if there is no pain relief, you can also use steroids. We can consider in severe diseases. A hospitalization is required if pain is not remitted. So we can contemplate for hospitalization in case of unremitting pain. So let us have a look at what is the role of steroid in such kind of cases. When we give a steroid, then the diabetes will also be uncontrolled. So there are multiple small studies who have demonstrated improvement of patient outcomes with the use of immunosuppressants in the form of like steroids, immunoglobulins, and also plasma exchange, but clear evidence is still lacking. Role of steroid in a double-blind study, including 75 patients who compared the high-dose steroid, weekly dose of 1 gram methylprednisolone for weeks versus the placebo. What was found that in the primary endpoint of motor improvement was not there, but the secondary endpoint in the form of the neuropathic pain was improved in this group. And steroid are considered particularly in those cases who are having severe pain just for the pain relief. Then next comes the role of immunomodulators. In 1995, there was a study by Crandall et al. Who reviewed the response to treatment of 15 patients with proximal axonal diabetic neuropathies. When IV immunoglobulin was given, it showed benefit in the strength, and however, most of these patients, they also received steroid orally or intravenously. Other kind of treatments in the form of cyclophosphamide as a thioprim as a steroid sparing agent. Sometimes, some cases also, they use the plasma exchange, and most patients using all these therapies, they improved, including 4 of the 5 plasma exchange patients and 2 of 3 intravenous immunoglobulin treatment. So what was in that all exhibited improvements in their pain and neuropathy disability scores. However, the primary pathology was not changed. So other complication also we have to look for. So patient can land in paraplegia, patient can have quadriplegia in the long run, patient can have depression, anxiety, and unnecessary spinal surgery also in some cases can be done. So this is the prognosis. Overall prognosis is, I would say, is good and is expected for diabetic amyotrophy, as this is a self-limited process. It has a progressive course that tends to worsen progressively, followed by stabilization and ultimately complete recovery with some residual motor deficit. Rarely progression to quadriparesis has been reported with an unknown degree of recovery. So I would like to summarize my presentation. Diabetic amyotrophy is a rare complication of diabetes patient compared to the distal symmetric polyneuropathy. The distinct history of unilateral neuropathic symptoms followed by rapidly by atrophy and weakness is typical for this disorder, and the complication most commonly occurs in cases of well-controlled type 2 diabetes mellitus. While the underlying pathophysiology is unknown in most of the cases, but it is thought that probably there is a microvasculitic process is there. The diagnosis is often based on the clinical and electrodiagnostic grounds, and tissue biopsy is not typically performed. Symptomatic treatment, as I said earlier, and attempts at the corticosteroid administration during immunotherapy should be carefully considered on those patients having severe symptoms. Better recognition is required for this disorder, which is likely to result in more rapid diagnosis, counseling, and finally, the referral system should be followed. Thank you very much for your kind attention.
Thank you, madam, for the very, good overview on diabetic hemorrhagic. You have highlighted the important aspects about diabetic hemorrhagic, the fact that it's a very rare condition, but severely distressing to the patient and can occur at different age groups. You have shown us a young patient also having that, while the traditional description is that it may happen in older patients, but it can happen in younger patients also, particularly the type 1 diabetics, and control of diabetes may not always, the degree of control may not always be the deciding factor. And also you have discussed about the various treatment modalities that can be adopted. I think we
Rakesh,
have questions then.
Rakesh, at one point, Kalpana's very, very, very vivid presentation and the latest reference, we really appreciate that. And, majority of the cases are confused, as you in between said, that a malignancy because of the muscle wasting of the person. And the cases that we have seen, they responded to insulin treatment because it is a beginning of the uncontrolled diabetes. And also, when I was in King's College, Dr. Peter Watkins used to describe 3 cases of recurrent Garland's amyotrophy. So this also can again recur with the uncontrolled diabetes. I think it was a fabulous presentation, Kalpana. Great.
Thank you so much.
We'll request her to stay back for the discussion later on, where we have a panel discussion. I will move on to the next presentation. Dr. Kishore Behra is going to do the presentation.
Yes.
Yeah. So this is a very important aspect, as I was mentioning, about sarcopenia, which is being recognized as an important determinant of diabetes complications, and how we need to identify that and how we need to measure that and manage the sarcopenia is a very important aspect, which Dr. Kishore Behra is going to talk to us about. We are all looking forward to that. Over to Dr. Kishore Behra. I think we can introduce him.
Welcome, Dr. Bhadada. He is here. So it is our welcome, Dr. Bhadada. Please.
Dr.
Sanjay,
Bhadada is
Sanjay,
also
good
here.
evening.
Welcome. Good evening.
Sanjay, good evening. Ashok here.
Good evening, Dr. Bhadada. We're looking forward to your
interview.
and also the panel discussion. We want you to be in the panel discussion also.
Actually, the interview by Dr. Kanwar is ready, and Dr. Bhattacharya will be there. And before that, Dr. Kishore is the head of endocrine in the AIMS Bhubaneswar, and he is a very senior endocrinologist who is doing a lot of projects at the AIMS and around, and part of the team NUCD and team Odisha Diabetes Endocrine. And he has taken this very important topic of sarcopenia, especially frailty in the elderly diabetic, which is a very common incidence and a relatively recent entity to detect and intervene. After the case-based presentation on hemorrhagic, I think Dr. Kishore's presentation on sarcopenia and at the same time frailty in the elderly diabetic is very pertinent. Let us listen to Professor Behra. The stage is yours.
Thank you, Jain Bhai, for this kind introduction. At the outset, I will thankful to Kanungo sir and Ashok sir, and also Bhadada sir and Rakesh sir. So, may I audible?
Yes.
Yeah, you are audible. Please share your slides.
Yeah, I'm just sharing my slides.
And by the time, welcome Dr. Kanwar. Kanwar has surfaced. The interview is very interactive. You'll watch soon after Dr. Behra's presentation. Make it full screen.
Yeah, we can see your presentation, sir, but can you make
Yes,
it
sir.
full screen?
Just 1 second, sir. It is something.
Yeah, now I think we can see.
Full screen. This will make it full screen.
Yes, yes, sir.
Yeah, now we can see full screen. Yeah.
Sir. So my topic will be treatment option for sarcopenia and frailty among older diabetes. So what I will do it, basically I will speak on how to approach the sarcopenia and something few slides for frailty, how we'll define it. And after that, some studies which has been done in Bhubaneswar, particularly in AIMS and SOM Hospital, and one study I have taken over is not published. And then treatment option, what are the treatment option available? So I'll be covering with introduction, defining sarcopenia, how will you define the sarcopenia, evaluation of the sarcopenia, epidemiology like prevalence, causes and risk factor, and the treatment. So as we know, the sarcopenia is a reduction in the muscle mass, that is muscles mass associated with, there is a decrease in muscle strength and the performance, and which is associated with increased morbidity, mortality due to physical disability, false fractures, and that all leads to increased mortality. So there are various criteria, but we'll be concentrating on the Asian criteria and the European criteria. So for that we have to measure the power, so hand grip strength by the jammers dynamometer, and which define that if you have a 26 gram less than 26 kg less than in male and 18 kg more less than in women, and muscle mass which is been measured in DEXA, that is appendicular lean mass divided by height meter square, 7 in male and less than 5.5 kg per meter square. And if the gait speed is less than 0.8 meter per minute, then we will define as a sarcopenia. But sarcopenia, there is a different, like probable sarcopenia, and the severe sarcopenia that I will be discussing in the subsequent slides. So frailty defining was the first described by Freud and colleague et al., and which defined as a clinical state in which there is an increase in an individual vulnerability for developing an increased dependency and or mortality when exposed to some sorts of stressor. And you can find at age more than 65, it is around 15%. As the age progresses, it's almost 1/4 of the older population, they suffer from frailty. And there is a cascade of functional decline in older adults from independence through to frailty and disability, which has been divided into 5 components. Number 1 is the weakness, which is by low grip strength, slowness, shrinkage, exhaustion, and low physical activity. And among that, the weight loss is usually the last of these 5 physical characteristics to manifest. And who is at risk of muscle atrophy and how do we identify it? So for that, the diagnosis process of sarcopenia, you have to have the case, assess, confirm, and severity. So in the primary care setting, we have to screen with SRC5. That is, if it is more than 4, then screening that probably this patient having sarcopenia. Then for assessment, we can assess with DEXA or bioelectrical impedance. So we have to measure the muscle strength, that is hand grip, or physical performance by 6 meter gait speed. And if it is there, then probably we're dealing with possible sarcopenia. Then there is a primary center. We can have a lifestyle modification in diet and exercise. Then we can send to the hospital. Then from the hospital, then the process of confirmation, we have to do the muscle strength, physical performance. Then we will do the muscle mass assessment by the DEXA or by electrical impedance, which has been shown in DEXA. If in male, it is less than 7, and female also in less than 7 kg per meter square. And in female, it is 5.4 in DEXA and 5.7 in BIA. Then in severity, we say sarcopenia if they have a low muscle mass plus either low muscle strength or low physical performance. If we have a 3 component, then it is a severe sarcopenia, and which is increased morbidity and mortality. So this is the ASEAN group of sarcopenia in 2019, which is I have described in the last slide. The assessment of the muscle mass by the DEXA. If DEXA is not available, we can go ahead with bioelectrical impedance with some sorts of limitation in that, and we can have a hand grip strength and 6-meter gait speed. So these are the various prevalence you can see from India. It is a cross-sectional study and taken the EWG SOP, that is the European guideline of sarcopenia, and they found in comparison to the control, the case having 44% of sarcopenia. And in study which has been published in 2023 September, and they have taken the ASEAN criteria of sarcopenia, and they found 35%. In our study, which has been published in 2022 in endocrine diabetes, we found in 45%. And these are the above 50 years old, and the recent study which has been going on in type 2 diabetes more than 60 years, we found almost 45% of the patients are having sarcopenia, and it is not yet published. We are still analyzing our data. So coming to the causes of sarcopenia, sarcopenia can be divided into 2 categories, primary and secondary. So primary usually is the age related, and there are various factors like endocrine factors, and there are some predisposing factors, and you can have a nutrition and metabolic malnutrition, decreased protein intake. So that all leads to muscle mass, decreased muscle mass and the function. And what is the more important, the key pathogenesis is the mitochondrial dysfunction, and there will be production of ROS, and then all that leads to decreased protein synthesis, imbalance, and increased protein degradation, and all leads to decreased muscle mass, decreased muscle strength, quality, and physical activity, and we diagnose them as a sarcopenia. So by using a simple mnemonics, we can have 4D like drugs. The most important statin, fibrate, steroid, and alcohol, and other res common like chloroquine, colchicine, antiretroviral drugs, and most importantly, what we get in day-to-day life is the type 2 diabetes, because the diabetes prevalences keep on increasing, and it will increase, and other diseases like chronic liver disease, kidney disease, heart disease, and osteoporosis, which is the term is called the osteosarcopenia, and deficiency like poor dentition, where patient can't able to take food, vitamin D deficiency, and other anorexia, malabsorption can lead to sarcopenia. So coming to the molecular mechanism, there are 4 mechanisms which is operate. One is the age, which called egrin musculoskeletal LRP4, which is responsible for the neuromuscular junction interactivity and the impulse propagation. If there is, that will be problem, then that can lead to sarcopenia. The second most is when the age progresses, there will be decrease in IGF-1, that will leads to PI3K, AKT, mTOR pathway will decrease, that leads to decreased protein synthesis, and there is like degradation of protein, autophagy, and UPS or malnutrition. When there will be activation of FOX, there will be increased proteolysis, or when there is a stellate cell dysfunction, so that also leads to production of the sarcopenia or initiation of the sarcopenia. Now coming to the treatment, there is basically 4 groups of treatment. Number 1 is a physical activity, and among them the most important is the resistance training, aerobics exercise, balance and flexibility training. And for prevention, you can have a nutrition like protein intake and branch chain amino acids like essential amino acids like valine, leucine, and isoleucine. Some extent vitamin D. These studies are not very vitamin D and calcium. They usually increase the muscle strength, but not the mass. And combination of the physical activity and nutrition, they do best. And some of the investigational drugs like myostatin inhibitors, inhibitors, all I will be discussed in the subsequent slide. And there are some herbal medicine also helpful for the treatment of the sarcopenia. So the treatment approach to frailty and sarcopenia, you can see this World WHO and International Conference on Sarcopenia and Frailty Research recommended that at least 150 minutes of moderate exercise per week or 70 minutes of vigorous intensity aerobic activity should be done. In addition, this guideline recommends performing a muscle strengthening activity at least twice a week on non-consecutive day to maintain or increase muscle strength and endurance. And that should be done with a exercise specialized with specialists on delivering this exercise. It will be supervised first, then subsequently patient can do. And you can see the designing of resistance program. You have 4 stages, which is training frequency, exercise selection, exercise intensity, and volume and rest. You can see in the right side of the cartoon, training frequency 2 sessions per week. Exercise selection, you can select the lower body or upper body, different parts. Exercise intensity, repetition, continuum based on a prescription, exercise volume, and rest period. All need to be concentrated. Now, coming to the treatment, you can see the all patient is the best practice guideline taken from the BMJ. The first is the resistance training, which I have explained, followed by protein intake, and which is you can know this 0.8 grams per kg body is the normal protein recommendation for the normal individual or adult. But in sarcopenia, we can give 1.2 and up to, in some patient, we can give up to 1.62 grams per kg body weight. And adjunct aerobic exercise to maintain overall health. But resistance training is preferred option for managing sarcopenia. And the nutritional intervention which act in different site, in the myostatin inhibitors which act in AKT SMART pathway, so that will stimulate the AKT, and so it will increase the protein synthesis. Ursocholic acid which stimulate the IGF-1, subsequently AKT, so that will muscle mass. Omega-3 fatty acid and hydroxymethyl butyrate, I will be discussing it. It acts on mTOR, so that will leads to muscle mass and strength. And oligonal which act on the autophagy. Autophagy is a process where the unwanted cell has been removed. If you don't remove the unwanted cell, then stellate cell cannot help in neogenesis. So to have a neogenesis, you have to remove the diseased or damaged cell. So oligonal is act, and subsequently it provokes the autophagy. That's why there will be myogenesis and muscle power will increase, or muscle mass will increase. So omega-3 fatty acid, the primary outcome, it is a randomized control trial, and which is the upper extremity muscle strength and lower extremity physical function. This is a 16 RCT showed that high dose 2.5 grams per day yielded greatest improvement at both upper extremity muscle strength and lower extremity physical function. And it acts, modulate the neuromuscular junction, increase the muscle protein synthesis, and decrease the muscle protein breakdown. And the mechanism of action is anti-catabolic effect on the muscle protein, anabolic effect on muscle protein, restoration of the insulin sensitivity, modulation of mitochondrial functioning and muscle fiber contractility properties, and neuroprotective and motor neuron excitability properties all may be modulated by omega-3 polyunsaturated fatty acids. Now coming to the leucine and hydroxybutyrate, hydroxymethyl butyrate, and which has been seen that this is a metabolites. HMB is a metabolites of oxidation of leucine, and around 5% of the ingested leucine is converted to HMB. And an open label randomized control trial in healthy older women concluded that if you give this, there is a promising result in strength, although it has no significant effect on short physical performance battery score. But its therapy in older adult is still not clear. So they have not recommended for the sarcopenic older patient to be given this medicine. Then coming to the investigational drugs like myostatin activin pathway, there are some monoclonal antibody LY2495655 and a monoclonal antibody that binds to and inhibits activin receptor in type 2B. There are some study, but these drugs are still considered investigational and further research is required. Now coming, which is the most important, is the exercise and the diet has got lot of beta analysis. I will be giving only one. And this is the 7 methods of treating sarcopenia, including resistance exercise, aerobic exercise, mixed exercise, nutrition. Resistance combined with nutrition and mixed exercise combined with nutrition and electric stimulation combined with nutrition and their effect on physical function. This is 2,485 patients, and what they found in terms of improving muscle strength, resistance exercise has the most significant effect on improving the grip strength. Resistance exercise combined with nutrition lifting performance best in chair standing test. For muscle mass gain, resistance exercise increased appendicular skeletal muscle significantly, while resistance exercise combined with nutrition significantly increased fat-free mass. And resistance exercise combined with nutrition is best result we are seeing in time of and go test. So in one line, resistance combined with nutritional intervention has the best effect on relieving the sarcopenia and can effectively improve muscle mass, strength, and functional performance. Now coming to the 1 or 2 slides about the diabetes and sarcopenia is the bidirectional. Hyperglycemia in elderly we consider is more than 65 and above or 60 above, and hyperglycemia leads to sarcopenia, dementia, and depression, and that leads to decreased ADL. And the characteristic of skeletal muscle in patients with type 2 diabetes, we have 3 different kinds of muscle fibers: the type 1, type 2A, and type 2B. Type 2B are less mitochondria, and type 1 and type 2A myofibril are having the more mitochondria, and they are having aerobic condition to generate the ATP. So these are more involved in type 2 diabetes. And in type 2 diabetes, there's a decreased insulin-induced glucose uptake into the skeletal muscle, and fewer capillaries, regardless of the myofibrils, are present, and decreased expression of PPR gamma and increased expression of propelfil factor 15 all leads to process of initiating the sarcopenia. And you can see there are various drugs which is used. We can see the association with improved physical performance in observational studies says probably bioguanides like metformin and thiazolidine, and some extent DPP-4 has some effect, and insulin has got some effect. Otherwise, there is no other drugs. Bioguanides also has some effect in improved physical performance in preclinical interventional studies. Improved physical performance in human interventional study also seen by the bioguanides. So in a single line, probably bioguanides has got some effect in that of the thiazolidine. Otherwise, SGLT2 inhibitor, they have an improved physical performance and preclinical intervention studies. So otherwise, none of the drugs has got effect in improving all the 3 parameters of the sarcopenia. And these are the various drugs, how they modulate the inflammatory and the glucose profile, and by doing that, they improve the muscle strength or the performance. And this is the slide when I was searching, I found the safe, inexpensive, easily available herbal medicine like curcumin, green tea, and ginkgo biloba and soya, that is reduce the stress, reduce inflammation, and increase the PI3K activity, which is one of the most important pathway modulating the TOR. It increases the muscle strength. So by modulating all these, they can have a positive effect in physical performance, hand grip, knee extension, weightlifting capacity, mitochondrial density increase, muscle fatigue resistance, increase in mean fiber area. So that all can lead to decrease in sarcopenia. So the overview of current strategy in potential benefit and limitation in managing the sarcopenia: exercise intervention, protein ingestion like amino acid and vitamin D, therapeutic agents. If there is a deficient like testosterone in male, probably there is some effect. And then the potential benefit is there is an increased muscle mass and strength, high mobility, increased protein synthesis, increased muscle mass, strength. And what is the limitation? The patient usually don't adhere to the exercise, and sometimes the poor nutritional status, anabolic resistance, and there is no approved drugs for the treatment. And probably some drugs are there which are having some side effect, like myostatin inhibitors. They have some side effects which has been tried in the cancer cachexia and has been withdrawn from the market. So these are the the drawback for the management of the sarcopenia. So in takeaways, sarcopenia and diabetes are bidirectional in nature. Resistant exercise, nutrition, protein supplementation, and group glycemic control in case of type 2 diabetes in sarcopenia is the key to success. It is an evolving condition that is not addressed properly, if not addressed properly, can lead to morbidity and mortality. The diagnosis of the sarcopenia with various diagnosis criteria has been put forward for over last decade and will included in ICD-10 for a few years back. And it is a evolving science, evolving disease, and lot of things may need. We have a normative data for our own, which has been there in Chandigarh. Sarcopenic SAR has done this. And there is a adequate screening facilities is there to diagnose in the primary setting and can be referred to tertiary care level for the adequate treatment. With this, I will stop my talk. Thank you for the patient hearing.
Thank you, Dr. Behra. I think you have dealt with a very interesting topic, and we will have the panel discussion where we have a lot of questions for you to discuss ahead. And but we'll first move on to the interview of Dr. Sanjay Badada by Dr. J.B. Kanwar, who's going to discuss with Dr. Sanjay Badada about bone health and diabetes. So after that discussion, then we'll come back to the panel discussion where we'll discuss more about sarcopenia and frailty, and also about amyotrophy. So to introduce Dr. Sanjay Badada, it's my great pleasure and honor. He's been a good friend of mine, and we were together in our DM endocrinology when we did our DM endocrinology. He's the immediate past president of Endocrine Society of India, and he's professor and head of Department of Endocrinology at PGI Chandigarh. His main area of interest is in the area of metabolic bone disease and diabetes in the young, and he is going to talk to us today. He has received many awards and has numerous publications to his credit, and he is going to be discussing, be in conversation with Dr. J.B. Kanwar about bone health in diabetes. So Dr. J.B. Kanwar is a professor and head of Department of Endocrinology at the IMS and some hospital in Bhubaneswar. He has also been a very active member of the Odisha Endocrine Society. He has been organizing several of the SECON meetings in Bhubaneswar, and he has several publications to his credit. He is going to talk to Dr. Sanjay Badada about bone health. Right. So I think we'll have, I think it's a recorded discussion. We'll go through it, and
it's a recorded.
We'll have the panel.
Stuti will share.
Very good evening to all of you. Welcome all the delegates to the 10th National Update on Diabetes, that is NUCD. And today for this interview, we have Professor Sanjay Vadada. And as you know that diabetes affects multiple parts of the body, retina, uh, kidney, vasculature, heart, everything, almost all the parts of the body are affected by diabetes. But diabetes also affects bone. And we do understand that if in elderly person, in old days, the two things are important. Two, rather I always say two B's are important. That is, one is brain and another is bone. So if your brain is working and your bone is working, then the rest of the things you can keep aside. So yesterday we discussed about the effect of diabetes on brain, and today we'll have a very interesting session on effect of diabetes on bone. And to speak on that, we have Professor Sanjay Kumar Badada is there. He is professor and head of the Department of Endocrinology in PGI Chandigarh. He is also a past president of Endocrine Society of India. And all the delegates is very much well versed with Professor Badada. So without wasting time, I would ask him, Professor Badada, what is the relationship of diabetes with bone?
Yeah, so very good afternoon. Thank you, Dr. Kanwar, for very important question indeed. Till now, we are telling the triopathy, retinopathy, neuropathy, nephropathy is there, but I think this is a high time to speak about the diabetic tetropathy. And the bone involvement in diabetes is like another microvascular complication. And indeed, the bone involvement qualifies for the microvascular complication. So it is a very important close relationship between diabetes and bone. Then there are multiple reasons because of that hyperglycemia or the hyperglycemic load actually harms the bone by multiple mechanisms.
As you mentioned that this is tetropathy, the various terms has been used: diabetic arthropathy, diabetoporosity, diabetoporosis. So multiple terms being used and being coined to effect of diabetes on bone. Professor Badada, what percentage of diabetic people are having involvement of bone?
Yeah, so it is difficult exactly to say that what percentage of patients of type 2 diabetes or type 1 diabetes affected by the bone, but you can say there is significant percentage, and depends on that what is the duration of diabetes, what is type of diabetes, how was the hyperglycemia over a period of time, what are other associated comorbidities. So if we consider all these factors, those are associated, then the prevalence may be go as high as 30 to 40% patients of type 2 diabetes may be having the some or other bone issue, and maybe severe osteoporosis. From one of our study, which is a hospital-based study, in just 253 patients of type 2 diabetes, we excluded secondary causes, and what we found is that approximately 30% of individuals are having osteoporosis, and it was more severe, more common in the females as compared to the males.
Correct. As we are discussing about the prevalence of diabetes, I suppose you would agree with me that the prevalence varies from type 1 diabetes to type 2 diabetes. Can you just enlighten us how these two types of diabetes being affected by diabetes? Are they pathogenesis or the manifestation or the architecture or BMD? What's your comment on the affection of type 1 and type 2 diabetes on bone?
Yeah. So first, before answering your this question, type 1 and type 2 diabetes, our audience might be thinking, if I'll say that type 1 diabetes is more severely affects the bone, and we have multiple reasons. First of all, the hyperglycemic load is very high. The second is peak bone mass is not achieved in type 1 diabetes because of the chronic disease. Third, type 1 diabetes, approximately 10% of individuals of type 1 diabetes are associated with celiac disease. So, and the low IGF-1, actually, these are the multiple factors responsible for the poor bone health in type 1 diabetes. But you might be wondering that in your clinical practice, you don't see many type 1 diabetes patients with the bone issues. The reason is that because mean survival of type 1 diabetes in Indian setting is actually very low. At PGI Chandigarh, if I talk, the mean survival in type 1 diabetes is approximately 35 years. So that is not a usual age to develop the osteoporosis actually. So in our clinical practice, we don't see many patients of type 1 diabetes with the osteoporosis. But in type 2 diabetes, the situation is really very, very grim, because type 2 diabetes induced in India is having the central obesity. And central obesity is an important marker of inflammation. And then onset of diabetes in India is relatively early as compared to our Western counterpart. And because of that, the peak bone mass is not achieved actually. On the top of that, the females, the menopause age is early in Indian patients as compared to the Western population. So low peak bone mass, high inflammatory level, early menopause, and associated vitamin D deficiency actually contribute significantly for the osteoporosis in type 2 diabetes.
What's your comment on the risk factors like the microvascular complications of diabetes, whether they also affect the bone, or only the duration or glycemic control are more important?
Yeah, so you are exactly, I agree with your this statement that microvascular complications are significantly affecting the bone, because the vasculature is same all over the body. And if I call microvasculature, meaning by that when the capillary thickness is less than 10 micron, it is actually called the microvasculature. So this type of capillary, if affected any other organ, that is similarly affected in the diabetes also. So in case of diabetes, the microvascular complication takes place, then their blood flow is reduced, their adiposity is increased, and the repair process is also impaired because of the involvement of the capillaries. So it is a close association with the other microvascular complications. Further, the microvascular complication actually predisposes for the fall, like retinopathy, CKD, foot involvement, all these also predispose to the fall in patients of type 2 diabetes, and we know fall and fracture has a very, very close association.
So if you look at the BMD, aerial BMD of a type 1 diabetes patient and a type 2 diabetes patient affecting the bone, is there any difference, or it's a similar kind of bone mineral density you get?
Yeah, bone mineral density may be even more lower in case of type 1 diabetes, because type 1 diabetes individuals are usually they are short because of multiple mechanisms, and we know that the shorter bone not achieve peak bone mass, so BMD will be lower in type 1 diabetes compared to type 2 diabetes. And on the top of that, the type 1 diabetes individuals are also in microarchitecture alterations because of very early onset of severe hyperglycemia. So very few studies are available at the level of microarchitecture. Microarchitecture is poor in patients of type 1 diabetes as compared to healthy individuals. And our recent data on high resolution peripheral QCT, it clearly shown that compared to the healthy individuals, type 1 diabetes individuals are having severe microarchitecture alterations on the HRPQCT.
So, what is the risk of fracture? We know that the type 1 patients having low BMD and type 2 diabetes patients have reasonably higher BMD. What is the risk of fracture in type 1 diabetes or fracture?
Dr. Kavar, it is such an important question, and I want to answer in elaborate manner that number one, any type of diabetes can increase the risk of fracture. If we talk about type 1 versus type 2 diabetes, the risk of any fracture in patients of type 1 diabetes is approximately 5 times more common as compared to healthy individual. we look at the type 2 diabetes, the risk is approximately 1.5 to 2 times compared to the healthy individual. So meaning by that, risk is 7 times higher in type 1 and 2 times higher in the type 2 diabetes. And it is equally applicable for the hip fracture as well as the spine fracture.
Correct. So to assess a diabetic patient for bone health, what are the tools you use so that this patient is having osteopenia or osteoporosis?
Very good. So there is a there is a issue with the use of the various tools to diagnose the osteoporosis in patients of type 2 diabetes or in type 1 diabetes. So right now you can say the gold standard technique is the DEXA scan only. Again, I repeat, the gold standard technique is the DEXA scan only. In the DEXA scan, if the T-score is -2, we consider patient is having osteoporosis because we use a correction factor of -0.5 for type 2 diabetes as compared to healthy individual, right? So DEXA is gold standard, but DEXA is a problem because DEXA does not give information of the cortical porosity. So to get the information of cortical porosity, you may require better facilities to assess the bone health. So people do use the high resolution peripheral QCT, and which is recently approved to assess the bone health in patients of the diabetes. Earlier it was used mainly for the research purpose, but now it is approved by some of the societies that HRP QCT can be used. QCT also can be used, but DEXA is the gold standard.
What is your comment on trabecular bone score? Because you are yes.
Trabecular bone score has a certain limitations, though there is some of the studies are done on the trabecular bone score, but right now on the basis of trabecular bone score, treatment is not yet planned or not indicated on the basis of TBS. But in addition, beyond that, if you can use VFA, that is a very good technique, and that is done on the DEXA scanner itself, and that will give you the vertebral fracture severity and the grade. Means where is the fracture and what is the grade of fracture. So VFA is very useful. TBS is not that useful and currently not used for the treatment on the basis of the TBS report.
In any patient, diabetic or non-diabetic?
Yes, any patient, right.
And what is your comment on FRAC score for prediction of risk in diabetic patient?
Right. So FRAC score is used widely, and though the diabetes is some of the places it is mentioned, but otherwise they use as a secondary cause of osteoporosis. They tick that instead of mentioning the patient is having diabetes, and they calculate the FRAC risk by that. So diabetes is considered secondary cause of osteoporosis, and that can be FRAC can be used for the prediction of the fracture. And on that basis, when we are in the dilemma and the patient is already having, say, kind of T-score -2 and the FRAC score is high, then we start the treatment in these patients with the help of FRACs.
Yes, I absolutely do agree with you. Even with the lower FRAC score as compared to non-diabetic, diabetics are higher risk of having a fracture in the future. There has been various modification to the FRAC score, like the increasing age or replacing rheumatoid arthritis with the diabetes. So what's your comment on those modification of FRAC score in the diabetic population? How far is acceptable and correct?
Yeah. So I think this is a good idea because we all know that diabetes is a disease which is affecting each and every compartment of the bone, whether it is a mineral component, whether it is the matrix component, whether it is a marrow component, and currently available facilities to diagnose diabetes associated osteoporosis is not that robust. So FRAX is a good idea and that can be used or utilized to calculate the risk. And I'll tell you, like, for example, you want to treat the pre-diabetes, right? Now the people are treating pre-diabetes. Why don't you want to treat the pre-osteoporosis or osteopenia? I can argue with that. So
Yes.
when the diabetes patients are already at the risk, and because it is a multifactorial, then it is nice to use these facilities till we have the better modalities to say predict fracture in the patients of type 2 diabetes with the imaging.
Okay, now after the diagnosing osteoporosis or low bone mass in diabetes, we move to another important clinical aspect regarding anti-diabetic therapy. There are multiple anti-diabetic therapy which increases the fracture risk, and some of the anti-diabetic for good for bone health. So can you please elaborate on those anti-diabetic therapy?
Some of the anti-diabetic drugs should be avoided, like pioglitazone or the thiazolidine should be avoided, because there is a data available with the thiazolidine that can increase the risk of fracture, especially the long bone fractures. So pioglitazone should be avoided. The message to the audience is that any patient, you should ask for history of fracture in diabetes. Now that is an important part of history taking. If there is a fracture, don't use thiazolidine. Second, if the patient is having strong family history of fracture or any other risk factor for the metabolic bone disease, then we should avoid glitazones or thiazolidine. Regarding the gliflozins, there are some study that increases the risk of bone health, but more and more studies are coming and there is no significant effect of gliflozins on the bone health. We did recent one study where you used the standard therapy plus dapagliflozin, and we did all the DEXA scan, HRPQ, CT. At the end of follow-up 1 year, in none of the patient with dapagliflozin group is having poor bone health as compared to the standard therapy. So it seems gliflozins are the safer drugs, like any other oral anti-diabetes. Metformin is good one, obviously that is safe. And insulin, they say that insulin increases the risk of fall somehow because of hypoglycemia. But anyway, as and when required, we have to give that. So in nutshell, I say avoid these thiazolidine. Rest are either neutral or okay. DPP-4 inhibitors are good choice, and the GLP-1 analogs are found to be useful because they stimulate the osteoblast.
Okay. It's a fantastic response and it's a very practical points in treating diabetes with osteoporosis. And the just last point, we are coming to end of our discussion. If a diabetes patient with osteoporosis or T-score -2, then what anti-resorptive or anabolic agent you would like to treat these patients?
Dr. Kavamar, very, very happy to interact with you, and you ask very, very pertinent and relevant, very practical questions. And indeed, to answer this question, we planned a study 3 years back, where what we did is, we have selected the patients of type 2 diabetes with osteoporosis and one control group. And one group was given teriparatide, that is recombinant human PTH. Other group was given zoledronate, and the third group was given the denosumab, that is rank ligand antibody. And what we found at the end of 52 weeks of the follow-up with this three treatment modalities, the teriparatide fared better to increase the bone mineral density at lumbar spine compared to zoledronate and denosumab. But over a 1 year period of follow-up, there was no significant difference in the fall, fracture, or the BMD at the measured at the tibia and the radius. There was no significant difference, except there is bone mineral density was increased with teriparatide at the lumbar spine, and which is expected because that is true for the non-diabetic individuals also. So as of now, I can say that any drug can be used. They are almost having equal efficacy, but in our setting, maybe Jolidinot is a good choice because it is easily available, once a year therapy, and cost effective as well. So I can say at this point of time, the Jolidinot can be a good choice. But if the lumbar spine is the problem, use teriparatide. If the PP is the problem, use use Jolidinot. If problem at the both the side, you can use the denosumab like in any other non-diabetic patient with osteoporosis.
Excellent, excellent. Thank you, Professor Badada. We heard directly from horse's mouth, who really works in the field of bone and diabetes, effect of diabetes on bone. He has lots of work on that. So it was a very informative session. He elaborately discussed about the pathogenesis of bone involvement in diabetes and how to diagnose and what drugs to use, what anti-diabetic drugs to avoid, and how to treat osteoporosis in a patient with diabetes. Thank you, Professor Badada. Thank you for your for enlightening us. Thank you.
Thank you, Dr.
Thanks.
Kumar, for this nice introduction and opportunity. Thank you. Namaskar. Jai
Thank
Hind,
you, sir.
Jai Bharat.
Jai Hind, sir.
Thank you. I think all agree that we had a very excellent discussion between Dr. Badada and Dr. Kanwar. They discussed many aspects about bone disease and diabetes. So many of the questions which I was thinking that I should be asking Dr. Badada have been covered in this interview. So we'll have all the panelists with us. Now we have a panel discussion. I think we have with us about 25 minutes or 25 minutes. We have with us. We need to conclude by about 7 o'clock. Is it, Dr. Kanungo, sir? What do you say? We have about 25 minutes with us. So we have, we additionally now have with us Dr. Ipsita Mishra, who's a young and upcoming endocrinologist from Bhubaneswar. So who's joined us now. So we'll start off the panel discussion. We have with Dr. Kishore Behra with us. Dr. Kalpana Dash is also there, and then we have Dr. Sanjay Badada in person now. We were hearing his recorded conversation. Now he's here with us in person. So I'll start off by requesting Dr. Ipsita. Dr. Jayant Panda is of course there with us throughout the session, and he'll be taking part in the discussion. I will start off by asking Dr. Ipsita to give us a broad overview of this musculoskeletal complications of diabetes. What do you think, how important they are, and what are the various components and all that? Can you just give us a broad overview of that?
Thank you, sir. I thank Alok sir for giving me this opportunity to be a part of all the eminent people present out here, all my teachers and ever personalities in the field of endocrinology. So taking up your first questions, we have already heard from Behra sirs, Badada sirs and ma'am's discussions. So broadly, the musculoskeletal diseases in diabetes, if you look into, they're classified into those which affect the fibromuscular part, secondly the joints, and third the bone. So this is a broad overview of classification. And then if we go into the fibromuscular part, what we have and we are aware about is the chiroarthropathy part, the periarthritis part, then so the CTS part, and the trigger finger part. So this is related to the fibroproliferative diseases of the soft tissues. Then if we go into the bone parts, sir has already given us the overview of osteoporosis. And apart from that, the fracture healing is also problematic in diabetic patients. And then one entity which is described but rarely diagnosed and treated is the idiopathic hyperostosis of the skeleton, that is the dish part. So that is one entity which is also included but rarely encountered or rarely diagnosed. And then the joint related, most commonly what we see, initially it was Charcot's, but now most common is probably osteoarthritis, followed by gout, and then the Charcot's. So this is the overview classification of the musculoskeletal problems in diabetics.
Thank you, Dr. Ipsita. So we'll come to Dr. Badada and ask him about, how do you, we had a very interesting discussion. We'll not repeat all the parts that were asked to you, and you'd already covered about telling us about, about how bone health differs. I mean, bone, the measurement of DEXA in type 1, type 2, and also you discussed about the various aspects you discussed. But what I would like to ask you is that what is your practical recommendation? How do we assess bone health in our patients with type 1 diabetes and in patients with type 2 diabetes? What are the practical ways in which we can look at that?
Thank you, Rakesh. So actually, the first and most important thing is that we should take basically bone health is an important complication of diabetes. First of all, we should understand our fraternity that bone is also affected. And if we consider any complication as a part of diabetes, then it will go like any other medical condition. Like we talk about the retinopathy, and we'll ask our student take a detailed history of retinopathy. Fine. Similarly, here also we should ask our student take about the bone history detail. Patient having bone pain, having a backache, having a history of fracture in the family members, anything. This type of information will help us to understand estimate the burden or the up to certain extent this information what is there. Then of course, obviously I can understand HRPQCT is not available everywhere in India, and I'm sure it will take more a decade at least to be more widely available. And so it is currently a research tool only. But the DEXA scan is good one that can be used, and we should use VFA, which is available in DEXA. That is just a software, and that can be lateral scan can be done, and that give you a lot of information about the spine fracture, which is actually often missed because in general when we talk about the fracture, meaning that in our brain we think it is a long bone fracture, it is not a spine fracture, and that's why the spine fracture you want to assess. Then VFA is very good technique. The advantage with VFA is compared to the spine is that if you see a lumbar spine X-ray, often we see two borders at the end of the vertebra when take a lateral spine X-ray. But VFA is a beauty that it will give you a single border, and that will help you to understand the site of fracture and the severity of the fracture. So I think what is available facility we can use like X-ray, we can use VFA through the DEXA scan, and if the DEXA is as mentioned with Dr. Kamar's discussion that if it is -2, we should treat them. And of course, vitamin D deficiency is very common in the diabetes also. So all patients should be given the adequate amount of vitamin D. And maybe some dietary restrictions are also there. So they may be also adequately supplemented with the calcium, at least during the perimenopause period when the in diabetes the diet is less and there is less calcium and calcium intake.
So in our diabetic patients, when do you recommend DEXA?
Yeah.
Type 2 diabetes and type 1 diabetes.
Right. So actually in type 1 diabetes, I'm not really sure what is the age of cutoff, but yes, because in type 1 diabetes, celiac disease is very common. At least in our population, approximately 10% of patients of type 1 diabetes are suffering from the celiac disease. So after adequately supplementing with calcium and vitamin D for at least 1 year or so, then we can go for DEXA scan in type 1 diabetes, especially is having any bone related symptoms. Coming to the type 2 diabetes, there is no separate guideline that there is any, they brought down the age of say screening for the osteoporosis. But if you remember, and that because ISBMR is came with the information that we should reduce at least 5 years age as compared to our Western counterpart, because our mean survival is just 72 years or 74 years, and they recommend the DEXA scan after the 65 years in the male. I think does not solve the purpose. So we already reduced that, and we stick to that same age in the diabetes and non-diabetic individuals, the same age.
Yeah. So, I mean, coming back to this, do you think the FRAX you spoke about FRAX being a good tool, and because it doesn't require any further tests and all that, we just need to put in some information. So how often should we use that? And as I understand that it is validated for above 40 years. So should we do it in all our, say, type 2 diabetics above the age of 40? Would it be a good practice to put their data into the FRAX and see what is their fracture risk?
Yeah, yes, I think there is no harm in that, and because it is just available online tool and it hardly take more than a minute, less than a minute in OPD, and the beauty is that even it is basically can be used without BMD also. So you don't have BMD, still you can use. But the problem with the fracs is that you can start the treatment, but we don't have fracs to be followed for the treatment part. So that is one of the deficit with the fracs. So, but yes, that is there, and this lot of information. If you use the fracs, then you get lot of information. Actually, that itself is also very useful information to assess the bone health. All these 10 or 12 points are there.
Yeah, but I think those who are having a higher risk, probably they can go for a DEXA before we start therapy. I mean,
Yeah,
if we need to
yes.
start therapy, although DEXA will not be, may not be indicated by their age, but I think then we can still do a DEXA, and then that would be helpful for following up. But in type 1, that problem still persists. So I think we need to come out with some statement on how, when we should,
Basically, type 1 diabetes, the major problem, Dr. Rakesh, is that they even not achieve the peak bone mass, because
Yes,
sort of diabetes, their peak bone mass is not achieved. So it's always a confusion. They often short stature. So we know that stature is one of the determinant for the bone density assessment. Actually, they use the lower bone mineral density because of the small stature. So that is also another. So I think we need more work in this area before I make any straight comment that. But if there is any risk factor, I say that we should supplement with adequate calcium, vitamin D, and can go for the bone mineral density assessment.
Yeah, thank you. We'll come back again to you. But before that, I'll ask Dr. Kalpana Dash about. She spoke about amyotrophy and the various ways in which we can diagnose that. How often it. It is an uncommon complication. But coming to some more common complications regarding this. We have this periarthritis. Can you tell us something about your experience with periarthritis? How would you deal with this problem in our patients with diabetes? Because it's a very common problem.
Most of the patients, when they age, normally those patients more than 55 years, they're having periarthritis, and especially those patients who are postmenopausal women. Male, those who are obese patients, they're having, they usually present with periarthritis, but normally we ask them to lose weight so that they can have symptomatic relief. And as far as the pain relief is concerned, so normally we avoid giving the NSAIDs. So we just ask them to give maybe just paracetamol, weight loss, and some modification in the lifestyle. So basically, it's just, I can say in females, they're having mostly periarthritis, postmenopausal patients. So when the patient approaches to us during the perimenopausal period, so we ask them to not to gain weight, because normally most of the women in our field, they tend to gain weight during the perimenopause. Just as soon as they attain menopause, there is significant increase in the weight. So during that time, normally what I ask my patient, so whatever diet they used to take before menopause, they normally should reduce their diet, and they should have more physical activity so that they can at least maintain the weight. If at all they can't lose weight, at least they can maintain weight. So this is how we just ask them to reduce their weight, and that's how they can just reduce the incidences of periarthritis.
Yeah, and I think physiotherapy and shoulder exercise
physiotherapy, of course,
have a very important role. But how often do you need do you need injections, steroid injections, and
no, I don't prefer the steroid
do
injection.
you recommend any of
Rather,
it?
just a local application of something. I just ask them hot fermentation and local application certain analgesic cream, something like that.
Yeah,
Maybe sometimes just pregabalin also, that also helps sometimes.
Yeah,
Because
so
most of the patients are having neuropathy, so even pregabalin sometimes helps.
So
But in such kind of patient, actually, I ask all my patients to go for a DEXA scan, because if there is some amount of osteoporosis, so when I treat them, so most of the symptoms actually that subside. So I normally counsel my patient like that, because bone is the framework of your body. So when there is osteoporosis, obviously the physical activity of the patient will be limited. So go for a DEXA scan if at all there is osteopenia or osteoporosis, get it treated so that patient can, at least the physical activity of the patient will be good, and the blood sugar, by that way probably the blood sugar will get controlled. This is how I approach to my patient, just to get a DEXA done so that maybe I can treat them.
Thank you. So let's ask Dr. Badada about the correlation between osteoporosis and
Physical activity.
arthritis. You think you are seeing some
Diabetes control.
often? I think there's some problem in connection. So we'll move to Dr. Baira and ask him about. He spoke about sarcopenia and how common it is in patients with diabetes and how it has an impact on the progression of diabetes and all the complications of diabetes. So can you tell us? You were talking to us about the study that you were doing, and you said that you found about 35% of your patients had sarcopenia. So can you tell us, shed a little more light on that, on your own experience?
Thank you, sir. Actually, we had 1 year back one study, that time 2 years back before COVID. So we don't have a DEXA scan at that time, which I have quoted. This is a thesis has been given to physiology, and I was the guide. So what we found, we used the appendicular skeletal muscle by using the equations. So in that we found that those are having neuropathy, and they are around 60% having sarcopenia. Those are not having neuropathy. The sarcopenia is around 40 to 45%. That is 2 years back. And recently one study that is been done, elderly type 2 diabetes, those are having, this is a non-funded project. So we didn't assess the 25-hydroxyvitamin D, and some patient we did PTH. And what we found, around 30 to 40% above age of 60 above. And what is more related to like BMI, if they have a low BMI, that is more significantly, those are having low BMI, they have a sarcopenia around 40 to 45%. The another one, what I quoted, that is Dr. Conwer, they have done a study. They have a case control study. They found around 35% by using the 2019 ASEAN criteria, and they found around 35%. So still what I found, probably the most important factors we could not find out by univariate analysis, like H1AC, fasting, postprandial, SCR, retinopathy was not correlated, but I have not analyzed fully. So still the data, what I found, the BMI is the most important. And in our previous study, when we found the neuropathy, we found that metformin, those are patients on metformin, they have a less sarcopenia. Otherwise, all other drugs are not related to any sarcopenia. That is what we found our findings. So we have given another thesis where we are taking diabetes of more than 50 years, and where we are seeing the sarcopenia and sarcopenic obesity, because you have a DEXA now. In that group also, we want to look at what is the prevalence of osteosarcopenia. So these are the study already been through by our ethics committee. So we'll be working out within 1 month.
Your recommendations on the use of anti-diabetic medications in patients with sarcopenia, which are the ones are good, which are not so good for patients with sarcopenia? Do you think?
Definitely, I think, sir, there is no controversy. I think everybody knowing, probably the metformin, there is no controversy that metformin we should use, and SGLT2 is neutral, and insulin also, because it has an anabolic hormone, probably it may help. Probably the drugs we should avoid, probably SGLT2 have some studies showing probably they have some bad effect in bone, and because the insulin, they can have because the elderly, if they have a hypoglycemia, they can history of fall, probably that drugs. And pioglitazone, if somebody having a risk factor for osteoporosis, we should avoid. But so far as the metformin and DPP-4 inhibitors is concerned, we can use without any problems.
Dr. Sanjay, would you like to add to this? because you have spoken about the SGLT2 inhibitors and the controversy that was there regarding their effect on the bone being sorted out with the larger studies now, not showing any effect on the bone health itself. But about the effect on sarcopenia, what is the effect of SGLT2 inhibitors on sarcopenia? Do you think they have a negative effect or they are good for the muscle?
Yeah, so SGLT2 inhibitor, we know that it reduces the weight and there is loses the fat mass, but simultaneously also loses the lean mass also. So there is some effect of SGLT2 inhibitor might be on the muscle mass, and that muscle mass, is it enough to cause any problem to the bone health? So I think there is no data on that. So, but with relation to the SGLT2 to bone health directly, in study with randomized control trial at our place with the HRP QCD data, we found there is no significant harmful effect of SGLT2 inhibitor on the bone health.
What about the GLP-1 analogs?
Yeah, GLP-1 analog is one of the good drug for the oral musculoskeletal health.
Because they reduce weight, they also cause more weight loss. But the weight loss, is it the muscle loss, the fat loss? It's predominantly fat loss, but what is the effect on the muscle and bone? I think there's a little network issue.
Sir, I would like to answer that.
Yeah, please.
GLP-1 receptor actually that increases the mesenchymal stem cells formation to the bone osteoblast formation through the RUNX2. So that activates the RUNX2. So from mesenchymal stem cell to it activates the formation of the bone cell, that is osteoblast. So GLP-1 receptor are actually good for the bone. I do not know about the muscle, but they are very good for the bone. So because of that thing, there is more of bone formation. So I think if you suspect somebody is having osteoporosis, likely to have osteoporosis or risk of osteoporosis, the GLP-1 receptor agonists are actually good anti-diabetic to use.
Thank you. So we'll ask Dr. Ipsita about, you're speaking about the joint involvement in diabetes. Could you tell us something about the osteoarthritis and also about could you tell us something about that?
Gout and Charcot. So osteoarthritis, of course, are in comparison to the general population, the prevalence of osteoarthritis in diabetics, it's well known that it is more. So per se, aging, obesity, excessive weight bearing, lack of physical activity in the initial years of the disease. So it ultimately leads to that problem of debilitating pain, mostly the females, because of the weight distribution, mostly it's a complaint which is found in the female related part. So, and we all know, sir, osteoarthritis per se does not have any definitive treatment modality until and unless it is debilitating, where they go for a replacement surgery. Probably when it is there in the initial time, it's very difficult for a weight reduction, as ma'am had already told. Once they go into the in and around menopause and post-menopausal part, so at that point, weight reduction, even if with drug therapy, GLP-1 analogs, or little bit with SGLT2 inhibitors, if they're taking, the targeted weight loss is not that much adequate. So prior training, prior physical activity to strengthen the ligaments, the joints, the tendons, initially will rather prevent. But once it has set in, management is symptomatic with physiotherapy, with exercises, with symptomatic treatment. So that is about the osteoarthritis part, sir. Charcot's is another joint-related issue. The occurrence of Charcot's has definitely come down in past recent years, but it does occur, and I'll not go into detail of managing Charcot's acute and chronic ones, sir. We know that. And then, of course, that is another entity which is relatively more in diabetics in comparison to other population is gout, because we know that hyperuricemia is one of the metabolic health issues, and rather it is a mirror that probably the patient can have dysglycemia and T2DM later on. So that is one part. If it is presenting to you in the acute phase, then with analgesic symptomatic treatment and the ZO inhibitors that can be managed. So osteoarthritis is the joint problem, which is on a huge burden. But honestly, once it has set in, the management part in the middle-aged females, I do not think other than a symptomatic treatment, we can do much of benefit to that part.
I have one question for Dr. Badada.
Yes, yes, ma'am.
Have you seen in the chat box?
Yes.
So, young girl with POI, osteoporosis, would you give bisphosphonate or only estrogen replacement is enough?
Okay, fine, ma'am. I think we can segregate this question in this way that if you are really want to treat the bone health, I go for the zoledronate or bisphosphonate. If you want to treat both condition, patient is having say, okay, you are talking premature ovarian insufficiency.
Yeah.
Yeah, obviously we will go for
POI, yes, premature ovarian insufficiency.
we go for the estrogen. Yeah, we go for this.
Only estrogen will do. We won't go for anything like bisphosphonate, zoledronic or something. No.
Estrogen with calcium, calcium.
That is enough. That is enough. Okay. Okay. Thank you.
You can at least give a fair trial of that, of treatment with the E plus P and the calcium, adequate calcium, vitamin D. The response is not good. In that case, we can add the bisphosphonate. But maybe in POI, primary therapy is estrogen. Like we treat on primary.
What is the cutoff dose, sir?
Until unless is having some fracture or something like that. If there is no fracture, just BMD is bad, then we can treat with that. That is better idea.
So I think that is again an indication for doing a BMD earlier, not waiting for her to become 50 years, 50 to 55 years to do a BMD. You may do a BMD within 5 years of menopause, that we would generally say. I mean, whether it is natural menopause or maybe POI, whatever it is, do a BMD. And if we find that there is significant osteoporosis not improving with estrogens, need for, I think, zoledronate in such situations.
Any secondary cause is there, definitely we have to.
Definitely. This becomes a secondary cause.
Forgot to mention about the frozen shoulder. You asked me about the periarthritis. So that has to be considered during the discussion with the patient. And also it has been shown that the retinopathy and albuminuria, that is also much higher in case of those who are having periarthritis.
Yeah, a quick question to Dr. Ipsita about this trigger finger, and how do you how often do you see that, and do you think that is I mean, you need any special medications for that, or it's just the physiotherapy that helps?
Trigger finger, sir, what I have seen during my training period and currently after my training period mostly occurs in those who have very poor glycemic control, middle-aged, not the younger ones, relatively middle-aged, and those who are follow a kind of inactive lifestyle, who are not into any kind of physical activity which is recommended. So physiotherapies are definitely what I say recommend, which is practical, is use a smiley ball into a lukewarm water and then squeeze it at least 15 to 20 times a day, and that really helps on a continuous basis. Along with that, sir, some supportive management with pregabalin or a combination of pregabalin and duloxetine that helps out. But then those who have it persistent in spite of everything, so then it becomes difficult, and they go later on probably they go into a state of contracture. So that is what I have seen is very rarity of that. But then the trigger finger initially, if a good glycemic control is there with this supportive management, it does subside.
Thank you. So we'll have one question for Dr. Badada about the bone markers, bone resorption markers. Do you think they are important in people with diabetes?
Yeah, so Dr. Rakesh, right now actually they are not used as a what you call to initiate the treatment or to follow the treatment in diabetes. But I think if I'll say I'll give an analogy, like you have a HbA1c and you have a SMBG in diabetes, like so bone turnover marker is something like that. Blood SMBG, while the BMD is HbA1c. So it will take 3 months to understand. Here it will take 1 year to understand there is any change in BMD or not. So if you look at the future, and since I have a facility at our institute to the bone turnover markers in the not very costly, we do in 600 rupees. So we do almost most of the patient, those are on treatment for the osteoporosis, irrespective of diabetes or no diabetes. We do that. And we even monitor our therapy of denosumab with that. Say patient comes, the CTX is suppressed at the end of 6 months. We don't give next injection. We'll ask the patient to after 2 months. We repeat the bone turnover markers. If the CTX increase, then we'll treat with the denosumab, otherwise not. The reason is that because 60 milligram therapy is actually the Western data, not for the Indians. We have not studied the per kg body weight. This dose is not there. So that is useful, and I'm sure in coming in big way this bone turnover markers for the management, at least not for the diagnosis of course.
Yeah, but at the present time, when it costs as much as the denosumab therapy, then I mean half the cost of denosumab therapy, then we would rather give the denosumab than do this marker and give it there. So
I
for,
agree. I agree.
routine clinical practice, I would say. But
I
when
agree.
you have the facility for doing it, you are able to decide when to give the denosumab dose. Ipsita was adding something, yeah. You wanted to add something? Yeah. Okay, Dr. Behra is also here with us. Would you like to give your final comments about about this session? I mean, in this session, what is the final message that you want to give about sarcopenia, and so that Dr. Alok is telling us that we are
No. Continue.
Yeah.
Please.
Continue.
Yeah, please give your opinion on
Yeah.
final words
The
on
discussion is very good. The
Yeah.
discussion is very, very good and productive. And this topic is very unusual topic. And especially the experts are very thorough in their subject. I'm confused whether Ipsita is an endocrinologist or a rheumatologist now. And Kalpana ma'am has directly asked a question related to the young girl and the zoledronic acid. So very interesting session, very informative data. So we are patiently hearing now everyone.
Hey,
Let us
Dr.
go
Panda,
ahead.
it's
Yeah.
sheer presence of Professor Badada that made the session interesting.
Very, very interesting.
And
Very
it's a
interesting.
rare opportunity to have him. So we
Yeah.
should listen as much possible from him.
Thank you for the opportunity. My last word is that bone balance is better than bank balance. Not a diabetes. So please take care of your
Yeah.
bone balance
So
rather than the bank balance.
So we should encourage all our diabetics to actually build up a good bone mass and also a good muscle mass and lose the fat.
Yes.
Actually, we physician attend many programs. So now I'm feeling like staying in a rheumatology or orthopedics discussion rather than endocrine discussion. Very productive, and especially in diabetic, this
We have
topics.
taken over everything. We don't need to go anywhere.
Yeah.
Not to be here only.
One point of all, one solution point of all problems. Let us go ahead. Yeah, let us go ahead.
Yeah. So we'll ask Dr. Kalpana Madam to tell us, give us our final message that she wants to give to everybody about this topic.
In fact, I would say I enjoyed the whole conference. I must congratulate Dr. Alok Kanungo for conducting this meeting since past 16 years. I believe it is 16 years, sir.
10 years.
Kanungo, sir, 10 years, 10 years.
This
And I
is
have
10th.
been a part of this meeting since past 10 years. And really wonderful meeting. But I would suggest that the delegates should be much more, because the standard of the meeting is so high. It is really high. So the delegates should be much more.
Madam, what you are seeing only faculty screen. There are many more delegates are there. They are watching.
They are
Is
watching.
it?
Yeah, yeah.
Okay, okay. Then I don't know. Then I don't know.
Many more.
The faculty.
You may get many photographs with the screen.
You are Kalpana ma'am. You feel that you are on stage. You are speaking.
Okay.
You are unable to see the crowd. The crowd will
We have
be
10,000 registrations.
1,000 registrations.
Yes. So many people are watching. You will get the photographs with this photo computers that you are saying we are listening.
And that is the beauty of a virtual program. The viewers are many. So that's why even if we are doing physical, we are making it hybrid so that people take the benefit. So think of the takers of your discussion.
I'm really fortunate to be a part of this conference actually. And since morning, I have been listening to all the topics, and it was really grand. Thank you so much.
Yeah.
Regarding the topic, everyone they have said, and I loved to hear from Professor Badada and from everyone. And Ipsita is really wonderful.
Yeah. So Ipsita is also,
Girl,
yeah,
the
before we
body,
ask
girl,
Ipsita,
and lady endocrinologist in Odisha. Okay.
yeah. So I think before we ask Ipsita for a concluding remarks, we'll ask her to speak about dish. She spoke about dish, so tell us something about that.
Yes, sir. That was a question which was asked to me during my training period. So I went into that because there was one patient, and I was asked, "What is the other differential for this low backache? Low backache, the patient, diabetic patient, is telling." So that time I was just a first year trainee. I didn't hear about this word. Then when I digged into, I found that okay, this term really exists. So, sir, this is a problem where there is abnormal calcification of the ligaments and the tendons, enthesis, the site of insertions. So especially if the anterior longitudinal ligaments of the spine are involved with that, the prima facie pathophysiology is again the abnormal deposition of the AGEs. So once they are, the entire ligament is involved, these glycation products go and stick to them. So there is a kind of a dystrophic calcification also at those sites. So they present to us with a back pain, which we usually think that probably this is either a stenosing pain, or it is a neuropathy related pain, or it is a osteoporotic related low backache which is there. But the etiology is something else. And usually those patients who are obese, are having uncontrolled dyslipidemia, hyperuricemia, these are the trigger factors. And sometimes for this, if you want to release the pain part along with the symptomatic treatment, along with pregabalines or other gabapentinoids, you may need to consider giving steroids. That is what was a deductive of that. And sometimes the calcification may be so extensive that it may need a surgical release. So, but then that is a rare entity, but does exist, and that was I was asked about this.
Thank you, thank you. So let us ask other faculty if they want to add something to this about their experience about diffuse idiopathic skeletal porostosis. Dr. Badada, Dr. Bhaira, or Dr. Kanwar. Anyone wants to?
Actually, osteoporosis has to be explored more in diabetes patients. We are neglecting in that direction. Because most of the centers, they don't have the dextromethorphan. Even some cities, they don't have. And that is also very expensive.
Now, many advanced glycosylation end product like AG products like pentosidine, you can assess serum or urinary pentosidine to look for the risk of osteoporosis in type 2 diabetes. These are also coming up. So many new things are coming up in diabetes and bone. So we should more venture into the diabetes and bone. As Sanjay sir said, that's a new tetraopathy, or that's called diabetic arthropathy. So you should more venture into these aspects. That's NUCD has given a new insight to look into these aspects also in diabetes and bone.
One thing I would like to add, because Dr. Behra, he discussed about the sarcopenia. So should we just go ahead with a diet? I mean to say in the elderly population, like more of protein, so that that can have a good role in reducing the sarcopenia. Like normally we give carbohydrate as 60% and protein maybe just 20%. So can we just give maybe 30-40% of protein instead of giving 20% and reducing the carbohydrate, because protein is the only one element that doesn't get deposited in the body like carbohydrate and fat. So can we have something like that?
Sir, madam, what I reviewed and I've seen lot of meta-analysis, then what is found the most important, the first line treatment is resistance exercise or plus resistance exercise plus protein supplementation. Yes, they say probably if you have a vibration component also with the resistance exercise, then probably they have a more muscle mass will be there. And they found probably 1.2 protein what they have recommended, and some special situation you can go more than that. But that protein, again, they've told that the protein should be mostly of
high biological value.
yes, high biological. They have a leucine like animal protein, because they have a more essential. But we cannot give, ma'am. That has been no study has been done, but they have. It will increase also, because the old age elderly type 2 diabetes, we can't give more protein. That is the drawback. So we can give maximum, ma'am, according to the EGFR, according to the kidney status. They told 1.2 to 1.5 is fine. Beyond that, then you have to really reassess the EGFR and the kidney status, and particularly in type 2 diabetes, elderly type 2 diabetes beyond 60 years and old.
Because as the EGFR comes down, we need to restrict the protein to avoid
One of the
damage,
sarcopenia,
abdominal
Rakesh
damage
and
that
Kishore,
can happen. Yeah.
is what is found today with the treatment of GLP-1 array and also with other weight reducing drugs. So there, this sarcopenia is partly because of the drug and partly because of the hedonic pleasure of eating is taken away.
Yes,
And
yes, yes.
they will not possibly take that much of protein, Kalpana. I think they even 0.6, 0.8 is difficult for them to take. So that's a big issue. But as you rightly said, the resistance exercise and some amount of protein supplementation is going to help. But I don't think there's any way of taking care of that sarcopenia.
And sir, particularly what some studies they show, probably the milk protein, whey protein, probably better than the plant protein. So, but there is no, I mean, much difference between the types of protein. But the animal protein, they say probably little better.
Ashok sir is not having sarcopenia. I won't support for the protein intake.
Yeah. I think Dr. Kanwar, a lot of the young people today, bodybuilding, take the whey protein, other proteins, and we know what they land up with. They land up with kidney problem, and that's the issue that has to be. I think one has to accept something. The number two,
we do have limitations.
I was just watching. I didn't ask Sanjay, what is the role of adipogenesis in the bones? That is a great part in the diabetes. Am I correct, Kanwar? There's a lot of adipogenesis, and that also one of the contributing factors for all that you discussed today. Fantastic discussion, great. And the divide between type 1 and type 2, one having the BMD more and one having the BMD less. No, that's possibly a good. I know Sanjay works on diabetes in the young, so that will be a good thing to look at. What do you think? The divide between the type 1 and type 2 as bone is concerned, one having a BMD much less and one having a BMD high. Am I correct?
Yes, I think that divide is there, where we see that type 2 diabetics, when we look at their bone density, it appears to be good. It appears to be normal or sometimes even higher, but still they have the higher risk of fractures. And that's because of the bone quality being affected, as Dr. Badada very nicely illustrated those aspects. And he also talked about type 1 diabetes, where the peak bone mass itself may not be achieved many times. So that's the reason why they tend to have a much lower bone density.
I just missed the initial thing, Rakesh, because SR Arvind was on the call. What was it first?
No. What I was saying was that type 2 diabetes tend to have a normal BMD or even little higher, and we are, but this
the higher side, but type 1 is less.
Still have a higher fracture risk, and that's the reason why we for the diagnosis of osteoporosis itself in patients with diabetes, we use a cutoff of -2 in the T-score rather than -2.5. So that's the new recommendation from the Indian Society of Bone Mineral Research. In their new recommendation, recent recommendation, they have suggested that this should be used as a cutoff for diagnosis of osteoporosis in people with diabetes.
Yeah. They do have problem with the microarchitecture in type 2 diabetes. They have trabecular structure is normal, but increased cortical porosity is there. So that's the way increased risk of fracture.
I was told that
this -2 will be applicable to diabetes in all varieties, like type 1 diabetes, type 2 diabetes, and FCPD, or it is differ?
Yeah, type 1 diabetes, when you're looking at younger ages particularly, then you're looking at the Z score rather than the
Z score,
because they have not actually reach their peak bone mass. So then we need to actually look at the Z score and not the T score. And
Yes, sir.
this is particularly applicable for the older type 2 diabetic patients, where we are looking at a T score of less than 2 as a cutoff for diagnosing osteoporosis.
But if you were seeing the diabetes young where the age is less than 35, probably we'll take the Z score.
Z score.
Yes,
Yes,
yes.
sir.
Rakesh sir told ki we have to discuss for 20 minutes till 7 o'clock. Now it is 7:30.
Yeah, 7:30. I think we
Rakesh, kindly
conclude and conclude.
You
We have
know,
Professor
Manoj,
Das. He will
the
give the
irony,
final concluding remarks. He has been
one
the
speaker.
sutradhar of the whole conference, and he will give the final concluding remarks.
No, Rakesh, before that, I must tell you that, in an assembly, speaker doesn't allow to speak.
Yeah.
Non-teaching teachers, not operating surgeons. So Alok does not belong to that category. So he said, let the discussion continue because he doesn't want to stop. It was a fantastic session. I really enjoyed it. And I was just thinking about also the bone alphas. There is some studies, bone alphas, bone fraction, the alphas fraction, which origins in the bone. There are also some defects recently have been described, which are important for the diabetic bone disease. But I don't know much about it because it's not my area. But it was a dissertation for a PhD in the biochemistry. We have about 300 PhDs, PhD students. I don't know where from they arrive, but it has become very popular PhD program nowadays. And some interest data from there. But the session was fantastic. I think Dr. Kanwar did a wonderful interview with Dr. Sanjay Padada. Kishore spoke very well. Kishore, it was really good. And
thank you, sir.
Dr. Punia, very good. And Kalpana, I don't know where you got that article. When we were in the earlier days, we only used to know if there is a diabetic amyotrophy, treat diabetes with insulin, they will recover and the muscle will fill up. But I didn't know about the use of steroids and immunomodulators in the garden variety cases. You also said sometime it may be necessary. I have never used, even though we had a series in King's College of about 30 cases, it's published. But we had lot of recurrent Garland syndrome. The beautiful.
But actually, recently I had a case. I had given immunoglobulin, IV immunoglobulin.
I saw the diabetic infarction, muscle infarct, DMI. I saw it in Calcutta because I was there for some judging, some papers, and I found that DMI is a great entity. They give it as just a swelling in the hand, Rakesh, and very severe very tender to touch. And unless you know that it happens, you won't be able to diagnose. And Ipsita was good, and in the initial stages, and fantastic, Ipsita. Congrats to you and Hudanand and fantastic. Ipsita's mother is my sister's classmate, Shiny, and fantastic, great. And I think we had a great session. Thanks to Alok and Jan for organizing the session. And Rakesh.
Excellent session, sir. Very informative.
You coordinated the session extremely well. Absolutely.
Yeah, and Dr. Rakesh's question were very practical.
Practical question.
Absolutely.
And then all the
One question, sir, one question to Professor Das.
Yes.
Shall I ask, sir?
Yes, please.
Please.
Sir, you don't get tired?
No, I mean, I somebody asked me, are you retired?
Since months you have been anchoring the session.
Retired. I said, I am not even tired.
If there are no sessions, you would be tired. If there are sessions, you would be tired.
That keeps them, fresh.
If you love what you are doing, Kalpana, that's what Dr. Kanwar is telling. If you love what you are doing, is great. Dr. Kishore Behra and Dr. Dukhabandhu Naik, they talk every day. Dukhabandhu is the head of the department in JIPMA. So does Kishore anytime get tired? They're very close friends. His friend from CMC fellow. I know they talk every day, they talk to each other. They never get tired, so something you like. No, I'm really very happy. The sessions were very good. And, we should take it forward. And today I read something today I heard something which was great. I had noted yesterday. That was the token by Dr. P.C. Sahu. Let us end the day with that. I think Madam is doing puja, so that sound will be there. I just will tell you loudly that what happens yesterday, Dr. P.C. Sahu, Rakesh, I think that's what also Manisha your better half. You are the host.
Yes, you are in the second.
Manisha told that at the concluding remark yesterday, Professor P.C. Sahu, whom Alok and Jayant picked up, he said one Bill Gates quotation. He said, these conferences are good, but what is most important, what you learn, you must implement. I remember Manisha picked up this sentence. Remember, Jayant? Alok? Manisha
Yes, yes.
ended yesterday with that.
Yes,
Let me today also end with that comment.
yeah.
It's most important that we must implement what we have
Yeah,
learned.
what we
I
learn is
remember Dr.
not
Jan Panda
important.
saying 7 golden points.
Yeah, that was by
Huh, huh.
Bill
Seven
Gates
golden rules
quotation.
and
7 golden rules by Dr. Sai. Yes.
Yeah.
and then putting to practice what you learn.
Yeah, is absolutely
Learning
exactly what
itself.
he said. Exactly. I liked his talk. Pichisa was good, and that this particular part I remembered when I saw. I had a small notebook like like Dr. Samjivi Moses. So I saw the first sentence noted in this one. So that's let us end with that note today for the Alok's great conference that we'll try to implement and take it forward for the patient care. All that we have learned today. Thank you very much. Great honor and pleasure.
Thank you, Ashok Bhai. With the esteemed faculties present,
Yeah.
we'll
That's
take
great.
5-10 minutes to complete the valedictory. And
Okay.
with all your presence,
Yeah.
please give the valedictory lecture.
I think I should say that 10 years back, it was a great beginning. Over the 10 years, there has been a well continuation. And mind you, Alok and Jayant and my dear colleagues, esteemed faculty, there is no end to NUCD. There will be an endless progression. Thank you.
Thank you. Jayant.
Sir, the most important thing that we have learned over years is to learn, to unlearn, and to get updated with science. When it started with an ambition of updating the doctors in the field of diabetes and endocrinology, the purpose was very clear. And we had so many physical meets, we had so many virtual meets, we had taken anybody and everybody in the country in the panel. And Dr. Kanungo has made a ripple over the globe by NUCD. We had international speakers, we had national speakers, we have regional speakers, we have state speakers, and many faculties as chairpersons. Till now, it's a much short for event for learning, and especially the structure that we are following for a couple of years, the talk, the debate, the interview, and panel. This is out of the box what I feel, and that gives a clarity on the theme that we take. And this all practices our excellent faculties and the continuity over the years, good shines has made NUCD popular. So I congratulate Dr. Kanungo. We are there all with him. Dr. Abhaya, Dr. Shambit, Dr. Kanwar, Dr. Jayashree, Dr. Devashish, and then the whole team, Dr. Kishore, Dr. Ipshita, we all are there. Odisha, we have no differences between physicians, endocrinologists, and subspecialties. We all together work for the cause and see that the purpose is done. And you see who are there. And this is by the great effort of Professor Ashok Das, the son of the soil. He has taken a lot of pain every time to make a very good program with best of the speakers,
I'll tell you a joke. I'll tell you a joke. I called Sanjay Badada and I just told him, Sanjay and me work together in diabetes in the young. He said, sir, before you, Dr. Kanwar just now called me. So, Sanjay was so happy. And, I think you had just called him. Am I correct, Kanwar? So he said,
Yes, sir.
he had just told me, sir, and I'll be there. I'll be now. You have
NUCD is a forum. The NUCD platform where Odisha connects the whole globe in the field of diabetology and endocrinology. So I congratulate the team. Thanks the great speakers and the panelists who have participated in the event last 2 days, and wish the good work will go on. Thank you. Thank you all.
Thank
Thank
you.
you. Good night.
I think Alok, concluding
Few
remarks,
lines
one
from
sentence.
Rakesh. Few lines from Rakesh.
Rakesh
Yeah,
might
I think I should congratulate
Rakesh,
Dr.
here.
Yeah,
Rakesh,
Dr.
please say
Dr.
one or
Kanungo.
two.
Yeah, my sincere congratulations to Dr. Kanungo, Dr. Ashok Das for the excellent program, and the entire team, Dr. Jayant, Dr. Kanwar, Dr. Kishore Bhairab, and all the others are here. Dr. Ipshita is here. So I think excellent program. Over the years, I've been attending many of the programs. I've been part of many of the programs, and I've seen that the format, particularly last 2 years, I think we have been following this format, and this has been particularly a very educative format where I think all the attendees are benefiting from this format of program. And I thank all of you for inviting me for this excellent.
You are our most favorite.
Yes, sir. Yes,
Kalpana,
sir.
2 lines. Kalpana, 2 lines.
No words, sir, that I can say. It's an excellent forum and really fortunate to be associated with this. And what to say, there is no words, sir. Excellent program. Always excellent, always.
Thank you. JB.
Sir, what would I say? The scientific program has been always been meticulously planned. And Ashok sir does meeting at 10 o'clock and Jayant sir comes at 11 o'clock. So throughout the night, they plan all the program. And most important thing I like is the panel discussion. In the all the conferences, the people come and give their talk. When the people come for the asking question, there is no time left. So you give lots of time, 15 to 20 minutes for the panel discussion. So much things are discussed. So many things are for take-home messages.
40
These are
minutes.
actually good
Every
things.
panel is 40 minutes.
Not only for delegates. These are very good thing for the speakers also. They learn a lot of things.
Yeah.
So there are good takeaway messages from these conferences. I would say from comparison to other conferences.
Thank you, JB. Kishore, 2 lines. Kishore, are you there?
Sir, thank you so much. Actually, when you call me, actually it is only 2 days, so I have to go for 2 days AM's OPD. Then Kanurvai told that you have to speak. Then I have had a lot of reading, so that's why I updated my knowledge. And thank you to be associated,
Your
sir.
talk, I think your talk was very good because sarcopenia is one of the focus for I work with the group, that group, no, Mayo group with Sri Kumar, Sri Kumar Reddy. No, what is his name? Nair, K.S. Nair. Sri Kumaran Nair. And today, most important topic is the sarcopenia. You spoke very well.
Yes, sarcopenia, fragility data and definition that you have given is very important to define the condition.
And it's always good to have Professor Rakesh Sai. I asked Alok sir would be here. Yes, sir, he has agreed to come and join us. Because sir would not come for panel discussion. Alok sir said, no, I have talked with Rakesh, he would come. So it's great to have Professor
Rakesh is now single point of contact for endocrinology and diabetology. He is the president of ESI and president of RSSDI.
Yes.
Let us,
when Rakesh is there, everything is there.
Let us request our youngest budding endocrinologist, Ipshita, to tell few lines because she has to carry the baton.
I thank you very, very much for giving me this opportunity to be part of all of these eminent people. All of them are my teachers, sir. So initially, when I saw in my name in that panel list, I was like, all are my teachers. What will I do? So that feeling of still a student is there inside me. So thank you so much. And I thank all the faculties, all my teachers present out here. So Sanjay sir, Rakesh sir, Kanwar sir, Jayant sir, Ashok sir, ma'am, all are my teachers.
Thank you, Ipshita. Let me give the vote of thanks. As a customary, I first thank the members of the scientific committee headed by Professor Ashok Das. He's a elder brother to me, but he's a mentor, philosopher, and guide to me and to all of us. And his interest in this program has been so good for last 10 years. From the day one I planned NUCD, I first talked to him that how do we do it? Now Alok will do it. A good program will be there. And it has been a good program every year. I thank Jayant for his unconditional support in spite of his very, very busy schedule. So when he becomes free for half an hour at 11 p.m. and then continues up to 2 a.m. JB Konwar is very instrumental in helping me and the team. Sambit was there, Sambit Das, Dr. Vijay Misra, Jayasri Swai, Bharat Panigrahi sir, Abhay and everybody helped us, and that is why such a team could come up. Jayant has already thanked all the speakers. I am really grateful to all the speakers because of their love for us and love for science. They all agreed with the moment I told, except some very difficult situations where some people could not join last moment. All the panelists have been great. So this has become really, particularly this year, this has become a great show this year. And audience, there has been 400 plus on day one, and today we'll know how much will be joining. And there is a happy news, good news. I just got the thing. India from 22 states, people joined. Hello, Manisha. Please come and join. Then United States 11 joined.
Oh,
Germany
fantastic.
2, Croatia 1, Malaysia 1, and Nepal 2. So this is the reach of NUCD now, and we'll get
Great.
a detailed report next time. So I want to give thanks to the audience, those who have really participated and learned from this. And this program was successful only because of Hardik and Neelam from
Yeah,
RX event.
they did
They
very well.
supported us unconditionally and they gave us their asset Stuti. We asked for Stuti that Stuti should conduct this meeting, and she has been there from the beginning till now. And Sagar and Ankit are also a great help from RX events. Website hosting was and designing was by Sanjay Swai, a local boy, but very good. And he has never done anything in which the website got crashed or anything. Very good job, Sanjay. And then support staff at Dr. Kanungo's Diabetes Center. After the COVID, I have created a city center, and there are 20 boys and girls. They helped a lot. Nargis, Monica, and all others. Prabir Mahanti from Kids Hospital and their staff all have helped us. And before going to sponsors, I want to thank two persons very close to my heart, Mamta and Saurav. Saurav has designed everything. 3 years back, when we thought of not having, because of COVID, we came back to this format. He designed he had his education in UK and all those. He's an economist, but he designed this format, all these things that we are telling, speech, debate, interview, and a long time, 40 minutes for the panel discussion, and all whole program is 10 themes, 10 90-minute slots and speakers. So my all the best to Saurav and Mamta, and sponsors. They have, all of them have unconditional. You must have seen, I don't have 20, 30 sponsors. I'm working with 4, 5, 6 sponsors, those whose heart is good and those who are unconditional support. They never bargain or ask me anything. They, whatever they give, I don't grumble. USB with the Farida ma'am at the top, and Yogendra Singh, Smita, Rupesh, Chandan, and the whole team have been working hard to help us. Kedar Chuli, Dipankar, and the team from Sanofi, Bikram Sotria, the head of Novo, Munish Malhotra, Amar Aithal, and Amit, Siba, and Vishal, all are good helps. I want their personal friends like. Aries, Bikram from Aries, Krishnendu and Rao and their teams from Glenmark, Mrs. Joshi, head of Abbott and her team, and Ajay Dhiman and Rishikesh, a Odia boy, head of Medley, they were also very helpful to us. So, small gathering, small people, better quality of delivery, and the conclusion will be the lady of the conference, Manisha Sahai. Manisha, 2 lines, please.
So it's my proud privilege, and I thank all the esteemed members for making me a part of this conference. And as one of the speakers mentioned that the attendees benefited, I would like to slightly correct that and say that even the speakers benefited a lot. So this is one of the platforms where different specialities interact, and this helps all to evolve a holistic approach towards the patient, because as nephrologists we'll be busy treating the kidney disease and forget about the other aspects. So I feel the platforms such as these are very, very important, because finally the patient is important and all of us should work together as a team to improve patient outcomes. So I personally also learnt a lot. I was there in some of the other sessions as well, and it was really, really nice knowing about the recent advances in many other fields of endocrinology, diabetology, which are relevant to the kidney care as well. So it's an honor to be here, and I mean, no words for this. And I would, personally thank Dr. A.K. Das, who has been a mentor, philosopher, guide, and a father figure. I mean, he keeps on telling daughter-in-law. So I had fought with him and told me, not daughter-in-law, daughter. So that's what he remembers. And I mean, it was, it has been my really, it has been an honor to be here. So thank you for the opportunity. And thanks everyone for a wonderful platform. Thank you. And hope this continues year after year after year. Thank you.
Ashok Bhai, you to conclude, and please request the speakers to contribute their chapters, and we are going to publish NUCD 24 handbook.
We are in the process of compiling and publishing the handbook of all that is presented. So my sincere request to kindly submit whatever you have presented, and we will edit it and publish it in your name only. It will be a lasting glory to the wonderful presentations that you have made. And the second thing I must say that there's no conclusion. It is only a continuation, new beginning. So again, tomorrow, on the Sankranti, on the 15th of January, we'll start life anew, where we have renewed knowledge, renewed endeavor, and we know that how much we do not know, that to acquire it, and the new knowledge to, as I told before, to implement it, as yesterday Manisha showed, to implement the new knowledge that we have in the patient care. So, dear friends, I must tell you that a conference is a great thing. And when we implement the things we have learned, is still greater. And we apply it for the people for whom we are there, for our dear persons with diseases, it becomes marvelous. And we will be aiming for that. Thank you.
Thank you. Thank you, everybody.
Thank you. Thank you. Thank you. Bye-bye. Bye-bye. Leaving now?
Yes.